Dear colleagues, today I am Professor Zhengong Dai. On behalf of the Faculty Committee of APPS 2020, it gives me the great pleasure to invite you to attend the 6th Annual Scientific Congress of Asian Pediatric Ophthalmology Society to be held in Kaohsiung Medical University, Kaohsiung, Taiwan. The meeting includes plenary lectures, satellite symposium, panel presentation, and exhibition. Experts from different domains will be invited to share their expertise and experience in the field of pediatric ophthalmology that features a world-class scientific program. I would encourage you to attend the APPS 2020 and look forward to seeing you soon. Thank you.
Hello everyone, have a good day. My name is Ko Hwan Lu. I'm the president of Zhongshan Medical University, Taichung, Taiwan. Also the president of Taiwan Pediatric Ophthalmology and Critical Care Medicine. Welcome to join the international meeting of APPS. Kaohsiung is a very beautiful city in South Taiwan. Welcome to Kaohsiung and welcome to Formosa, Taiwan.
Children are our hearts, our lungs. In Taiwan, we take very good medical care for children, and we are very happy to share and learn experience from friends all over the world. Come on, get ready to be here in Kaohsiung, Taiwan. Trust me, you will have a fantastic journey here. Welcome!
Hello, this is from
Ladies and
APPS 在高雄，Welcome to 台湾高雄。
Good morning. This is the APPS TPPCC 2021 Joint Congress. There will be 15 minutes, then our exciting program is going to start. Please come and join us.
Dear colleagues, today I am Professor Zhengong Dai. On behalf of the Faculty Committee of APPS 2020, it gives me the great pleasure to invite you to attend the 6th Annual Scientific Congress of Asian Pediatric Pathology Society to be held in Kaohsiung Medical University, Kaohsiung, Taiwan. The meeting includes plenary lectures, satellite symposium, parallel presentation, and exhibition. Experts from different domains will be invited to share their expertise and experience in the field of pediatric pathology. The features a world-class scientific program. I would encourage you to attend the APPS 2020 and look forward to seeing you soon. Thank you.
Hello everyone, have a good day. My name is Ko Lu. I'm the president of Zhongshan Medical University, Taichung, Taiwan. Also the president of Taiwan Pediatric Pulmonology and Critical Care Medicine. Welcome to join the international meeting of APPS. Kaohsiung is a very beautiful city in South Taiwan. Welcome to Kaohsiung and welcome to Formosa, Taiwan.
Children are our hearts, our lungs. In Taiwan, we take very good medical care for children, and we are very happy to share and learn experience from friends all over the world. Come on, get ready to be here in Kaohsiung, Taiwan. Trust me, you will have a fantastic journey here. Welcome!
Hello, this is Frank.
Ladies and
APPS 在高雄，Welcome to 台湾高雄。
Good morning, everyone. Today is the second day of APPS TPPCC Joint Congress 2021. Welcome to attend and join us. This online conference is the 6th Annual Scientific Congress of Asian Pediatric Pulmonologist Society and the 23rd Annual Conference of Taiwan Society of Pediatric Pulmonology and Critical Care Medicine, and also the 12th Annual Scientific Congress in Pediatric Pulmonology for 3 places across the strait. You can get all our information on the official website, www.2021-apps.com. Our meeting will go on the Cisco WebEx virtual meeting and also is played live on YouTube and will be sharing online for 3 months till December 2021. You also can go on our website, explore and wander through the online symposiums and see more than 100 e-posters anytime as you like. I am the master of the second day morning of APPS 2021 and hope you all follow us throughout this great and exciting medical journey. Enjoy the day. Good morning, and I hope everybody enjoyed yesterday's great congress. Today we're going to start another day, and we're going to start with the Young Investigator Awards. This is actually a very important part in our Congress, and we always want our young investigators to be recognized and acknowledged for their great work, and it also shapes our future of the pediatric pulmonology across the world, actually, across Asia. And so this time, among the 130 more abstracts, we have chosen 11 uh, abstracts to get the presentation. So this will be divided into 2 parts. In the morning, the first part will be about original research, and in the afternoon, the other part will be about clinical case reports. So in each part, we will have, for everyone to present their work, we will have 7 minutes video pre-recorded part. And another is very important. After the presentation is done, there will be 2.5 minutes for the QA section, which is live. So please, all the participants in the Congress, you are welcome to provide your questions or problems inside our chat room. And we can give the moderator for the chance to ask them the questions. And also the international reviewers, please remember to give your scoring, because we're going to choose among the 11 participants their order and for the great presentation they have done in the end of this meeting in the award ceremony. So let's let's enjoy the show. And today, this morning, we're going to start with the moderator, Professor Yu Zhilin, please. Please open your voice, Professor Yu Zhilin. Your voice, please.
Can you hear me?
Yes, very clearly.
Oh,
Thank you.
Thank you. Good morning, everybody. I'm Yisulin from National Cheng Kung University Hospital, and I will moderate the first 2 talks this morning. And the title of the first talk this morning is air pollution and neurologic factors have distinct effects on asthma exacerbation for young children and elders, presented by Dr. An Chai from Kaohsiung Changgen Memorial Hospital. So please play the video for this talk.
This is Dr. Tian speaking from Kaohsiung Changgen Memorial Hospital in Taiwan. It's an honor to have this opportunity to present our research results about how air pollution and meteorological factors affect asthma exacerbation for young children and the elders. Asthma is one of the common airway diseases from young to old. Environmental factors contribute to the development and exacerbation of asthma. Allergen exposure resulting in asthma attacks is undoubtedly. Besides that, air pollution promoting the occurrence and progression of asthma through several mechanisms has been reported. Some meteorological factors, including temperatures, atmospheric pressure, and humidity, are also related to asthmatic acute attacks. In the real world, dynamic changes of air pollutants and meteorological factors always coexist simultaneously. If only single pollutant or meteorological factor is focused on, its health effect may be overlooked. Therefore, we designed a comprehensive study to determine the influence of air pollution and meteorological factors on asthma acute exacerbation. We focus on young children and the elders because these groups are especially susceptible to environmental changes. The records of emergency room visits due to asthma acute exacerbation were collected from the Taiwan National Health Insurance Research Database from 2005 and traced to 2013. Relevant air pollutants such as sulfur dioxide, nitrogen dioxide, ozone, carbon monoxide, particulate matter 2.5 micrometers, and particulate matter 10 micrometers. The meteorological factors like temperature, rainfall, and humidity were collected from the Environmental Protection Agency monitoring stations. A bi-directional case crossover analysis was used to investigate the effects of air pollution and meteorological factors on asthma acute exacerbation. Each emergency room visit for asthma acute exacerbation was defined as the case day. The same weekdays 1, 2, or 3 weeks before and after emergency room visit for asthma were defined as the control days. For the same person, we compared outdoor pollution or meteorological factor exposure on the case day with air pollution exposure on the control days. The primary outcome measured was emergency room visits for asthma acute exacerbation. Individuals who were included had a diagnosis of asthma as a principal or secondary condition according to ICD-9 code. The study population was further divided into subgroups according to gender or age. Air pollution generally had a 48-leg effect. Therefore, we used the 48-hour moving averages of air pollutant concentrations and meteorological factors for the regression model. For other meteorological factors like humidity and rainfall, the 24-hour average was used for analysis. According to our data analysis, we found that air pollution and meteorological factors mutually influence each other. For example, the degree of correlation of PM 10 micrometers and PM 2.5 micrometers is high. Outdoor air nitrogen dioxide and carbon monoxide were also highly correlated. Our results show the decrease in outdoor air pollution with rainfall and more severe air pollution during the cold season. The gray column is monthly number of visits to the emergency room for asthma. The red curve is mean value of PM 2.5 micrometers, and the blue curve is mean value of temperature across all locations. We found that there were more emergency room visits due to asthma in the winter and spring, and the value of PM 2.5 micrometers was higher during these seasons. Therefore, the contribution of each air pollutant and meteorological factor for asthma emergency room visit is needed to be further clarified. This is the relationship of air pollution or meteorological factors with emergency room visits for asthma in a case crossover study without stratification by age. The analysis showed that the increase in value of PM 2.5 micrometers and the decrease in temperature or sulfur dioxide were associated with more asthma emergency room visits. If the group of young children less than 5-year-old was focused on, the analysis showed that there was no correlation between the air pollutants or meteorological factors and asthma acute exacerbation. For the elders, it seems the increase in value of PM 2.5 micrometers is a risk factor for asthma emergency room visits for male elders aged more than 65 years old. Our conclusion is in Taiwan, dynamic changes of air pollutant and meteorological factors coexist simultaneously, and asthma acute exacerbation is closely related to low temperature and certain air pollution. The influence of air pollution and meteorological factors leading to asthma acute exacerbation is age and air pollutant dependent. The effect of certain air pollutants was not exactly the same among different age groups. Previous studies show a stronger association between outdoor air pollution and emergency room visits for asthma among children less than 5-year-old with or without statistically significant. But in our study, younger children less than 5-year-old were not more susceptible to the effect of outdoor air pollution and meteorological factor for asthma acute exacerbation than older children. The difficulties of asthma diagnosis in younger children, a higher prevalence of respiratory tract infection, and lifestyle difference among countries may cause these different results. For example, infants and toddlers stay at home more often and active outside in Taiwan. This is my presentation, and thanks for your attention.
Okay, thank you for your presentation. Right now we are going on to the Q&A session for this talk. Don't have any from the chat room. Okay, maybe I can ask the first question. For the question of case visiting ER, do they have repeat asthma attack that they would visit ER on the control days? So for the case visiting ER, do they have repeat attack of asthma exacerbation that they would visit ER on the control day? What I mean?
Yeah, this is a good question. Yes, for the person who go to the ER for the help of acute asthma exacerbation, and it is possible for the chance to visit for the second day, a second time on the control days. Yeah, and but because
So how
our
do you define the case and control day in that kind of situation?
Well, we will know the situation from the database from the Taiwan Health Insurance, and there's one special condition is that for Taiwan, and if the children go to the hospital, go to the ER room, the second time they go to a hospital, the ER room for the same condition, and we usually admit this patient and into the in the hospital ward, and this is if this patient hospitalized due to asthma acute exacerbation, and this patient will be included in our research. Yeah, so I think most of the people we enrolled in our study is on only visit the ER once for the control days.
Okay, thank you for your answer, and I think we have, because time limit, we have to move on to the second talk
Thank you.
this morning. Okay. Okay, the second talk this morning will be presented by Dr. Aishin Gu from Franklin Memorial Hospital at the Lincoln, and the title of this talk is Graded Blood Metabolic and Airway Microbial Analysis for IgE-mediated childhood asthma. So please play the video for this talk.
Hello everyone, I'm Pei Xingu from Taiwan, Chang'e Memorial Hospital. It's an honor to present here. In the following 7 minutes, I will talk about the idea of my research, integrated blood metabolic and airway microbial analysis for IgE-mediated childhood asthma. Asthma, a commonly seen disease in childhood, can be classified into non-atopic and atopic by the serum Ig levels. Also, microbiota in airways have been reported to be associated with atopic asthma in our previous study. In the study, by using metabolomics-based approach, we would like to discover the molecular mechanism for different asthma endotypes and their association with airway microbiome. So, for the metabolomics analysis, we collected the blood samples using NMR analysis to get the metabolite spectrum and classified them into groups by Ig levels. We compared each group, including the Canal plot heat map. We also analyzed functional metabolic pathways through KEGG database, and finally correlated our findings to clinical conditions as well. This is the study design for lung microbiome and asthma. We choose a case control study, and we use the high-sec Illumina platform for the children around 3 to 5 years old, and collect their source swab samples by using the 16S RNA amplification to identify the airway microbiome. This is the microbiome analysis flowchart. We use the software CHIME to get the operational taxonomic units and to further identify the diversity and richness of the airway microbiome. At last, to find out the differential abundance of microbiome between the asthma and healthy groups. This is the result of the epidemiologic characteristics of the children enrolled in this study. A total of 53 subjects were enrolled in this study, including 28 children with asthma and 25 healthy controls. As previous study, there was a significantly higher total serum and mite-specific Ig levels in children with Ig asthma in comparison with non-Ig asthma and healthy controls as well. These were the results of metabolites identified using Kinomics NMR suite and metabolites discriminated between each groups. We found 6 metabolites to be significantly different by p-value between non-Ig asthma and control, and 3 between Ig asthma and controls. To make it simple, this is the Venn diagram showing the association between the metabolites identified in each groups. Among the 6 metabolites mentioned, 4 of them were unique for non-Ig asthma, and acetic acid was unique for Ig asthma. Also, there were 4 metabolites discriminated between IgE and non-Ig asthma. Totally, these 7 metabolites appeared to be Ig related and associated with asthma. This heat map showed a further Spearman's correlation analysis to evaluate the correlation between blood metabolite and serum Ig levels. The 7 Ig asthma-related metabolites were strongly correlated with total serum Ig level, either positively or negatively. Also, there was a strong correlation between metabolites associated with Ig asthma and non-Ig asthma. We further put these metabolites into metabolic S-way analysis. Metabolite associated with non-Ig asthma indicates that the glycolysis may play significant roles in this disease mechanism. On the other hand, we found that Ig asthma associated with metabolites were mainly enriched in pyruvate and acetyl-CoA metabolism, suggesting pyruvate metabolism to energy through acetyl-CoA may play a crucial role in IgE production in response to allergens. Also, several papers had noticed microbiome to process these metabolites through its catabolism. To find out the association between blood metabolome and airway microbiome, we analyzed the data and showed the result through this heat map. And we found that the metabolites associated with IgE asthma were strongly correlated with airway microbiota. Acetic acid is a microbial-derived metabolite. It's also one of the short-chain fatty acids produced by bacteria. Fusobacterium is a genus of anaerobic gram-negative bacteria of the respiratory flora with increased invasive properties in an inflammatory setting. There is also high abundance of Fusobacteria species in asthmatic children. A significant positive correlation between acetic acid and Fusobacteria species in this study indicates the existence of the host microbial interactions in asthma phenotypes. So, in conclusion, metabolomics reveals microbes-related metabolic pathways associated with IgE in childhood atopic asthma. For example, we see the relationship between Fusobacteria species and acetic acid, suggesting host microbial interactions in asthma endotype. This study provides a molecular mechanism for the impact of airway microbiome on asthma endotypes by using the metabolomics-based approach. So this is the end of my presentation. Hope you enjoy it, and thank you for your attention.
Okay, thank you for your presentation. And now we are Q&A session for this talk. See if there is any question from the chat room. Pick anyone. Okay, maybe I can ask some question as a moderator. One question. We know that gut airway microbiomes are linked to some phenotype of asthma, so-called gut lung major blood metabolic product related the metabolic pathway with the airway microbiome. So my question is, because we all know that the human gut is the most densely colonized organ in our body. So my question is, where are the blood metabolic products coming from? GI microbiome or airway microbiome? Because asthma is linked to both gut microbiome and airway microbiome. Measure the product from blood, not the airway. So that's my question. My question is, these products come from airway microbiome or gut?
Okay, thank you for your question. And yes, this is a very good question that both the gut and the airway microbiome have some relationship. They may influence the metabolic levels in our blood. And there are some studies have noted that both the gut microbiome and the airway microbiome has to related. So in our study, we choose the respiratory the bacteria in the respiratory tract because I think this is very straightforward. This is a very straightforward result if we found that since asthma is a respiratory disease, and we also found some doubt that this metabolites to be related to the airway respiratory bacteria. And so in the future, maybe we can also do some research in the gut bacteria.
Okay. Because time is also limited, so we have to close this session of this talk, and I'll hand over to next moderator for the other talks.
Okay, thank you, Professor Lin. So we just have 2 pass, and next our moderator is Professor Zhongming Chen. Please start.
Thank you. I'm pleased to introduce the next topic. The title is Soluble Viridial Cyclase Activation Prevented Postnatal Closure of Ductus arteriosus in neonatal rate, presented by Dr. Yi Qing Liu from Department of Pediatrics at Kaohsiung Medical University Hospital, Kaohsiung, Taiwan. Please welcome Dr. Liu. Please start.
Good morning, ladies and gentlemen. It's my honor to share our study, cerebral guanine cyclase activation prevents postnatal closure of ductus arteriosus in neonatal rate in this Congress. The ductus arteriosus is a vessel connecting aorta and main primary artery and plays an important role in fetal circulation. Delayed closure of DA attributed to pulmonary edema and respiratory failure in prematurity. However, PDA is life-saving in patients with dato-dependent congenital heart disease. The closure of DA involves vasoconstriction and vascular remodeling. The DA remodeling is caused by extracellular matrix deposition, proliferation, and migration of smooth muscle cells. Current medication for regulating DA parency is mediated by prostaglandin E cyclin AMP pathway. We use CAS inhibitors such as indomethacin or ibuprofen for PDA closure in neonates with heart failure. In patients with dato-dependent CHD, we use PGU1 for keeping DA parency. However, this agent has significant adverse effects. The CAS inhibitor can induce renal failure or GI bleeding. The PGU1 may cause apnea or fever. So, do we have other alternative agents with less side effects for regulating DA parency? Sinacigua is a SGC activator, which can activate cyclic GMP protein kinase pathway to cause vasodilatation and anti-remodeling on pulmonary hypertensive vessels. As a result, we hypothesize that Sinacigua can keep DA parency by vasodilatation and anti-remodeling effect. We also want to explore the underlying mechanism by use of angiotensin II. Our experiments include three components. In vivo, we check the DA morphology and histology. Ex vivo, we evaluate the vasodilatory effect by measure DA vascular tension. In vitro, we use DA smooth muscle cells to explore mechanism of proliferation and migration. In vivo study, we inject Sinacigua in neonatal rate at birth. After 2 hours, we check the DA morphology and histology. In control group, the DA is patent at 0 hour. After 2 hours, DA closed. In Sinacigua group at 2 hours, the DA is still patent. The DA to PA ratio is significantly higher in Sinacigua group at 2 hours. In histology, the lumen of DA is obstructed with intimal thickening in control group at 2 hours. In Sinacigua group, the lumen of DA is still patent with less intimal thickening at 2 hours. We demonstrate that Sinacigua can prevent DA closure and had an anti-remodeling effect in vivo study. In ex vivo study, we evaluate the vasodilatory effect of Sinacigua. We sacrifice the neonatal rate and take out DA. Then we add oxygen, which causes vasoconstriction. Then we use Sinacigua in different concentration. In the concentration of 10 and 100 nanomolarity, the tension declined obviously. To identify our hypothesis of vasodilatation through the pathway of cyclic GMP and protein kinase G, we perform immunofluorescence assay of cyclic GMP and add protein kinase G inhibitor. In the immunoassay study, the expression of cyclic GMP decreased obviously in control group at 2 hours, and the expression of cyclic GMP was preserved by Sinacigua at 2 hours. To identify the vasodilatory mechanism, we pretreat DA ring with protein kinase G inhibitor KT5823. The relaxation effect of Sinacigua was attenuated by PKG inhibitor prominently in a concentration of 10 and 100 nanomolarity. In vitro study, we use angiotensin II to identify the synergistic effect on smooth muscle cell proliferation and migration and the underlying mechanism. Angiotensin II can induce smooth muscle proliferation, and the proliferation was attenuated by synergistic dose-dependently. Angiotensin II also induced smooth muscle cell migration, and the migration was inhibited by synergistic dose-dependently. Angiotensin II also activated RS production, and the RS production was attenuated by synergistic dose-dependently. Angiotensin II can cause MAPK signal pathway activation to induce phosphorylation of ERK and JNK, and the activation was attenuated by synergistic dose-dependently. A similar result was also noted in the pathway of protein kinase B. So in vitro study, we demonstrated the anti-remodeling effect of synergistic by inhibition of smooth muscle cell proliferation and migration, RS production, MAPK, and the protein kinase B signaling. In our study, we demonstrate that synergistic can keep DA patency by vasodilatation through the pathway of cyclic GMP protein kinase G, and had anti-remodeling effect by inhibition of MAPK, RS, and the protein kinase G pathways. This study implicated that SGC activation or inhibition can be a promising therapeutic target in regulating DA patency, and can be applicated in neonates with hemodynamic significant PDA in the future. Thanks for your attention.
Okay. Thank you for Dr. Liu's presentation. We have one question from an international reviewer. Could you tell us what are the side effects of silasequel in humans?
Thanks, your problem. The major side effect is hypertension. The reported incidence is about 10%.
Okay, thank you. I have one question. How did you decide the dosage in animal study? You used the 10 milligram per kilo. How did you, for human study, or in human first, how did you decide this dose in animal study, 10 milligram per kilo?
Actually, this dose is by previous judged by previous study result.
By previous in vitro or in
Uh,
vivo study?
in vivo animal study.
Okay. Dr. Liu, do you have any future plan to compare the clinical efficacy of silasequel and PGE1?
Actually, the major side effect of PG1 is apnea and fever. Because apnea may induce, maybe we have to intubation with the neonate. So we hope to use this agent and cause less side effect of respiration.
Okay. And the last question from Dr. Lin. Do you perform the experiment on other vascular tissue?
In our research group, you mean? Actually, we perform this study just in the issue of ductus arteriosus.
Okay, thank you. Because time is up, we give the time to the master. Thank you.
Thank you, Professor Chen. So the next moderator will be Donghao Xu. Let's welcome Professor Xu.
Thank you, Professor Li. It's my pleasure to moderate the next two topics. The first topic is presented by Yoon Hong Min from Department of Pediatrics, Prince of Wales Hospital, the Chinese University of Hong Kong. Topic is childhood OSA prediction by the anatomic variables in upper airway MRI. Please start.
Hello, I'm Yun Hoi Man, a postgraduate student from the Department of Pediatrics from the Chinese University of Hong Kong. This presentation is about childhood obstructive sleep apnea prediction by the anatomical variables in upper airway MRI. In children, OSA is attributed to prolonged partial and/or intermittent complete upper airway obstruction. Anatomical causes such as adenotonsillar hypertrophy, obesity, and craniofacial anomalies can cause narrowing or a more collapsible upper airway, which contributes to the development of OSA. Pharyngeal length, cross-sectional area of the narrowest airway, and lateral pharyngeal wall thickness can affect the airway collapsibility. The pharyngeal length was reported to be a more important OSA determining factor than the airway cross-sectional area. In previous study, we found that lateral pharyngeal wall thickness correlates with OSA severity. Therefore, this study aimed to evaluate the OSA predictive ability of these upper airway anatomical variables. We recruited prepubertal children suspected of OSA to perform MRI and overnight polysomnography. OSA was defined by OAHI equal or larger than 1. MRI was performed during wakefulness, and subjects were aligned in the Frankfurt plane. The pharyngeal length was measured from the hard palate to the tip of epiglottis. To adjust for the effect of age, the age-adjusted pharyngeal length was calculated by the standardized residual. Other anatomical variables were measured on the transverse plane. The smallest airway at the retropalatal level was identified. Then the cross-sectional area of the airway was measured, and the width and length of that was calculated for the width-length ratio. Also, we measured the LPW thickness of both sides and summed as the total LPW thickness in both transverse and oblique dimensions respectively. The transverse LPW thickness was defined as the distance between the middle border of pharyngeal fat pads and the lateral edge of the airway. The oblique LPW thickness was defined as the distance between the internal carotid artery and the edge of the airway. For statistical analysis, Pearson correlation was performed on the anatomical variables and the log-transformed OAHI. Group comparison was performed using t-test, and effect size was calculated using Hedges G. Classification models were built by logistic regression and CART-3 model. 70% of the subjects were used as training data to select predictive variables for OSA. The model accuracy was then evaluated by a confusion matrix using the remaining 30% of the subjects. This study included 27 subjects with a mean age of 8.7 years old. 20 of them were males. By PSG, 15 of them were classified into OSA group and 12 of them were non-OSA group. The correlation analysis showed that pharyngeal length and LPW thickness were significantly correlated with OSA severity in terms of log-transformed OAHI. The oblique dimension of LPW thickness and airway cross-sectional area almost reached statistical significance, while the airway width-length ratio did not correlate with OSA severity. Group comparison was performed. The OSA and non-OSA groups had no significant differences in anthropometric data. The OSA group has significantly larger LPW thickness in both transverse and oblique dimensions. The effect size was 0.8 and 0.88 respectively. OSA group had larger pharyngeal length, and the difference was more prominent after adjusting for age. The mean SAT score for OSA group was 0.21 compared to negative 0.68 in non-OSA group. The effect size was 1.1, the largest among the anatomical variables. The airway cross-sectional area and wave-length ratio were not significantly different between OSA groups, but the effect size was medium to large. Using the oblique LPW thickness, adjusted pharyngeal length, airway cross-sectional area, and wave-length ratio as independent variables, the logistic regression model gave an accuracy of 88.9% to predict OSA. The CAT model selected the age-adjusted pharyngeal length and the wave-length ratio of the airway as classification criteria, giving an accuracy of 77.8%. With the selection criteria, a small adjusted pharyngeal length, meaning a shorter pharynx, was predictive of no OSA. For a larger adjusted pharyngeal length, if the airway wave-length ratio is larger than 2.2, it was predictive of OSA. This study has a limitation of small sample size, making the machine learning process less representative. But due to the high cost of MRI and PSG, we were only able to have the current data set subjects at this moment. To conclude, the anatomical variables of the upper airway, including the LPW thickness, adjusted pharyngeal length, airway cross-sectional area, and wave-length ratio were predictive of OSA severity in different models. That's all for my presentation. Thank you.
Okay, thank you, Dr. Mann. We have many questions for you from the floor. The first is that airway obstruction is a dynamic condition, and MRI is the exam that upper airway is in a fixed time point. Do the kids also have dynamic examination like bronchoscope?
For this study, we don't have other dynamic examination like bronchoscopy.
Okay. The second and the sixth question is similar that how do you find this variable in the MRI can help clinically in managing children in suspected OSA?
I think this study is give us some insight in how the craniofacial structure and the anatomical structure that can affect the OSA. And so current treatment are usually as tonsil, the surgery to remove the soft tissues. So for some children, their craniofacial structure may be different. So the treatment may when we consider the treatment, maybe we can also think about how these other structure may affect the surgical outcome.
Okay. The next question is that human breathing movement may change the airway during the different breathing stage. How to control this confounder factor in this study?
When we do the MRI scans, we ask the children to ask them to breathe through their nose normally and ask them to refrain from swallowing. So the radiographer will take the photos when it's during the expiration. But of course, there may be some difference we try to control it, but sometimes the children may move a little bit, and that may vary a little bit.
Okay, thank you very much because the time is limited. So we'll move on to the next topic also by you. So the topic is the validation of sonographic measurements of lateral parapharyngeal wall thickness in children. Please start.
Hello again, I'm Yun Hoi Man from the Department of Pediatrics, the Chinese University of Hong Kong. This presentation is about validation of the sonographic measurement of lateral parapharyngeal wall thickness in children. This study was a collaboration with the Department of Imaging and Interventional Radiology in the Prince of Wales Hospital, the Chinese University of Hong Kong. Lateral parapharyngeal wall thickness indicates the distance between the wall of pharynx and the internal carotid artery. LPW thickness is a potentially useful anatomical marker of childhood OSA. Measuring LPW thickness can be by MRI and ultrasonography. Ultrasound is more readily available, technically less demanding, and more cost-effective. However, its validity of LPW thickness measurement has not been verified in children. Therefore, this study aimed to assess the intra- and interoperator reliability of the sonographic measurement of LPW thickness in children, and to validate the measurement against MRI measurement. We hypothesized that the sonographic measurement of LPW thickness is valid and reliable. Prepubertal children with suspected OSA were recruited. All of the subjects performed PSG. LPW thickness was measured by both ultrasound and MRI. For ultrasound, the subjects were positioned supine on the examination couch and their neck slightly extended, supported by a soft pad, like this figure. The internal carotid artery was identified with color application. The lateral wall of the pharynx appeared as an echogenic line on the real-time ultrasound, indicated by arrowheads here. Whereas the lumen of the pharynx was completely obscured by gas shadowing, shown by an open arrow. The LPW thickness was measured as the distance between the internal carotid artery and the echogenic surface of the pharynx in an oblique coronal plane, represented by the orange arrow. The LPW thickness on both sides was measured 3 times on 3 separate images, respectively, and the mean value of LPW thickness of the left and right sides were summed as the total LPW thickness for analysis. The measurement was repeated on the same day by the same operator twice for calculating the intraoperator reliability, and repeated by another operator for calculating the interoperator reliability. For MRI measurement, the LPW thickness was measured from the image that captured the smallest airway cross-sectional area at the retropalatal level. The transverse LPW thickness was defined as the distance between the middle border of parapharyngeal flat pads and the lateral edge of the airway. The oblique LPW thickness was defined as the distance between the internal carotid artery and the lateral edge of the airway. Intra-class correlation coefficient was used to examine the intra- and interoperator reliability. A two-way random model was used. The agreement between the LPW thickness measured by ultrasound and MRI was assessed by ICC with a two-way mixed model. The agreement was also evaluated by Van Alman plot. The mean of the difference with a bias of 1.96 standard deviation denotes the limit of agreement. 32 children with a mean age of 8.8 years old were recruited. 25 of them were males. The intra and inter-operator reliability of the LPW thickness by ultrasound were good, with an ICC of 0.91 for intra-operator reliability and 0.84 for inter-operator reliability. For the LPW thickness by MRI, only the oblique dimension is presented here. The agreement between the ultrasound measure and MRI measure LPW thickness had an ICC of 0.65. This was acceptable, but due to the different imaging planes of LPW on ultrasound and MRI, which is slightly different, so the agreement is only acceptable. Meanwhile, the blend element plot demonstrated a mean difference of 0.075 cm and a 95% limits of agreement from negative 1.1 to 1.25 cm. To conclude, the sonographic measurement of LPW in children demonstrated good intra and inter-rater reliability and an acceptable agreement with MRI measurement. Ultrasonography is a valid method to assess LPW thickness in children. This study was supported by the direct grant for research from the Research Committee of the Chinese University of Hong Kong. That's all for my presentation. Thank you.
Okay, thank you very much. We have some questions from the floor. The first one is that do you do this dynamic or static? Because it's inspiration or expiration when you do the measurement?
Just like the MRI studies presented, and it's all done during expiration.
Okay, so it's done in the expiration phase. Okay, another question is that which one between the echo and the MRI, which one is more related to the clinical symptom sign or clinical severity?
For the ultrasound and MRI, the correlation with the OSA severity, I'm not very sure, but as far as I remember, it should be the MRI outcomes are more correlated with the clinical symptoms.
Okay. And did you do the sample size calculation? What was the ideal number of the children required, the size number?
We did a sample size calculation based on our pilot study on the LPW thickness between OSA and non-OSA children, and the minimum number to validate the difference was 32, which is our current number.
Okay. And another question, some factor might affect the LPW thickness, like after talking too much. So do you use the same situation to do the sonography as the MRI? Is the same situation for these children?
We asked the children to come back to do the MRI, and on the same day, after they do the MRI sessions, we'll ask them to do the sonography.
Okay. So would you recommend MRI for everyone who is suspected with the OSA in your clinical practice or echo?
I think ultrasound is more practical because if we need to do MRI for everyone, it would be very costly and it takes very long time. And especially for young children, they may not be very cooperative to do MRI, and because we are doing it during wakefulness. So we will only do it for the echo.
Okay, the next question is, there are some artifact in the echo examination, especially when you do with some air. Is there a problem for you?
We'll take the measurement 3 times, so this difficulty let's try to minimize.
Okay, thank you very much. Thank you.
Thank you.
Thank you. Thank you for Professor Zhonghao Xu's moderation. So the next section, we will go to Professor Deming Wang, please. Moderation, we will next go into the last presentation, which is moderated by Professor Deming Wang. Please open your voice and your camera. Thank you.
Hello, everybody. I'm Dr. Wang. And the last topic is presented by the Dr. Nitin Joshua, come from India. He will present acute gastric injury in critical ill children, impact on clinical outcome. Dr. Joshua, please. Slide, please.
Good morning. I'll be presenting our study, which is acute gastrointestinal injury in critically ill children and its impact on clinical outcome. The GI tract is injured in critically ill children due to various mechanisms, including hypoperfusion and reperfusion injury, hypoxemia, fasting-related epithelial atrophy, and bacterial infections. Once injured, gut can be the driving factor for multi-organ dysfunction by different mechanisms like increased GI permeability, which releases bacterial toxins and endotoxins into circulation, altered gut microbiota with colonization with pathological organisms, and bacterial translocation to cause systemic infections. Bowel inflammation can release cytokines into the circulation and can cause systemic inflammation. But GI dysfunction is not well described, and GI dysfunction is not part of any of the multi-organ dysfunction scores. In 2012, European Society for Intensive Care Medicine defined acute gastrointestinal injury AGI for critically ill adults in 5 categories, AGI grade 0 to 4 with increasing severity. Presence of AGI is associated with increased mortality, which has been seen for adults in various studies, but there are no pediatric studies of AGI in children, and there are no good definitions for pediatric AGI. Objectives of our study was to estimate burden of AGI in critically ill children aged 1 month to 18 years over first week of pediatric ICU stay. Secondary objectives were association of AGI with clinical outcomes, comparison of AGI with PILOD-2, which is an established multi-organ dysfunction score, and characteristics of children with AGI versus without AGI. For burden of AGI, we choose pediatric adaptation of ESICM AGI definitions. For outcomes, we studied 28-day mortality, mechanical ventilation duration, length of PICU stay, and hospital-acquired infection. For characteristics of children with AGI, we studied age, gender, nutritional status, shock, mechanical ventilation, and disease severity. AGI grade 0 is no GI symptoms. 1 is transient self-limiting symptoms. 2 are symptoms severe enough to require intervention but improve with intervention. 3 are severe symptoms which cause worsening of multi-organ dysfunction or which persist and progress despite intervention. Grade 4 are dramatic life-threatening symptoms like bowel ischemia with necrosis, hemorrhagic shock, or abdominal compartment syndrome. This was a prospective observational cohort study from a tertiary care center in North India. We included children between November 2017 and June 2019. Inclusion criteria was children admitted to pediatric ICU aged 1 month to 18 years, and exclusion criteria were history of chronic gastrointestinal illness or elective admissions. Written informed consent was taken from all the guardians, and the study was approved by ethics committee. GI symptoms were recorded daily by the pediatric ICU team, and they were classified by principal investigator into AGI grades. Daily PILOD-2 score was calculated for 7 days. Children were followed up for outcomes till the discharge. With estimated prevalence of 46% from adult study and a precision of 7.5%, our target sample size was 170. During the study period, we had 367 admission. We screened 170 children, of which 19 were excluded, 6 had elective admission, 4 had malabsorption, and 9 refused consent. So finally, we included 151 children in our study. Baseline characteristics of the included children are the median age was 48 months, 57% were male. There was significant malnutrition in our cohort. The most common system involved was respiratory system in 47%. PIM3 predicted mortality was 7%. 79% had mechanical ventilation and 67% had shock during the first week. We could start enteral nutrition for 75% during the first week of admission, and parenteral nutrition was given for 5%. Prevalence of AGI in our study was 47% with 95% confidence interval from 38.9 to 55.3%. AGI grade 1 was seen in 22%, 2 in 16%, 3 in 7%, and 4 in 2%. We found that 28-day mortality was significantly increased in children with AGI to 48% compared to children without AGI where it was 15%. Also, we found that 28-day mortality increased progressively from grade 0 to grade 4 of AGI from 15% to up to 100%. We adjusted association of AGI with 28-day mortality by age, nutritional status, PIM3 and day 1 pillow 2 score, which are marker for baseline disease severity, and there was significant association between AGI grades and 28-day mortality with odds ratio of 1.89. Though we did not find any significant association of AGI with other clinical outcomes, including PICU length of stay, duration of mechanical ventilation, and hospital-acquired infections. When comparing AGI grades with individual pillow 2 component, we found that AGI grades, cardiovascular and hematological component of pillow 2 showed significant association with 28-day mortality. While comparing characteristics of children with and without AGI, there was the children with AGI were significantly older and they had worse baseline disease severity compared to children without AGI. And 76% of children with AGI had shock compared to 41% without AGI. So strength of our study are that it's a novel concept in pediatric intensive care. It was a prospective study design, so takes care of some of the biases of retrospective studies. Limitations are that it was an observation period was limited to first week of pediatric ICU stay, so we could have missed some children who developed AGI during the second week or third week. Also, this was a single observer had classified AGI, so there could be significant inter-observer variability, which we could not document. Sample size could not be completed, but with a sample size of 151 patients, we had a reasonable precision of 8.2%. So to conclude, AGI is present in nearly half of critically ill children and it is associated with increased 28-day mortality. It can offer a useful ordinal scale to quantify GI dysfunction in critically ill children, and there is need for larger study for confirmation of our findings and identification of risk factors for AGI. Thank you.
Thank you. Introduction, so new concept. Now is a Q&A stage. Is AGI an independent predictor of severity of illness? Did you consider co-founders like hematology prevalence?
So, like I presented in our presentation, so we adjusted for one baseline disease severity, which included PIM3 as well as day 1 pillow 2 score. So day 1 pillow 2 score has 5 components, which also takes care of hematological abnormalities. And also when we compared AGI with 28-day mortality and individual pillow 2 scores, because it's a like established organ dysfunction score, in that also it was adjusted for various other organ dysfunction and it was still associated with significant, it still had significant correlation association with the 28-day mortality.
I have 2 questions. How did you categorize, what's your standard for categorization into grade 1, 2, 3? Because patient's condition at the same day might be grade 1, grade 2, grade out from grade 2 to grade 2, grade 1 fluctuation. So how do you sure to categorize into grade 1, grade 2, or grade 3? This is the first one. And the second one is I saw the almost 80% above the have an enteral feeding. So is there, because the patient during first week, the clinical station is not stable, so it might be just keep a 2 meal, 3 meal enteral NPO. So how do you categorize patient into enteral feeding or TPN support?
So the first one, we assigned these grades daily from day 1 to day 7, and worst grade was taken. So if a patient had on day 1 AGI grade 1 and on day 3 had AGI grade 2, so we took it as grade 2. So classified it as grade 2 because that's the worst AGI grade over the first week. And so this is how we classified into grade 1, 2, 3, and 4. And second question is this enteral nutrition, because some of these were very sick children. So we could start enteral nutrition in around 75% during the first week. And we used parenteral nutrition in around 5%. So there might be some overlap also that some children may have got both of these, but this was like overall pattern, and around 25% we could not start during first week. So some of the children could have died on day 3 or day 4, and some of the children might have started nutrition after first week of admission.
Okay, thank you. Because time limit, this culture. Thank you.
Thank you, Professor Deming Wang, and all the presenters today. This will end the first section of the Young Investigator Award. Just a reminder for all the international reviewers, please give your scoring within 1 hour after this section. Thank you. Next, we're going into the plenary lecture this morning, and we invite our moderator, Professor Junren Wu, and later we will have a Q&A section also. Professor Wu, please.
Yes, thank you. And greeting from Taiwan. It is my honor to for moderator with Regina from Philippines, and Professor Ong is a distinguished professor in the world, and is especially in the respiratory care. So, respiratory care and the NASA CPAP care, and Regina has asked me to read several words because she is in Philippines and cannot attend the meetings. She says that Professor Ong is an international recognized and multi-awarded pediatrician, neonatologist, anesthesiologist, and academician rolled into one. He has a long list of achievement, significant position in the clinics and the academics, international awards, certifications, and the research. Let me just try to bring some of the highlight of his CD. And he is he was trained in the Columbia University, and he has been WHO consultant in China and has participated in several national heart, lung, and blood intensive institute sponsored committees, and has been invited for more than 650 times as a lecturer in more than 20 countries. To date, he has more than six articles and book chapters. He has pioneered in the use of bubble NASA therapy and is very much known for his expertise in the technique of one lung ventilations and the management of PPHN without ventilation, to name a few. Colleagues and friends to talk on ventilation strategies of the newborn with respiratory distress. Let us welcome Professor Ong Ren Tan. Thank you.
Hi, everybody. I will to share with you my experience with ventilatory strategy in neonate. I have no financial relationship to disclose or conflict of interest to resolve. The goal of mechanical ventilation is to oxygenate the patient and to remove carbon dioxide. While doing so, we attempt to minimize damage to the lung. There are different strategies of available positive pressure ventilation for different disease process to protect the lung. And to have a good understanding of technique to optimize mechanical ventilation and minimize complication. Often in medicine, less is more, and be aware that newer isn't always better. Don't believe everything you read. Dr. Korobo from NIH, he had done many lung injury study, and he said the vast majority of lung injury are man-made, and I think that's true. So when we ventilate the baby, we try to keep it simple so we can understand and all keep it safe. And there are a spectrum of respiratory disease ranging from mild distress to severe respiratory failure requiring varying degree of support. The ventilator assistance provided to these infants should be graded according to the severity and the type of the disease. And most of infants' respiratory disease can be treated with a CPAP alone. But if adequate oxygenation or acceptable PaCO2 cannot be achieved, ventilatory support are escalated to IMV, SIMV, and if NAMA or high frequency ventilator are available, they are used for specific indication, and we reserve the more invasive and the labor-intensive ECMO therapy as a last resort. And if premature baby with severe RES, we also give a surfactant. If severe PPHM patient, we may use inhaled nitrous oxide. And invasive mechanical ventilation is not without risk. From that can have a problem from endotracheal intubation or mechanical ventilation. So if for the patient on invasive mechanical ventilation, we'll try to win aggressively when they improve, and try to extubate as early as possible and press on CPAP to minimize the complication. And when we ventilate the patient, we like to ventilate the lung about this area. We don't want to keep a lung in the low lung volume or high lung volume, because both will actually increase the pulmonary vascular resistance. That's why we don't hyperventilate our patient, severe PPHM patient. And this is a study on the human on the supine position. You see when they breathe spontaneously, see the diaphragm, most diaphragm move, ventilation is the dependent part, and that's where the more, because of gravity, most of the perfusion also. So they have better ventilation perfusion much. But if you paralyze the patient or anesthetize the patient, then the diaphragm is not at this line anymore, it's up here. So, so you have to use a positive pressure ventilation. But this because abdominal content has a pressure on the diaphragm, and in the depending part is more pressure because of gravity. So when you ventilate, most of the ventilation in the upper part, but perfusion still more in the depending part. So actually, this compromise ventilation perfusion matching. And whole thing like this, a patient on a supine position, And if he doesn't have a spontaneous breathing, you will have a retention of secretion in the dependent part. And the best mode of ventilation is spontaneous ventilation. As you can see, when the patient IMV not enough, then they will manage to breathe spontaneously. And when the patient SIMV, they can do the same thing. They will breathe spontaneously between the respirator cycle. And and there's a physiological reason characterized by spontaneous variability, such as heart rate, respiration rate, or blood pressure amplitude are all variable. So therapeutic intervention with a life support system diminish and eliminate spontaneous physiology reason. And elimination of this inherited spontaneous reason may be detrimental and contribute to the morbidity and mortality associated with such life support. So mechanical ventilation may be improved if a normal physiological variation is reproduced. And this is a study try to prove that. So they use a computer to control inspirator cycles, onset, duration, rate, and volume, to produce a better oxygenation. And you see when they do that, see how the better blood gas, then compare with the ventilator with volume control or style with volume control. So if biologically variable ventilation will improve non-mechanical gas exchange, inflammatory mediator, and historic evidence of less lung damage, and also will decrease atelectatic and poorly aerated area. Okay, so we don't have that program, so we try to let the patient a chance to breathe spontaneously to maintain that physiology variable. And like this patient, see their lung is collapsed, so clinician often make a mistake, try to open up that collapse by increase the pressure, and you see this all connected. If you use too high pressure, actually you hyperinflate the good lung and damage the patients. Mechanical ventilation, there are two ways to ventilate. One is a pressure limit, the other one is a volume limit. When we use a pressure limit, usually if a small child, because your tidal volume is small, so hard to accurate know what the exact tidal volume, or there's a large air leakage. So this is the time, even in adult, if there's a large air leakage from the endotracheal tube, you use a pressure limit. And if you use the volume limit, use the tidal volume 4 to 7 cc per kilo, but you put a pressure on the gas will compress, so this is compressed volume. If respirator tube inside circuit is only 1 liter, each centimeter water pressure increase, you lose 1 cc in the compression. And for instance, if you use a 20, then just every breath is a 20 cc loss in the compression, and that's bigger than infant's tidal volume. So when you use the volume control, yes, the means ventilation maybe become more stable, but because the compressor volume bigger than patient tidal volume, also there always has more or less have some leakage. And also the tidal volume very small, so just to make a control delivery tidal volume difficult. And when you use a pressure limit, so when the preset PIP is reached, that will maintain the duration of the inspirator cycle, and delivery tidal volume is less affected by the endotracheal tube leakage. And the tidal volume delivery is depend on patient mechanical assist resistance, compliance, or patient effort. And usually the pressure limit ventilator, they had a simple and reliable mechanical design and widely available in nearly all ventilators. And most clinicians are more experienced with this mode of ventilation. And, this have in past 40 years, this respirator used in our unit, but now we use servo I, but they stopped making it. So there's a new one, is a servo N, servo U. Now let's talk about some basic simplified schematic of infant respirator. And there's a 6 parameter you should thinking about. One is the FiO2, you have flow rate, you have control IMV rate, control the inspiration time, and control the PIP and the PIP. So this infant respirator, conventional infant respirator before SIMV or oscillator available, we have 4 ways to ventilate the patient. Well, number 1, I call conventional technique. Usually that's how we started. And if not enough, we go with high frequency positive pressure ventilation. And the third one, before you can use increased inspiratory time for the very severe lung disease patient, but now just we don't use this technique anymore because this will be depressed by high frequency oscillator. And last time you also can count the patient's respiration rate and adjust the respirator the same rate, and you will see synchronized. But now we have a SIMV, so we just use SIMV. We don't use this technique anymore. So for the conventional ventilation, so the 6 parameter, now FiO2, so we try to keep O2 saturation around 90s, and we set the alarm limit 85 to 95. Flow, so we keep, so Y to 8 liter is enough flow so can reach PIP within inspiration time and also prevent the breathing of exhale CO2. IMV rate, so you use IMV rate, so control the CO2, also avoid excessive labor spontaneous breathing. And usually we start with about 20, and if not, you go from there. And the inspiration time, this is most controversial. I think, when you use the inspiration time, 0.1 time constant, patient only receive 63%. If you include 2 time constant, then the patient gets 86%. If you use 3 time constant, only increase from 86 to 95. So usually we try to keep it around 2 time constant, and usually just about 0.5 seconds for the infant. And time constant is a compliance time resistance. So, in this part of the lung, so it's the worst part of compliance, lower, so time constant is shorter, and this better lung compliance is better, so you have the bigger, longer time constant. So if you use the short inspiration time, you may ventilate more in this area, but if you want to ventilate more homogeneous, then you should use a longer I time. And PIP, so you just use PIP to see inadequate chest excursion. If you inflate the alveoli, then alveoli expand, the lung expand, you should see chest excursion. And usually, for the term baby, we start with 20 centimeter water pressure. For the premature baby, we start with 15 because they have a chest wall thinner, and we go from there. And usually they have a low FRC, so we use a PIP. And usually we start with a 5, and your patient, when they have the low FRC with a severe deep inspiratory retraction, when they breathe spontaneously, then we'll increase the PIP. If a lung already hyperinflated, we'll decrease the PIP. And usually this eye servo eye respirator is what we use, and you see servo eye can have so many more to ventilate patient, but we stay with a pressure limit. Use a pressure control or the AC, and use SIM with some pressure support, and just will be the setting of our setting like this. So initial setting will be flow rate 5 to 8 liters, but now some of the respirator, they have a default, that's flow rate. And we keep FiO2 to keep a PaO2 around 80, 90s, O2 saturation 90%. IMV, so we usually start with a 20, but to avoid if they excessive level breathing or CO2 is high, then we increase, but we increase only up to 40. If not enough, we use other type of ventilation. And inspiration time, usually we use a 0.5 second. Peak inspiratory pressure, usually we start with about 20. And if not enough, we go from 0 to 15 centimeter water pressure for premature baby, and PEEP is start with 5. If patient improves, so we will aggressive win the patient, decrease IMV rate, even CO2 can be, don't have to be so low, and decrease the PIP, you have excessive chest excursion, patient improve, and FiO2, if not near so high, we decrease the FiO2, and usually no change for flow rate, inspiration time, and the PEEP. How about if a patient deteriorates, you should find out what's the reason, maybe because endotracheal tube obstruction, and most of the time that's the reason, or they develop pneumothorax, or the patient under ventilate or over ventilate. Some patients transfer to us for possible ECMO, often the problem because they are over ventilated. And if CO2 is high, or patient breathes too hard, or increase the rate, IMV rate, but only up to 40. And I say before, if just not enough, we try other way to ventilate. For the hypoxia, so we make sure the PIP is enough, or maybe increase the PEEP if there's severe inspiratory destruction. And if PIP and PEEP not a problem, then we increase the FiO2. So like, for instance, like this patient, they deteriorate, is because the tube is too far. So you have to pay attention where the endotracheal tube, and this patient, see the endotracheal tube, the tube had a bevel. So this is because head position is the bevel against the tracheal wall. So you are partial occlusion. That's why the patient deteriorates. For instance, this patient, she is transcutaneous PO2, the transcutaneous PO2 gradually decrease because his head is on the left. So we know this patient deteriorated not because secretion, because he was sucking properly. And when the turn, so we think maybe the head position, turn the head to the right, see the PO2 improve, turn to the left, they decrease, to keep the patient head on the right side. So this premature baby happen more often than you think. And this patient deteriorate because he needs suction, but unfortunately, often the patient, instead of suction this baby, they will give a baby the sedation. So like this patient transferred to us for possible ECMO. And so after we suction, we cannot couldn't do the respirator setting fast enough. So this patient, just because we suction properly, so can avoid the ECMO. So how about convention doesn't work? Then we try high frequency positive pressure ventilation, such as you have problem oxygenation, or require too high pressure, or CO2 too high. Then we try this way. So this way the gas exchange mechanism is different from the conventional spirit, and we'll try. And the second will be increase the rate up to 100, and inspiration time 0.3 seconds, expiration time 0.3 seconds. And usually keep a PIP same as on conventional setting, and we decrease the PIP because expiration time is very short. Otherwise, you will have intrinsic high PIP. And we find this type of ventilation is good for patient with a PIE or the patient, some of the more severe congenital diaphragmatic hernia or the patient hypoplastic lung, or if the patient has a high PaCO2 on the conventional, you can try this way. And when the mechanical ventilation, when they improve aggressive weaning, so for the conventional, you will decrease FiO2, if PO2 is high enough, or decrease the rate, your patient can breathe more, and we give too much chest excursion, we decrease the PIP. And if a patient better on high frequency positive pressure ventilation, you don't decrease the rate right away. We only win FiO2 or PIP. And we aggressive winning the patient when they improve, and we try to extubate patient as early as possible. So when the patient's condition, whatever the reason he was intubated, now condition is improved and is stable, the IMV rate already less than 20, the patient also active and had spontaneous breathing. But sometimes the patient, your patient is active, but they have a flip-flop PaCO2 due to endotracheal tube obstruction from retention or secretion, or because the tube bevel against the trachea wall. If patients are active, we know they can breathe. In this case, we still extubate the patient and put on a CPAP. So just look at this kangaroo baby, so small, they can breathe. So I think the clinician do not give the infant, especially the preemie, enough credit to be able to breathe themselves. So they keep the patient on respirator too long. Remember, they're small, but their tidal bone is very small too. If they're active, they can be extubated. Okay, your patient agitated on respirator. So we have to find out what is wrong. And usually, most of the time, because endotracheal tube needs suction. So you are looking for the cause, it's agitated, and usually most of the time they need suction or endotracheal tube. And we just try to keep the patient intubated on nasotracheal intubation, make the patient more comfortable. But if you do all this and the patient still had agitation, then maybe just near mild sedation. And when you give a sedation, just mild sedation, you don't want to anesthetize the patient. And when you choose what kind of medication, you should see this patient had a pain or just near sedation. Okay, and this paper reviews 300 animal study and human study, and he found if a patient on fentanyl drip or 9 days, 100% of them will have physical dependence. So the adult patient with COPD waiting for the heart transplant, sometimes they are on ECMO, and you see they can be extubated and walk on the hallway. So the newborn on ECMO, they can be extubated as well. And maybe just a better way to sedate the baby. And, when you use IMV, you're thinking about the 6 parameter. When SIMV, you consider 6 parameters as well, but you also have to make sure this sensitivity is enough and the patient will synchronize with the respirator. When you're on AC, patient control the rate, so you have to have a backup rate in case they stop breathing and also have to worry about the sensitivity of the setting and make sure they synchronize. If the rate is high, you may have to readjust the eye time and the PEEP. And see this patient, patient IMV, see the patient with marine to breathe between the respirator. Patient SIMV, see he can breathe spontaneously between the respirator. And this patient on SIMV with volume guarantee. See the volume not necessary is this guarantee. And this another SIMV with volume guarantee, and this patient AC every time patient breathes, they trigger the respirator, assist the ventilation. And if when you are on AC, patient control rate, you will rate it too high, you have to readjust eye time, such as this patient didn't decrease the eye time and see the expiration time become so short. And usually just most of our patients were ventilated with like SIMV and some pressure support as just usually pressure support is 5. And, when the neural signal start from a respiratory center and transmit from operating nerve to the diaphragm, excite the diaphragm contraction, and the chest wall and lung expand, and so the patient breathe. So the airway pressure decrease and flow reverse, and we use a flow reverse to trigger respirator. That's a patient trigger ventilation, that SIMV or AC. Or if we have the setup, like use a respirator, so it can detect the patient diaphragm excitation and to trigger the respirator, and that's called NAMA. So the NAMA will be, the respirator will be triggered faster and make patient more comfortable. And when you use a NAMA, you need this EDI catheter. This EDI catheter is a specialized gastric tube with a small electrode embedded inside. And it is a position at the distal esophagus at the level of crural diaphragm to measure the patient's EDI. And this produce an EDI waveform when this position properly and connect to a servo respirator. And this EDI waveform is used to trigger on and the cycle of each assist breath, and also just control the amount of pressure delivered and independent of airway leak. So this will be EDI waveform. Okay, and this when you use NAMA more in the respirator, there's a backup or if patient apnea or EDI catheter misplaced. And so this NAMA with invasive ventilation, you see this EDI waveform, and use time that NAMA level, and you got this PIP pressures, and this on non-invasive NAMA, so it work very well as well. Okay, so but we want this non-invasive NAMA. It's a NAMA. It's very good for the omphalocele. Like this patient had a giant omphalocele, and he was on respirator and had a problem even with the oscillator. So he was ventilated with a NAMA, invasive NAMA, and he was doing well, and he improved extubate, and so we use a non-invasive NAMA, and I found for severe omphalocele patients, this NAMA is very useful. And also like good for the patient had a severe CDH, like this patient had a deaf CDH, and he was so sick, he was required ECMO. And after repair, so he was extubated, and he was placed on the non-invasive NAMA. But when you NAMA with hold a premature infant, so the extremely premature infant has immature respiratory control, and occasionally has a great deal of periodic breathing with an alternative period of apnea or vigorous effort or hypoventilation after the point of apnea. So if just apnea, just respirator, there's a backup, so no problem. And you vigorous effort, so you may have a very high PIP, and that's dangerous. So make sure you set the alarm limit to prevent overexpansion. And if there's hypoventilation, then that's a problem, because this EDI is very low, so the PIP is very low, also not enough, so the patient maybe stay hypoxic. And high frequency ventilation, here is like a high frequency positive pressure ventilation or high frequency flow interrupter or jet or the oscillator. So in United States, in our unit, so usually we may use a high frequency positive pressure ventilation or oscillator. And this is the waveform for the conventional, into the two there, so until the alveoli level, they just still have a high, but the oscillator, because the rate is so high, it's just damping. By the time go to alveoli, it's very low. And just compare with the oscillator and jet and just conventional ventilation. So this is the jet. But when you use jet ventilation, you still need a conventional ventilator to keep the PEEP. So usually the jet ventilation hold the air leakage syndrome or excessive secretion or the hemodynamic compromise. Or if a patient on oscillator doesn't work, then you try other way and you maybe use a jet. And this oscillator, so you have this parameter you should think about frequency, 10 to 15 hertz. Bigger baby, you turn to low, more small baby with a higher frequency. Inspiration time is 33 seconds, and the mean airway pressure to keep a lung expand. And amplitude, so you see vibration, lung to the umbilical level, and you have a bias flow, and but this respirator doesn't have an oxygen bundle, so you need to attach an oxygen bundle to control the FiO2. And come the oxygenation. So in the conventional, you use FiO2, PIP, PIP, inspiration time. And when you use the oscillator, you think about FiO2 or mean airway pressures. Usually mean airway pressure, increased mean airway pressure, oxygenation will be improved, but only up to a certain degree. And when you conventional ventilation an oscillator, the immediate ventilation is frequency, time is amplitude. So remember that A is about 1, B about 2. So this immediate ventilation about F time this. So if you increase the frequency, so that means you will decrease the tidal volume, and decrease tidal volume, you will decrease the mean ventilation and increase PaCO2. She increase the rate in the conventional mini ventilation increase, but in the oscillator will decrease. And when we ventilate with oscillator, compare with the conventional, she just increase the mean airway pressure. And but because I say mean airway pressure increase, people tend to keep increase the mean airway pressure. When the mean airway pressure is so high, just become is not good. And usually ventilate keep in this area. And we find the patient on oscillator, we still on top of ventilator, if they have spontaneous breathing on top of it, actually the better. This patient had a spontaneous breathing on top of the oscillator ventilator, so he had a better SpO2. And when the CO2 low, he stopped decrease the ventilation, so the O2 side drop. Keep decrease amplitude, so the CO2 higher, so he start to breathe and the CO2 improve again. And the oscillator all had the shunt oxygenation. So if there's the obstruction such as stenosis, they don't pass. This is called shunt oscillation. So the FiO high frequency oscillator, they're very effective to remove CO2, but they are very sensitive to increase airway resistance. And but there's sensitivity to non-invasive compliance. So like this patient, his left lung is a collapse after the surgery. So initially we saw bigger secretion, or we do a suction, but didn't improve. So we know this compliance is different on both sides. So we put on oscillator, and you see this left lung, collapse left lung for a few days, now start open up. And just study compare with the high frequency ventilation with the conventional ventilation, and you see the place of high frequency ventilation better decrease the BPD only in the unit zero conventional ventilation, very high incident BPD. Other than that, there's not better than the conventional. And also this high frequency ventilation may be associated with a high rate of brain injury. So usually people don't use this as a primary mode of ventilation. And so most of the people only like us, we only use oscillator as a rescue because other ventilation doesn't work. Okay. Thank you very much.
Thank you, Professor Ong, for his excellent speech. And we know that he is an expertise in the respiratory care and when he start a ventilation, he always at the patient bedside for a long time. So he has an excellent result. So, and also he wants to have anesthesia, but the anesthesia is only mild degrees only, not in the deep anesthesia. My question is how to have the suction if the patient after respirator is become worse and he has some secretions in the airway. So how to use the ET suctions such as the tube length and the position of the head. This is question one. Question two is how to extubation. How to on what condition the patient can extubate and how to do this. Thank you.
Okay, you hear me?
Yes.
Can you hear me? Okay.
Yes.
How the patient had usually you the patient on respirator and is agitated. You don't want any reason such as tube disconnect or something like that. So usually main is near suction. And you know the endotracheal tube is a foreign body. So in the trachea will irritate, create more secretion. And also the tube, so the patient, this tube foreign body, so suppress the serial motion. And also patient cannot cough. So, you know, so you the patient, and when you suction, I know a lot of people suction cast only just near the tip, don't go beyond the endotracheal tube. No, I don't think that's right. Secretion don't jump to the endotracheal tube for you to suction. So usually we will suction the main bronchus. And we also pay attention, the nurse had to pay attention to the length. And usually if a patient like 1 kilogram, the endotracheal tube length plus 3 centimeter or to suction the main bronchus. And you have two main bronchus. So you want to suction the left side, you turn the head toward the right side. So you have better chance to go to the left side. You want to go suction the right side, you turn the head to the left. Okay, and you suction capsule into the right place, and then quickly aspirate and pull. And another thing people make a mistake. They say the baby is small, so the medication dose is small, so the suction length should be low too. No, that's wrong. Yeah, the secretion is secretion. Newborn secretion can be just as thick as the adult. An adult patient when you suction with 18 French suction catheter. When you use a newborn, you use a 6.5 or 8. So the resistance very high. If anything, there should be high, more negative pressures, not less. Okay, that's how we suction. And before, of course, before suction, you give increase some oxygen and watch the FiO2, and after suction, so the the O2 start recover, then you turn on the oxygen. So that's whole for the suction. And I think your second question is about when we extubate.
Yes.
Okay. All right. When we, as I say, show, so the patient, we always, patient has spontaneous breathing. So the exercise your muscle, their muscle don't get atrophic. So, and your patients are active, they can move like that, they can breathe. Okay, that's very important. And usually, if sometimes when we extubate a patient, we direct laryngoscopy and the paint the larynx with epinephrine, because you have a whole body. You especially the patient intubate for a while, you more or less had some edema, and I think quite often they fail extubation because edema. So usually with laryngoscopy, we paint and ask and put a tube out, use secretion, we suction, quickly suction, and we also paint and make sure the vocal cord is moving. That's how we extubate. And usually when we extubate it, we extubate faster than most of the people. And our success rate extubation, like when I extubate, I expect close 100% of success. Not like other people report 30-40% of failure. And I think that's because most of the time the failure will extubate because edema. Okay.
Okay. Thank you, Professor Ong. And Frank Du, please.
Yes, thank you, Professor Rentian Wong, and thank you for the moderator, Professor Junren Wu, for this very nice talk about ventilation and the section. So now we're going into a morning break, and please come back about 4 minutes later. Thank you.
Thank you. Thank you all.
Thank you.
Thank you.
Thank you, Professor Wong.
Thank you.
It's morning break time now. Please come back 10 minutes later.
In the meeting room, we have a main room, which is room A, where all the plenary lectures are. We also have a room B that will show the exciting online symposium, e-posters, and nice video shows. For going into room B, go to the participants breakout section, that you can find room B in the virtual meeting conference room.
At the Nestlé Nutrition Institute, we have one clear vision: to bring nutrition science to life through the people who live it. Connecting a world of healthcare providers, generating discussion and encouraging relevant conversations. NNI believes that the more we promote and grow the understanding of nutrition today, the more we can shape the science of tomorrow. So, we foster and disseminate nutrition research to a global audience, sharing a premium range of resources, offering both scientific and practical information, which is available anytime, anywhere, and covering everything from the first 1,000 days to healthy aging, from cutting-edge science through to sustainable nutrition, to actively establish deeper, more meaningful dialogue, inspired by your needs, fueled by your desire to be at the forefront of scientific thinking, and ultimately, to help you in your professional life. Everything we do is built around you to help bring nutrition science to life through the people who live it. NNI, advancing science for better nutrition.
Thank you for this part, and sorry for the short break, but there's still many exciting lectures going on. So next, we're going to the next plenary lecture, which will be moderated by Professor Professor In Wen-zhong. Please, Professor Zhong.
Thank you, distinguished guest, Professor Gary Wang, my co-chairs, Professor Andrew Collins, and Professor Zhengong Dai. Ladies and gentlemen, it's my great pleasure to introduce our next speakers. Professor Gary Wang obtained his undergraduate medical education from the University of Alberta, Canada. He subsequently received a fellowship training at University of British Columbia and Children's Hospital of British Columbia, and visiting fellowship at the Children's Hospital at Munich, Germany. He is the immediate past president of the Asia Pacific Academy of Pediatric Allergy, Respirology and Immunology. Currently, he is the president of Hong Kong Institute of Allergies and one of the board of directors of the World Allergy Organizations. He is one of the steering committee members of the International Studies of Asthma and Allergies in Childhood Research Group. Among other duties within many education boards, he is also an associate editor of New England Journal of Medicine. Today, he is going to talk about how can we put an end to the COVID-19 pandemic. Ladies and gentlemen, please join me to welcome Professor Gary Wang. Professor Gary Wang, please.
Thank you very much for the organizer in giving me the opportunity to discuss with you this important topic, how to put an end to the COVID-19 pandemic. I think over the past 1.5 years since March 2020, when the COVID-19 outbreak was declared to become a pandemic, all of us have been asking this question many, many times over. And in order to figure out how we'll be able to put an end to the pandemic, we may want to look at the history over the past 100 years. Well, what exactly were responsible for pandemics in the last century? We can have a look here that 4 pandemics have all been related to influenza virus. The famous 1918 pandemic H1N1, followed with the 1957 H2N2, and the 1968 pandemic due to H3N2, and then the relatively mild 2009 pandemic due to H1N1. And in the last 20 years, there has been a couple of viruses that try to achieve the status of a pandemic. And they are the SARS in 2003, which is a novel coronavirus attacking humans, followed with the MERS in 2012. Primarily, the cases were limited in the Middle East. And there was also an outbreak in Korea. But these 2 viruses did not achieve the status of a pandemic virus. And there was also, in between the period of 2013 to 2016 of the Ebola outbreak, primarily the cases were in Central Africa. And when we look at these viruses that achieve the pandemic status, they were all due to influenza, and they all have some resortment of viral genes from avian or swine influenza. Because of the resortment resulting in a new strain, humans were not immune to this infection. And there's also a common phenomenon that these viruses succeed because they did not kill the host in most of the cases, such that there are many cases of mild infection, and the humans can bring the virus from one region to another region, from one person to many other persons, unlike SARS-CoV-1. And if one look at the famous Spanish flu, the pandemic in 1918, there were no vaccinations. There were no effective specific medications for influenza. The pandemic stopped. We basically back then tried to combat this infection by isolating the infected, cut down on the number of infections as much as possible by the use of masks, and eventually large percentage of the population became immune from natural infection, leading to the cessation of the pandemic. And if one look at the current scene due to SARS-CoV-2, one will realize that this pandemic is causing major problems currently, especially in the Americas, and also with the emergence of new variants such as the Delta variant with very high infectivity. Cases are surging across many European countries. And if one look back in the situation in late 2020 and early 2021 in the United States, the situation was very bad. And as a result, if one look at the typical Western approach at that time, the approach was trying to keep the economy open as much as possible, as long as there are not too many new cases that may overwhelm their hospital system and ICU, and also strict limitation and control of people in terms of shutting down are rather difficult in those countries. Instead, they put a great bet on developing effective vaccination. And in the US, they have the Operation Warp Speed with major seeding money to speed up vaccine development. And of course, vaccine is a very important tool to help to stop the pandemic. If one look at the famous disease smallpox, that has killed millions and millions of people. But how exactly do we make a vaccine? And the term vaccine comes from the Latin word vacca, meaning cow. And the vaccine that we use is the virus, vaccinia virus. And it was the careful observation of Dr. Edward Jenner, an English physician, who observed that milkmaid had very mild cowpox infection. And with that, they are immune to the development of smallpox. And in fact, if one look back at the history of this vaccine, the natural infection, as you can see here with a pair of brothers, the one on the left was infected because he was not vaccinated, while the other one was vaccinated and protected from infection. And this infection can have a mortality, particularly in young infants, up to 80%. And if one look at the deaths related to smallpox, In the 20th century alone, it was estimated as 300 to 500 million people died from this infection. And when the virus was brought to the Americas by the Europeans, it basically killed off 90 to 95% of the natives. And with the development of vaccination and widespread use of vaccination in stopping outbreaks, the disease finally was eradicated from the human being, and it was declared eradication by the WHO in December 1979. And in fact, if one look at the history of using some sort of infection resulting in protection, one will realize 291 years before Jenner's work on cowpox, a Chinese doctor in the Ming Dynasty from Hubei, in fact, they have this method of getting scrapings of dry powder smallpox scabs from infected individual and use a very long tube and blow it up the nose. Basically, the recipient would develop a very mild disease. But with this method, there was a mortality of 0.5 to 2%. So it's not exactly benign. But this was replaced by the widespread use of the vaccinia virus, the smallpox vaccine, subsequently. And if one look at how the immune system learned to recognize and respond to various antigens, and usually when we get exposed the first time with some sort of antigen with a primary response, and within a few weeks, if we give another dose of the antigen, that tends to bring a secondary response, which result in a higher peak of immune response to a particular agent. So in the last year, we have seen rapid development of different types of vaccines. So are they going to help us to end the pandemic? Now, we have the messenger RNA vaccine from Pfizer and Moderna. We have the adenovirus vector vaccine from the AstraZeneca Oxford group. And we have the inactivated virus from mainland China. And we have also the subunit virus, vaccine, Novavax. Well, how exactly do we make the vaccine? Well, there are different strategies. One can use live but attenuated organism, such as polio, the Sabin vaccine, MMR vaccine. But not all infective agents can be easily attenuated. So another way is to inactivate, kill the virus, such as the use of formaldehyde in inactivating the polio vaccine, the Salk vaccine. And they're also using parts of the virus, such as the hepatitis B surface antigen, using as a subunit vaccine. So, but when you develop these sort of vaccine, you're going to need a lot of antigen, a lot of that virus, and you have to cultivate these viruses in live cells, such as the influenza using the eggs. So we have newer ways of making the vaccine when we understand the pathophysiology of SARS-CoV-2. Well, we know the spike protein is very important for attachment to the ACE2 receptor on respiratory epithelium. Once attachment takes place, the virus is internalized and causes infection. So if one can stimulate the immune system in making antibody against the spike protein, that would be highly efficacious. Well, so can we teach the cell, all right, give some instruction and teach the cells to stimulate the immune system? And that's the basis of the DNA vaccine or the RNA vaccine. The DNA by giving the DNA material that gets into the host cells and cause expression of a certain part of the virus on the surface membrane. An RNA is basically an RNA encoded specific instruction. In the case of the COVID-19 vaccine, it codes for the spike protein, and it's packaged in a nanoparticle and get internalized by various cells and expressed on the cell surface, stimulating the immune system to produce an immune response. And with that, the rapid development goes through animal study, as you can see here in this DNA vaccine against the SARS-CoV-2 in animals. And subsequently, there are this phase 2 trial of the Moderna published in the New England Journal showing very effective, stimulating a very effective immune response producing antibody against the spike protein. Subsequently, with large phase 3 trial, the vaccine efficacy was demonstrated. And this is the way we determine the vaccine efficacy. Of course, if there were lots of cases circulating in the community, it would be relatively easy to demonstrate whether the vaccine works or not. And also, the better vaccine, the fewer the cases that would be needed to detect protective ability, because there would be a large differences between the vaccinated and the placebo group. But we can only look at specific time interval. Okay? For example, the current vaccines we have for SARS-CoV-2, basically, we have data on the efficacy over a period of time of something like 3 months. So we also need to remember the virus can mutate. And when they mutate, it may affect vaccine efficacy. And one look at the Moderna virus, one of the messenger RNA virus. You can see here the phase 3 trial published in the New England Journal of Medicine. You can see comparing the placebo group and the vaccinated group. There's wide separation. And one calculate out the vaccine, Moderna vaccine efficacy, and this is how we calculate it. So among the almost more than 15,000 who were vaccinated with the placebo, there were 90 infections. While the 15,000 who were vaccinated with the active vaccine, 5 of them developed the infection. So with that, one can estimate the vaccine efficacy was 94.4%. But one must remember, now from this trial and the data, out of the 15,000 who got placebo injection, 99.4% of them did not get infected. So that means if one calculate the number needed to treat for saving one person from infection, we're talking about a number something like 179. But of course, these numbers may change depending on how severe is the outbreak of the infection in the community. But in any case, a lot of people who may not get infected or who may get infected developing very mild infection, we need safety of the vaccination. And when it comes to safety, it takes a large number, in particular, if we want to detect rare infection or rare side effects. And also, the longer the trial, that is, the follow-up period, the more likely we may be able to detect appreciable delayed side effects, if there are any. So for example, if one look at the adverse effect of the Oxford AstraZeneca vaccine, the Johnson & Johnson vaccine has a similar problem because both of them were adenovirus vector vaccine. And they were shortly after this vaccine were authorized for emergency use, there were rare reports of CNS thrombotic event. And this event commonly occurs in young women. And the estimated incidence in the group that is at highest risk are the 30 to 39-year-old women, estimated to be about 1 in 100,000. And subsequent careful investigation of these patients, it appears that the vaccine can stimulate the body to produce a presence of specific antibody, the platelet 4 antibodies, which result in the problem of clotting and thrombocytopenia and the central cerebral venous thrombosis. Now, one must remember the typical vaccine schedule, actually from preclinical to clinical, going through the different stages, and regulatory review. Very often, it takes about 6 to 8 years minimum. For the SARS-CoV-2 vaccine, we have only spent about a year and a half. And when it comes to vaccination, I'm sure many of you have seen these numbers being quoted. So some being higher and some being lower. But one must remember, these trials were done at different period of time with different type of variants circulating and also in different populations. So it's not fair to compare these numbers directly. But when you come to the vaccination, we should look at what exactly do we try to prevent. Do we try to prevent all infections? Or do we want to turn symptomatic infection into asymptomatic infection? But actually, with vaccination, what we really want to prevent are those with severe symptoms. Prevent people from getting sick, resulting in ICU or death. And basically, all the licensed COVID-19 vaccine can achieve more than 90% in terms of protection against the severe outcome. And those are the outcomes that we care about particularly. So when one look at the Eastern approach, in contrast with the Western approach, putting a lot of resources in developing the vaccine, the aim of the Eastern approach, such as in places like Korea, Taiwan, Vietnam, Singapore, Hong Kong, or mainland China. Okay. These countries aims to contain and eliminate the virus from circulating in the community. So very early on, there was universal masking to cut down on the spread. There was very strict lockdown, very strict, Wuhan style. Basically, all the activity comes to a halt. And in terms of isolation, as opposed to the home isolation in many European countries and North American countries, in Asian countries, primarily institutional isolation. Because in many of the crowded cities in Asia, home isolation simply is not practical. And in January in 2020, when there was this massive lockdown in Wuhan and Hubei, there were a lot of criticism from the Western media, as in this case, a story from Washington Post expert from the United States criticizing these sort of unprecedented quarantine of big city would not work and never effective. Well, that was the criticism. But at the end, if you look at, from Wuhan to Taiwan and all the cities and countries in between, Italy, Spain, France, UK, and then to North America, to Rio, and then Taiwan. Basically, all the countries would use similar strategies of lockdown. And subsequently, there were no more criticism. And in fact, people were trying to balance how tight the lockdown should be in different countries. And there were some modeling determination of how effective of the lockdown was in Wuhan. And as this analysis published in Science last year demonstrate the lockdown in Wuhan indeed reduce the number of infected cases dramatically in mainland China. And of course, it would reduce the number of deaths dramatically. Well, the Eastern approach has been to end the pandemic by containing it, by eliminating it, hopefully, just like what had happened in 2003 with the SARS-CoV-1. But this time around, because of the presence of lots of asymptomatic or mildly symptomatic people, it's much more difficult to achieve, particularly in other countries who may not be using the dramatic public health measures that were used in many Asian countries. If you look at the use of masks, there were lots of demonstration or arguments or problem in Europe that people would like to have their own freedom. They don't want the mask. Lockdown, they don't want that either. They want to have their personal freedom to go around. And in terms of testing and isolation, there was massive problem in many countries in terms of the capability of doing testing. And I mentioned earlier, the use of home isolation in many Western countries has been found to be highly ineffective, while institutional isolation is more the norm in Asian countries. And when it comes to about the discussion of testing, I think this example show how massive, dramatic scale of testing can be. A couple of cases of the port workers in Qingdao late last year, with routine testing, they were found to have asymptomatic infection. And those 2 port workers were taken to a local hospital, the Qingdao Chest Hospital, which was designated as the hospital to look after patients with COVID-19. And subsequently, there were a taxi driver who developed a transient ischemic attack and was investigated in Qingdao Chest Hospital. And he was found to have the infection. And with the infection, now because of the taxi driver, and also there was also 1 patient and 1 nursing assistant also found to be infected, all from the hospital. The Qingdao City decided to perform a total population of Qingdao population with testing within 5 days. There were 9 additional cases found, and they were all related to the cluster within the hospital. It's highly likely that the 2 port workers who were investigated earlier there spread to the other patients in this hospital, resulting in the nursing staff got infected, and the nursing staff passed the virus to the taxi driver. And that's how the outbreak was controlled. And during the 5 days of the testing in the city, there were no specific lockdown, so to say, for the people. People were not allowed to use public transport until they were test negative. And if people leave Qingdao, they need to have a negative test, and also they have to be home isolated for another week and retested to make sure they're not infected. Now imagine, because in countries where a lot of people are not vaccinated and a lot of people are not immune, a few cases would result in a significant outbreak. But of course, these sorts of testing required a lot of cooperation from people. Imagine, testing 10 million people in 5 days. You need not only the laboratory facilities, you also need the cooperation of the citizens. And if one wants to look at the results of how well different countries control the outbreak, I think probably the best statistic is to look at the number of deaths per 100,000 population. This data coming from the Johns Hopkins University monitoring. As you can see, a lot of the countries with very high mortality are usually European countries or in America. Okay. Now, up to, for example, the data I have shown you here with the bold black letters are those as of August 26. In Hungary, it's 312 per 100,000. In UK and USA, it's 200 per 100,000. But what about Asian countries? Well, if you look at some of the Asian countries, look at Japan, about 12.5 per 100,000. Thailand, 14.06. Indonesia, 47. Vietnam, 9. And then Korea, Singapore, China. You see the numbers are very, very low. And if you look at the current as of August the 26th, the rate, the mortality in Italy is 237 times that in Singapore. So certainly, for now, many of the Asian countries have done much better than that of the European countries. But as long as the virus are circulating in some parts of the world, Asian countries can be very vulnerable to various types of infection. For example, like the current Delta variant. And if one look at the projected COVID-19 vaccine coverage around the world, well, by the end of this year or early next year, yes, we can see in North American country and Western European country, and for Asia, probably with the exception of Singapore and Hong Kong, the vast majority of the countries in Africa, Southeast Asia, and also across the Middle East, we will be far from reaching a state of herd immunity. So that means as long as there are pockets of places where there are active circulation and infection, who knows, some other new variants may develop. Currently, our current vaccine seems to be still effective against the Delta variant in terms of severe disease. But certainly, we're seeing they are not as effective for preventing infection as in the original variant. So that means, no matter how we protect our border, we cannot shut down our border forever. And so we need to watch out. And if one look at the various emerging respiratory virus over the last 20-odd years, you can see, the new in the avian influenza. We have been lucky that the transmission of avian influenza is rather difficult from one person to another. You need very close contact in order to catch infection. As a result, we've been lucky that the various avian influenza did not result in widespread transmission. But who knows what will happen in the future? There is various viruses emerge and in the human population. Now we have the COVID-19, and I'm sure this will not be the last virus. The next virus will come. It's a matter of time. So we need to be prepared. Now, if one look at the 4 pandemics in the last 100 years, there are things that are in common. They have a lot of relatively mild patients, right? And they can spread easily from one person to another one. The coronavirus has similar characteristics. Flu vaccine was developed. The first one was commercialized in 1945. So from 1957 onward, the pandemic, in a way, were kind of controlled with the help of the vaccination. But still, you can see the 2 pandemic, 1957, 1968, there were millions of deaths. And now, the coronavirus has caused more than 4 million deaths around the world already. So, when you think about how to put an end to a pandemic, do we want to eliminate the virus from human transmission, such as what we've done for SARS-CoV-1? But it was relatively easy for SARS-CoV-1 because when a patient can transmit the virus, usually the patient is symptomatic. So it's very easy. We can diagnose the patient, isolate the patient, and then we can stop the chain of circulation. SARS-CoV-2, the story is totally different. There were so many asymptomatic patients or mildly symptomatic, such as the virus, who continue to propagate in humans. And looks like we'll have to wait until most people became immune, either by infection or by vaccination. Do we see the end to this pandemic? In the meantime, various measures, right, should be used to minimize transmission, particularly to the at-risk group. And there's actually a choice how we want to do it. Right? If we do stick to, very strict public health measures, right? Because whatever we do, there will be a price tag. There will be a cost. If we lock down, shut down the economy, there will be a cost. But there will be a lot of lives saved too, as demonstrated by the first wave of outbreak in many Asian countries. And at the end, the combination of public health measures, the massive use of testing, the use of masks, and the behavior of social distancing, and the limitation of personal freedom, they all help to end the pandemic. And of course, with effective vaccination, that would help us to speed up to reach the end of the pandemic. And hopefully, we'll learn from all the what had happened with the 4 pandemic due to influenza and the pandemic due to coronavirus, SARS-CoV-2, that we will do better when the next virus comes around. And I thank you very much for your attention.
Gary, hi, this is Andrew Collin. I am in charge of the Q&A for you. Very nice to see you from the other side of the world. Can you hear me?
Yes, very well.
Hi. Well, there are comments, of course, of the wonderful talk, which an opinion that I, of course, share, not surprised. And I really appreciate the depth and detail of your approach here. There are some questions that I will share with you. I'm not sure that we'll be able to go through all of them. One question is about considering poverty and environment. Would you recommend a policy of COVID-19 vaccination for children at different age groups?
Yeah, Andrew, I think we are seeing accumulated evidence that children do play a significant role in spreading the infection. There were outbreaks in school, and then within the outbreak, the teachers got infected. And I personally don't really worry too much about children. A small minority of children develop, for example, most severe complication related to COVID-19, multi-system inflammatories. And yet, even if you look at that rare complications, the mortality is extremely low. US data suggests that it's something like 1 to 2%. And our way of treating immune response related to system inflammatory syndrome. So I would expect nowadays when we treat the child with that syndrome, our success will be a little bit better than the original data published. But the fact is, we have to get the children. Otherwise, they would continue to spread the virus in school and spread to the adults. And we know now, even if we're infected or if we get immune by vaccination, the coronavirus, for some reason, our immunity do not sustain. After a while, after a natural infection or vaccination, our immune protective capability drops with time. So it looks like as long as there are viral circulation, we will be needing regular booster of immunity of vaccine every now and then, so that regular vaccination for children be an important part of combating this infection. Unfortunately, if I always say, if all countries in the world can behave like many of the Asian countries in the initial wave, we could have eliminated this virus from human circulation. But given the picture that we're seeing right now, I think we can achieve that. Once the border of many of the Asian countries open, the new variants will come in and cause trouble. So we just have to live with this virus.
Different angle is asked here about the possibility of targeting the expression of ACE for prevention or treating childhood COVID-19. Is there such an approach at all that is dissociated from the question of vaccination?
Yeah, if one look at data related to ACE2 receptor, as well as the severity, yes, there seems to be data suggesting, for example, in the patients with asthma or allergic disease, the expression seems to be a little bit lower. And also, in general, children's expression appear to be a bit lower. But I would hate to use that strategy to manipulate, the density or the ACE receptor, because, we don't really understand the biological function. The ACE2 receptor are there for a specific physiologic reason. I would think that approach of trying to manipulate ACE2 receptor, at least on a population level, would be dangerous. In patients who are infected, maybe, but and also we know those who tend to develop severe disease, it's not just their attachment, it's their subsequent immune response to the viral infection. So the current strategy managing those severe cases really is immune manipulation rather than targeting the entry of the virus. The entry of the virus through the ACE is more for preventing infection.
Another question here along the lines of antibody creation is there are opinions that the antibody for COVID-19 is not a reliable marker of protection. And I think that actually this resounded strongly in the opinion that was heard at the FDA the other day, where I think Dr. Gandhi stated that, you have type B type and T cells that are active despite the fact that the titers are not elevated. How does one approach this in the future?
Yeah, the current approach of trying to test whether someone is immune or not very often is look at the antibody against the spike protein. But that is only, to me, it's a one specific part of our immune system in protecting us. And certainly, purely just measuring the antibody may not be at all reflection of the immunity. And the other cellular immunity, mind you, measuring cellular immune response is a lot more complicated than measuring antibody. Currently, I don't see a good way of how to get around with this other than a population approach. If, let's say, if the majority of the community vaccinated, majority of them, and when you, for example, measure antibody, many of the people, you can at least detect antibody. One would tend to suggest, at least in this community, it's reasonably well protected. In particular, just like the flu, we want to protect in flu, we want to protect disease and severe complication in the two end of the spectrum, the very young and the very old. I think for SARS-CoV-2, slightly easier. Even for the very young one, we know from data of infection in the neonates and infants, they don't get very sick at all. So it seems, if we get those, for example, those with comorbidity, those over 60 years of age, if we can get that group well protected, the coronavirus, the SARS-CoV-2 will become another flu virus that we have to live with daily basis.
So another angle to the same question is relating to the statements by Professor Verinder Singh yesterday, who was talking about comorbidities. And so would one take a different approach in protecting the children with comorbidities? And particularly the question relates to Asia. I'm not sure why in Asia it would be any different, but that's the nature of the question.
It's interesting, despite the fact that we worry about comorbid conditions making COVID-19 infection more severe. If one look at the mortality data among children, excluding those related to multi-inflammatory system syndrome, in fact, there have very few deaths related, to children with comorbid condition and COVID-19. And even if one look at the population, asthma, probably most common respiratory children. And yet there are all sorts of data suggest, except for the very severe spectrum, poorly controlled asthmatic. In general, asthmatic are not at a very high risk of developing severe COVID-19. So in children per se, I do not worry too much about morbid. It's more the elderly that I worry. And that's probably the reason why in many countries, for example, in the UK and the US, they were starting vaccinating the third dose for that particular population.
I don't know whether there's a timekeeper, but can we go on, continue? Because there are other questions here. Is somebody keeping check of time? Dr. Zheng Kong Dai?
Yes, I think 1 more minute.
1 more minute, okay.
1 more minute. Yes, please. Thank you.
So this is another angle of the question of ACE2. Since the expression of ACE2 is closely related to pulmonary hypertension, are there any altered histologic changes in lungs of children who are infected, and I guess that people who die with COVID-19?
Very, very good question. I think there are very few pathologic reports because there are simply very few deaths. The deaths that I know of, for example, Asia, there was from the Wuhan cohort. One was related to a patient with leukemia, and another patient was a young infant also develop interception and the delay in management interception. But if you look at the path report, overseas, there may be a few also related to deaths related to system inflammatory syndrome. But I'm not aware of hypertension per se is a problem in terms of the pathologic from the lungs. Not that I'm aware. And one thing I would like to get back.
Gary, I'm sorry, we're not hearing you.
Right. Someone mute me. Now,
yeah.
I guess mute everybody. Yeah, about the use of vaccination. Now, a lot of parents worry about two doses, particularly the mRNA vaccine. And because there are a very small percentage, something like 12 per million children, particular for the adolescent boy developing a mild form of myocarditis simply because of the most significant immune response. And there were discussion about why don't we just give them one shot. And I must say, giving one shot has not been tested properly in terms of its protection. And that's why, I see Andrew nodding. In the United States, you still give 2 shots to the adolescent, even though people are talking about shot. Because to me, I say, whatever you do in the pandemic, such as vaccination, on one hand, you want to achieve effectiveness. On the other hand, you want to minimize adverse effect. And the adverse effect, as we can see for the mRNA vaccine, yes, a mild form of myocarditis does happen. But if we cut out the dose, basically we give the primary stimulation without another secondary stimulation, without properly test this sort of regime, we don't know whether it's effective or not. That's why, in fact, in Israel, back in May or June, they have considered giving one shot to the adolescent. But at the end, when they look at the data, they decide not to do so.
Well, Gary, there are other comments about your wonderful talk, and thank you very much for it. And I definitely share that and look forward to see you in other environments. And thank you, everybody, for sharing with me. And we'll see you later. Bye-bye.
And thank you. Thank you very much.
Thank you.
Good to see you all. Bye now.
Bye. Thank you all. Thank Gary Wong for the great speech, and thank Andrew Collin and Wen Zhong and Ren Gongdai for the moderation. Next, we're going into the next section, which is about satellite symposium. And for this part, you can go on the official website on the www.2021-apps.com. We will have more talks over there. So you're welcome to see more talks over there. But for the time limit, we just choose a couple of topics to share in the main room. So the first part is the B1 Satellite Symposium about pediatric sleep medicine. So you will see 2 more topics in the online symposium part. You can see the talking about OSA and many important parts.
Right now,
so this is
no, in Taiwan. She's speaking right now.
Sorry, please turn on your microphone again.
Okay. Can you hear me? Yes. Okay. So next we're going to introduce the moderator, Miss Mei Zhizheng, to talk about the next topic. Thank you.
Thank you, Dr. Liu. I'm Professor Mei Zhizheng from the Institute of Emergency and Critical Care Medicine of National Yangming Jiaotong University and the Neonatal Medical Care Center of Taipei Veterans General Hospital in Taipei, Taiwan. I'm very happy to be a moderator with Professor Aru Wang Principal from the Pediatric Department of the Mahidol University in Thailand and Professor Albert Lee from the Department of Pediatry of the Chinese University of Hong Kong
to introduce our honorable speaker, Professor Yu Shu Huang from Taiwan. Professor Huang graduated from Taiwan Chang'an University. She has published a lot of reports related to pediatric hypersomnia, narcolepsy, pediatric OSA, and ADHD. And currently, she is a director of Department of Child and Adolescent Psychiatry at Chang'an Memorial Hospital in Taiwan. Today, she is going to give us a wonderful special talk, Alternative Non-Invasive Treatment of Childhood OSA. Dr. Huang, please.
Good morning, ladies and gentlemen. Thank you for inviting me to this conference. I'm child psychiatrist from Chang'an Memorial Hospital and University in Taipei, Taiwan. Today, I'm going to present the topic of alternative non-invasive treatment of childhood OSA. And today, I will focus on the orofacial myofunctional therapy and the passive orofacial myofunctional therapy. I have no conference of interest to disclose. As we note, the pediatric obstructive sleep apnea was initially described in 1976 by Professor Garimino. In 1971, he also published an article and emphasized that pediatric OSA was different from the clinical presentation reported in adult OSA. It was characterized by more disturbed nocturnal sleep than excessive daytime sleepiness, and presented more behavioral problems, particularly school problems, hyperactivity, inattention, nocturnal enuresis, sleep terror, and other psychiatric problems such as depression, insomnia. Our team also published an article in 2017, and it showed the underlying causes of pediatric OSA are very complex, such as adenotonsil hypertrophy, obesity, anatomical and craniofacial anomalies, and hypotonia or neuromuscular disease. Because the complicated mechanism of pediatric OSA, there are some treatments for pediatric OSA was noted, such as medical treatment, surgical treatment, and orthodontic treatment. As we note, the TNA has been the recommended treatment for pediatric OSA, but in the recent past, this practice has been placed very much in question because the residual problem and the recurrent rate is still high after TNA. So we should reconsider what the real mechanism of a pediatric sleep disorder breathing is. In the textbook, always show the upper airway patency is a core component in the pathophysiology of a pediatric OSA. We know that the upper airway is located behind and below the craniofacial cavity. Therefore, there is no doubt that craniofacial development affects the development of the upper respiratory tract. Moreover, we should question, is craniofacial malformation a cause of a sleep disorder breathing or a consequence of a sleep disorder breathing, or both? Many previous studies show that the theories of a craniofacial growth is not supported by a single theory, as we don't really know what controls bone growth. So the craniofacial growth should be affected by many factors, such as the genetic and the epigenetic, local, regional, and the systemic influence. At birth, children may already have factors that will impact on their orofacial growth. Most of these factors have a genetic origin. But there are also factors that are acquired very early in life, such as upper airway allergy, progressive tonsil adenoid enlargements. The next slide, I will show the risk factor of abnormal development of the upper airway. Let's see the genetic risk factors such as the short lingual frenulent, dentogenesis, generalized muscle disorder. All these factors will impact abnormal orofacial growth and maxillomandibular deficiency. Another environmental factor such as allergy will increase the adenoid tonsil hypertrophy or enlarged turbiness, and finally will decrease nasal breathing and increase mouth breathing. Premature infant also, they were born too early, so they are absent of enough training, and finally will increase the abnormal orofacial growth. Also, they have a more muscle hypertonia, and it also will increase the mouth breathing. Mouth breathing locally leads to local inflammation, and it will increase the tonsil adenoid enlargement and then worsening of a poor nasal breathing with increase in upper airway resistance. Finally, it impacts abnormal orofacial growth. And this is a continual interaction between the factors leading to mouth breathing, and mouth breathing is built on these factors. So from about concepts, we should focus on the earlier in life functions that will affect the development of the oral cavity. There are some critical functions in normal development of orofacial structure during first 2 years of life, such as nasal breathing, sucking, swallowing, chewing, and mastication, biting force, eruction, and tongue thrusting. If these functions are impairment, will lead to abnormal growth of orofacial structure and increase the risk of collapsibility of upper airway during sleep. Let's see the nasal breathing. Nasal breathing is one of the important early in life function. At birth, the size of the nasal fossa is small, and the nasal turbinates are large, leaving only a relatively small passage in paramedian. So the nasal ventilation provides direct feedback to thorax ventilatory movement. The regulation of the nasal airflow to thorax ventilator movements involves a complex series of reflex acts in the motor cortex. So lack of normal nasal breathing, typically coupling with thoraco-abdominal ventilation, will lead to deficiency in the development of a normal breathing. Moreover, normal nasal ventilation will be related with the development of a sinus, anterior part of a nasal fossa, and the maxillary. When impaired, nasal respiration will result in postural change of the head and neck, and changes in the tongue and the mandibular displacement. Unfavorable dental facial development may occur. The previous study showed that the abnormal nasal ventilation will impact the mouth breathing. These findings are in agreement with the effects of increased upper airway resistance on dental arch morphology and can be explained by long-term change in the position of the head, mandible, and tone in order to maintain the airway adequacy during sleep. Not only the craniofacial morphology will be changed, but also the mouth breathing will change the side of the oropharynx tube. Therefore, chronic mouth breathing will change in posture, increase in nasal resistance, increase airway collapsibility, alterations in facial growth, and narrow hard palate will be developed. Finally, developed the pediatric obstructive sleep apnea. From this concept, Professor Garmino published an important article in 2018. He emphasized that the earlier in the life developments of the orofacial structures and the anatomical variants that may be present at birth and can impact nasal breathing. After birth, there is a continuous interaction between orofacial function and the growth of orofacial anatomic features. The orofacial dysfunction identified today as impacting orofacial development and leading sleep disorder breathing. This is my patient. He is a 2-year-old boy with developmental and language delay. You can see his adenoid hypertrophy and tonsil hypertrophy also. He has the symptom of mouth breathing. Unfortunately, he only received rehabilitation. No one cared about his physical problem, and there is no treatment. When he was 4 years old, you can see the adenoid and the tonsil hypertrophy become more serious, and the mouth breathing has also become worse. Finally, it impacts on craniofacial growth. You can find the cranial cervical angulation increase. You also can see the overjet and overbite and high mandibular plate. Also, the open mouth breathing was noted. Due to the open mouth breathing and snoring, the PSG was arranged. The result showed AHI is 103.1 per hour. A lot of O2 desaturation and severe pediatric OSA was found. From previous study and the test report, we can understand the impairment of these functions lead to abnormal growth of orofacial structures that support the upper airway and increase the risk of collapsibility of upper airway during sleep. Finally, developed pediatric OSA. Meanwhile, our previous research has proved that dysfunction causes deformity, and then we can understand why oral myofunctional therapy is effective in treating pediatric sleep disorder breathing. In 2013, Professor Garmino had published an article of myofascial reeducation in pediatric sleep disorder breathing. In 2015, there is a meta-analysis study, and the results show the myofunctional therapy could reduce AHI 50% in adult OSA and 62% in pediatric OSA. Also, the myofunctional therapy could improve the symptom of snoring and daytime sleepiness. The purpose of oral myofunctional therapy is to breathe through nose, to put the tongue in the right position, and to correct the posture, to exercise orofacial muscles, and particularly the tongue muscle. This exercise also helped on swallowing, speaking, mastication, and sucking. Because there is no long-term outcome study of oral myofunctional therapy, So we designed a study to evaluate the treatment outcome of oral myofunctional therapy in pediatric OSA. This is a 2 years following study to compare the oral myofunctional therapy group with oral device we call the passive myofunctional therapy and control group. In this study, we collect 15-fold pediatric OSA patient whose AHI greater than 1 per hour to receive the oral myofunctional therapy, and another 15-6 patients received passive myofunctional therapy. Unfortunately, there are only 23 patients who would like to come back after half years follow-up, and there is no patient would like to come back to complete the study. Let's see the result of a myofunctional therapy. The PSG results show the RDI, radar, and sleep latency have a significant improvement in the half year's treatment, but the very poor compliance and no people want to come back after 1 year. In oral myofunctional group, there are 10 patients have a very good compliance, so we compare the spirometry with control group, and we see the PNS, NPH, and AD2, the nasopharynx area, showed significant improvement after half year's treatment. This is a 4 years old girl received the oral myofunctional therapy with very good compliance. You can see not only the AHI improvement, but also the nasopharynx distance have significant improvement after half year's treatment. Due to the poor compliance of oral myofunctional therapy, Dr. Michel Hervit, who is orthodontist from Paris, would like to result the program and develop a special oral device. This device is a mandible advanced device with tone bead, and its mechanism is same as the oral myofunctional therapy, so we call it passive myofunctional therapy. Even the young kid can wear it by themselves every night. Let's see the result of a passive myofunctional therapy. The PSG data showed the total 29 patients, their AHI hypopnea index and the percentage of awake have a significant improvement after 6 months treatment. Due to the poor compliance of oral myofunctional therapy group, so there is no 1 year's PSG data in this group, but the passive myofunctional therapy have a not bad compliance, so we have a long-term outcome result of this group. The PSG data showed the AHI hypopnea index, snowing index, and sleep latency have a significant improvement after half year and 1 year treatment of oral device. After 1 year treatment with passive myofunctional therapy, then patients stop to wear the oral device for 1 year. And then we do the PSG study again. And the results show the AHI hypopnea index and the snowing index deteriorated significantly again without passive myofunctional therapy. We also compare the PSG study between the treatment with myofunctional therapy and the passive myofunctional therapy. The PSG results showed the AHI in sleep, hypopnea index, hypopnea count, and the percentage of awake have a more improvement in passive myofunctional therapy group. We also compare the cephalometric study between the two groups. In passive myofunctional therapy, the cephalometric data showed significantly improved the width of the airway at the level of the nasopharynx. In oral myofunctional therapy, who have a good compliance also have showed significantly improvement in the same level. It means the passive myofunctional therapy have the same mechanism as myofunctional therapy in the treatment of a pediatric OSA. Recently, we published another article and it showed the passive myofunctional therapy not only improve PSG and cephalometric, but also the quality of life have a significant improvement. From previous study and our long-term following study, finally, I want to make the conclusion. The mouth breathing during sleep leads to abnormal orofacial growth. The abnormal orofacial growth is involved in abnormal breathing during sleep. The treatment of a pediatric OSA must deal with orofacial growth and mouth breathing during sleep. The oral myofunctional therapy is a way to reach this goal, and it is a non-invasive treatment of a pediatric sleep disorder breathing. But the age and the compliance are the important limitation of oral myofunctional therapy. Finally, I would like to say oral myofunctional therapy and the passive myofunctional therapy could serve as a adjuvant treatment to pediatric OSA. Thank you for your attention.
Thanks a lot for Professor Huang's talk. It is really very impressive. As we see here in the chat box, there are so many questions. However, Professor Huang is occupied right now, so she cannot join our QA right now. But there is her email in the chat box, and also we're going to, the committee will transfer your question to Professor Huang. She will be very happy to answer your question. So since time is up, so we need to close this session now. Thank you for your attention.
Thank you for Professor Meizhi Zheng for the moderation. Next, we're going into the next section of the Satellite Symposium, which is the C1 Pediatric Critical Care Medicine part. And this part will be moderated by myself, which is working in the National Taiwan University Children's Hospital in the Pediatric Pulmonary and Critical Care Medicine Department. And also from Thailand, Professor Ruchipat Samramse Rajit, which is the professor of pediatrics working in the Chulalongkorn University in Thailand, Bangkok, Thailand. But because of his clinical duty, he will not be able to show online right now. So I will continue to do the moderation for the next talk. So next, we're going to welcome Professor Enting Wu, which is actually a colleague from my hospital. She is working in the pediatric intensive care unit, and she's trained at our hospital, and she went to the Children's Hospital of Philadelphia in the United States for advanced cardiac care, and also the National Cardiovascular Center in Osaka and Okayama University Hospital. And after the training, she come back to our hospital and devoted in ICU care, ECMO, and hemodynamics, and also resuscitation. So next, her talk is going to talk about pediatric ECMO. Please start.
Ladies and gentlemen, welcome to this meeting. I'm Dr. Enting Wu from National Taiwan University Children's Hospital. I'm the director of PQ. Today my topic is pediatric ECMO. I have no disclosure. Because the spectrum of the topic is very broad, so I have to focus more on ELSA reports. And the second, I would like to introduce ECPR and discuss the guidelines and outcomes. And I will focus more on long-term outcomes, and I will let Finally, I will discuss the ECMO use in COVID-19 pandemic era. We couldn't talk about pediatric ECMO without mentioning Dr. Robert Bartlett. He's the professor of general surgery in Ann Arbor, Michigan University Hospital. Early in 1970s and 80s, he started a prospective randomized trial to use ECMO to treat neonatal respiratory failure. This famous article is published in 1985 in Pediatrics. In this trial, they tried to divide the patients with neonatal severe respiratory failure who is unresponsive to conventional therapy. They enrolled 14 patients, 2 not in randomized trial, and 11 patients underwent ECMO support and all survived. But 1 patient received conventional therapy only, and this patient died. And actually, this kind of prospective randomized trial is not only a medical trial, it's also an ethical dilemma. Actually, early in 1975, baby Esperanza's story inspired Professor Bartlett. Born in 1975, this newborn was not cyanotic, a blue baby, whose cast was from a lack of oxygen in her blood as her lungs were not fully developed. In no uncertain terms, she was dying in a last-ditch effort. Dr. Bartlett wheeled in an ECMO machine just 20 hours old. The child was hooked to it for 6 days, allowing her lungs to develop and recover until her tiny body could survive on its own. The newborn's mother fled from the hospital, believing her baby would not survive. So the hospital nurses took charge, naming the girl Esperanza. That means hope. Today, Lady Esperanza is 44 years old, a mother of 3 kids, and she has the chance to take a photo with Professor Bartlett, who saved her life 44 years ago. Nowadays, the ECOS indications in pediatric or neonatal groups includes oxygen index greater than 40, PaO2 to FiO2 ratio less than 60, and the pH less than 7.25, shock state, air difference greater than 500 millimeter mercury, and the plateau airway pressure greater than 30 centimeter H2O, and the contraindications include lethal chromosomal or other anomaly, poor predicted neurological outcome, irreversible brain damage, uncontrolled bleeding, ICH greater than grade 3, and advanced multi-organ failure. And if the baby is put on ventilator for more than 2 weeks, and the body weight is too small and the gestation age is too young. Let's look at the ELSO registry report. This organization reports the worldwide ECMO results and published just this year in April. They characterize the patients into 9 categories. For pediatric patients, in neonatal pulmonary support, the result is the best. The survival rate can reach above 73%. And for neonatal cardiac, the survival rate is 43%. For neonatal ECPI is 42%. And for pediatric patients, for pulmonary support, the survival rate is 60%. For cardiac is 43%. For ECPI is 42%. The result survival rate is much better than in the adult group. This figure shows the survival rate of each group by year. And here we can see the best is the neonatal respiratory support. And the second is pediatric respiratory support, and third is pediatric cardiac support. These three ECMO support, the survival rate can reach above 55%. But the others, the survival rate is not so good, maybe around 40 to 45% only. However, the ECMO for neonatal respiratory support, the use is decreasing from 80% in 1990 to 2017 to only 10%, less than 10% of the cases. The reason for decreasing ECMO use for neonatal pulmonary disease are the invention of inhaled nitric oxide and high-frequency oscillatory ventilator, surfactant therapy, and also more NICU can provide better neonatal critical care. But in some severe form of certain disease, the percentage of ECMO support remain unchanged. For example, it's congenital diaphragmatic hernia and also PPHN, pulmonary hypertension. And also registry data also show the outcome of neonatal respiratory failure requiring ECMO support depends upon the underlying diagnosis. Neonates with meconic aspiration syndrome, PPHN, and RDS continue to have good survival. On the other hand, neonates with more complex other primary diagnosis and those with congenital diaphragmatic hernia have lower survival rates due to the disease severity. Although the overall survival rate for sepsis is reported to 72 since 2012, it has been decreased to 45%. Then we move to the AHA guidelines for cardiopulmonary resuscitation and emergency cardiovascular care. In these guidelines published last year, CPR has been considered for pediatric patients with cardiac diagnosis who have INCAR in the settings with existing ECMO protocols, expertise, and equipment. And the evidence originated from Get with the Guidelines Resuscitation Registry. The retrospective review since 2000 and 2000 to 2008 of pediatric patients with INCAR after cardiac surgery, use of eCPR was associated with higher rates of survival to hospital discharge and higher favorable neurological outcome than conventional CPR. However, there is insufficient evidence to suggest for or against the use of eCPR for pediatric patients experiencing OCA or pediatric patients with non-cardiac disease experiencing INCAR refractory to the conventional CPR. That is quite different from adult patients. Also, registry also published the guideline this year for pediatric eCPR, and they suggest for patient selection, cardiac disease, several parameters with limited effectiveness of conventional CPR. When we consider limited stroke volume with chest compression, limited effective pulmonary blood flow and oxygenation with compressions, and a limited cerebral perfusion, we can consider institution of ECMO during CPR. For patients without primary cardiac disease, also limited data reported outcomes associated with eCPR universally worse than in patients with cardiac disease. Finally, for unwitness of collapse, they have poor outcome and should be considered a relative contraindication for eCPR. This guideline also describes the decision and the timing of eCPR. The best candidate of eCPR should receive cardiopulmonary resuscitation within 1 minute after cardiac arrest. Then high effective CPR was provided and the airway established. Within 5 to 10 minutes, the rescuer should decide to call for eCPR call for ECMO team. And maybe we spend 5 minutes to launch the ECPR team and prepare equipment and call a blood bank to prepare the blood component to fill the circuit. And we need 15 to 20 minutes to do a cannulation procedure and start the pump flow. The target duration of ECPR should be achieved within 30 to 40 minutes to have better neurological outcome. Finally, the guidelines establish the ECPR decision pathways or flow diagrams that indicate who, what, and when to launch ECPR and indicate where the cannulation will be undertaken and circuit started like this. In the literature, there are so many publications talking about the ECPR result. The survival is around 45 to 60%. Our hospital once published our data in 2008 by Professor Chen. That article is published in Lancet, now become the guideline of HA. We also report our pediatric experience in resuscitation. In this article, we collect 11 years experience, and we have 54 patients. For ECPR, we use VA ECMO cannulation. For patients less than 20 kilograms, we explore the neck to find right common carotid artery and the right internal jugular vein for cannulation. For patients with bigger size, we use femoral artery and vein, and sometimes we put reperfusion catheter to ensure the distal perfusion. And for patients just after cardiac surgery, we open the chest and put our cannula directly into right atrium and ascending aorta. During the study period, we have 54 ECPR events, and 17 patients died on ECMO. 37 patients successfully went from ECMO. We have 12 ICU deaths, 25 patients survived to discharge, and among them, 21 have good neurological outcome. So the overall survival rate was 46%, and 84% patient has good neurological outcome. As for CPR duration, the CPR duration in survivors are 39 and 17 minutes. And for non-survivors, it is longer, but not reach statistical significance. And we found that patients with pure cardiac disease of cardiac arrest had a survival rate similar to patients with non-cardiac causes. That means we did not pre-exclude non-cardiac patients into ECPR program. Higher pre-ECPR lactate levels and the presence of post-ECPR renal failure were associated with increased mortality. This is our learning curve. We divided our study period into 3 periods: early periods, middle periods, and the late periods. That means the mature stage. We found that the duration of CPR shortened gradually, and the survival rate improved a lot. In the early period, we don't have any patient survive from ECPR, but in late period, our survival rate can be above 50%. Through practice, regular briefing, group meeting, and we provide 24-hour, 7-day CVS surgeon service and ICU care, we can achieve this outcome. Here we proceed to check the long-term outcomes and the neurological outcome. There's a 17-year single institution experience describe the clinical outcome of neonatal and pediatric ECMO. The most common patient-related complications include intracranial hemorrhage, infection, and the seizures. And here we can see that in neonatal group, ICH is more prevalent than pediatric group. However, for infections, pediatric group have more infection episodes than in neonatal group. Is the high incidence of ICH in neonatal via ECMO related to neck vessel damage. In the procedure, we insert the venous cannula into right internal jugular vein, but sometimes there is already a CVC here, so the venous return is very poor. And also we insert the arterial cannula inside the right common carotid artery and ligate the distal parts, so brain perfusion is diminished. In a large-scale study from ELSO registry, the VA ECMO in pediatric patients, most of them receive neck cannulation, and the overall neurological injury was 21%. If we check the neurological prevalence of neurological injury by age, we can see that in neonatal group, the neurological injury reached above 22%. And also, from categorized from cannulation site, we can see that carotid artery cannulation carries the highest neurological injury rate. It's 23%, and for aorta cannulation is 13%, and for femoral artery it's 15%. Further investigation by multivariate logistic regression model showed that carotid artery cannulation for via ECMO is associated with statistically significant increased odds of neurological injury. Therefore, we emphasize the needs of vigilant neurological monitoring of patients supported with ECMO, especially those cannulated through the carotid artery. Interventions that may limit ECMO support time should be strongly considered early in patients' ECMO course. How about the long-term functional status after ECMO? In a study, enrolled 514 patients from 8 hospitals. 40 patients had cardiac ECMO and 14 underwent ECPR. They issued questionnaire and arranged long-term follow-up study, and they found 17% of patients had good functional status, and 22% of the patients have mildly abnormal functional status. So most of the patients after ECMO support, they can lead a nearly normal life, just as usual people. How about the ECMO utilization in the COVID-19 pandemic? There's a dashboard from ELSO registry telling us that there has been 8,710 patients put on ECMO. Most of them were in North America, and the patient from Asian Pacific is only 122. By 90 days from ECMO, 48% patients died in the hospital, and more than 30% patients discharged from hospital. And the role of ECMO support in COVID-19 patients is still evolving. Patients with COVID-19 supported with ECMO initially exhibited similar mortality with the patient without COVID-19 infection. When conventional capacity existed, indications and contraindications for ECMO should remain unchanged. However, as hospital system capacity diminished, when more and more infected cases require ECMO, contraindications for ECMO use should become more stringent based on characteristics associated with increased mortality and long-run duration. There's no data to recommend deviation from conventional ECMO practice. For example, blood product transfusion thresholds, tracheostomy, endotracheal extubation, rehabilitation, cannulation configuration, or ventilator management. The most important is that protect our members. Full personal protection equipment is more important, sometimes more important than patient care. Potential discontinuation of ECMO in a setting of perceived fertility should be clearly discussed with patients and their surrogate decision makers. That is, in this kind of patient, maybe palliative care is more suitable rather than the utilization of ECMO. Rarely, patients with COVID-19 infection require ECMO support for severe ARDS, myocarditis, or multisystemic inflammatory disease. The selection criteria and the management are not different from other patients. There's a report collecting only 7 patients from Europe also, from 3 countries. 3 patients died from ICH, cerebral infarct, and pulmonary embolism. We concluded that ECLS is life-saving in severe cardiorespiratory failure, unresponsive to conventional treatment, especially in neonatal respiratory failure and ECPR. Most of the ECMO graduates have good long-term survival and acceptable life quality. With limited medical resources and the highly contagious nature of COVID-19 infection, entry criteria of ECMO should be more cautious for both appropriate allocation of resources as well as ensuring protection of healthcare personnel. As a pioneer of ECMO, Professor Ballet is still very active. In a recent review article in Critical Care Medicine as a 15th anniversary article entitled as Cardiopulmonary Resuscitation and Vascular Therapy, Dr. Ballet made a personal view. He stated that some ECMO center could establish via ECMO for cardiac failure or arrest in 5 minutes. The best of these was the National University Hospital in Taipei, Taiwan, under the direction of Dr. Wen-J. Ko. This remarkable experience in adult CPR continued today under the direction of Dr. Yixiang Chen. Dr. Ko now is the mayor of Taipei. These words encourage us to make more efforts to keep these excellent results, and also we want to provide this excellent ECMO care also for pediatric patients. Thank you for attention.
Thank you, Professor En-Ting Wu, for her nice talk and the presentation talking about ECMO. If you have any questions, please leave in the chat room and we will send her the question for her reply. Because she's on clinical duty today and cannot become here live for QA. So the next section, we are going to welcome Professor Yixuan Qiu for the moderation. Thank you.
Dear colleagues, welcome to this Pediatric Critical Care Medicine Satellite Symposium. I am Dr. Yixuan Qiu from the Department of Pediatrics at Kaohsiung Veteran General Hospital, Taiwan. My co-chair is Professor Alfred Tan from Hong Kong. So it's my great honor to introduce today's distinguished speaker, the Professor Frank Lu. Professor Lu is the director of the Division of Pediatric Pulmonology and Critical Care Medicine, Department of Pediatrics from National Taiwan University Children's Hospital. His expertise and interests include pediatric critical care medicine, pediatric pulmonology, pediatric mechanical ventilation and chronic respiratory support, and also pediatric ethics and the child protection medical care, and also the child-friendly health care and the pediatric palliative care. So today he will give us a talk of palliative care in pediatric pulmonology and the critical care. So let's welcome Professor Lu, please.
Ladies and gentlemen, we're going to talk about palliative care in pediatric pulmonology and critical care. I am Dr. Frank Lu from National Taiwan University Children's Hospital. WHO in 2018 has talked about palliative care definition as prevention and relief of suffering of adult and pediatric patients and their families facing the problems associated with life-threatening illness. These problems include physical, psychological, social, and spiritual suffering of patients and their family. And this definition is actually one of my favorite, which talks about pediatric palliative care is achieved through active and compassionate therapies intended to comfort and support the child as well as family members. So when we're talking about palliative care in PICU, actually it focuses on very important aspects. This include enhancing quality of life, minimizing suffering, optimizing function, and supporting families in complex decision-making and communication. And so to make that happen, actually, ICU care models will divide it in three. The first one is integrated model, which all ICU clinicians will work as a primary provider of the palliative care. The second one is the palliative care team as a consultant model and to work together with the ICU. And the third one is the mixed model, which combines the both. So there are a couple of barriers to effective pediatric palliative care, which we also need to mention and be aware of during ICU care. The first one is about therapeutic autism. We always think that there's more to do and we should never give up, and that actually is a myth. The second part is about whether we can have concurrent curated treatment. So nowadays, we all have a consensus that any appropriate and adequate treatment should be given to all the patients. And the third one is about training, because we sometimes lack adequate training of professionals for the children. So this is sometimes a very important barrier. And the last one is about the burden of grief, which the patient and the family, even professionals, will face during their care of the palliative care children. So the models of care actually are three of them. And the most common, sometimes still there, is exclusively domains of the curative and palliative care, which means after the curative care doesn't work, and then shift to palliative care. The second part is integrative care, which we start the curative and palliative care all at the beginning of the high-risk diagnosis, and then it depends on the weight of the condition and clinical course, and we change their ratio. The last one, which I think is the most important one, is the concurrent components of complementary care involved into the palliative care in ICU. So during the diagnosis, the cure-seeking care, life-extending care, comfort and quality of life maximizing care, and family supportive care all needs to be provided. And also when the death is more close to the end of life care and bereavement care also has to be supported. So usually when we talk about pediatric palliative care, the main focus is about life-threatening illness. So sometimes the conditions may be curative, but there will be a high risk, so maybe fail. Sometimes there are long-term treatments like ventilators or deteriorating muscle powers, and sometimes they're exclusively palliative diseases like trisomy 13, or sometimes very severe non-progressive disability like hypoxic brain injury or extreme prematurities. All have to think about palliative care in the suitable time and duration. So there are a couple of distinguished features of the pediatric palliative care. So usually the case number are less, so the experience goes lower. And there's also many different diseases with rare diseases and ensure clinical course, and whether we want to provide the therapy or treatments or not, and the growth and development effect during the palliative care is also a very important factor that has to be noted. The influence to the family and the medical decision made by the adults all have a big influence during palliative care, and also when to talk about a child's death and when to introduce the pediatric palliative care is also very important, and how to support them with their needs and with a creative way of supporting them to fulfill their needs is also has to be think of. So there are 8 components of the pediatric palliative care: physical, psychological, social, emotional, spiritual, are all common with adults, but growth and developmental, educational, and play has to be also seen in the children. So there are a couple of medical decision making, which is the challenging point, especially in the ICU, which talk about the consents. And if the conflict happens, how to make a consensus is critical and important. So we usually will follow the ethical principles and see the best interest, sanctity of life, quality of life, or relational potentials has to be think about during this decision making. So then we will go into an advanced care planning, which we call ACP. And this we want to let the child and family understand the possible clinical course and have more time to think about their consideration, thoughts, values, and views, and their expectation and wishes to make it more reasonable and have a consensus together with the medical team is important. So we'll talk about life-sustaining treatment, abbreviated as LST. So there's actually lots of them in the ICU talking about whether we want to do resuscitation, ECMO, ventilators, intubation, inotropic agent, antibiotics, dialysis, or blood transfusion, or even whether we want to give fluids or diet. These are all important options. All has to be think through with all the benefits and risks. And we can use 4 models to deal with it with limitation, withhold, withdrawal, and time-limited trial. So actually in Taiwan, we have a pediatric palliative hospice care reference manual, which was discussed with the experts in Taiwan in 2019. We have a suggested decision-making based on the therapeutic predictions. So if we think that the treatment or therapy is not effective, actually we suggest to stop it. So if we haven't started yet, we will withhold. If we already started, then we will suggest to withdraw. But if the therapeutic predictions and outcomes are good and effective, then we suggest to perform and continue. So what about in between when we're unsure? Then we suggest to do a time-limited trial. With a limited amount of time, we try the therapy and to make sure whether it's effective or not. And this is really helpful when we have some challenging making the decisions. So this is a study in pediatric critical care medicine in 2016, which talking about limiting and withdrawal life supports in the PICU. They collected 17 PICUs in the States, United States America, and they see their characteristics. So they can see with 10,000 patients admitting into the PICU, they have 275 patients that died in the ICU. So one part discussed with the limitation or withdrawal, one part did not discuss. So these two groups have a comparison. And we can see the model of death, especially of failed resuscitation, have more in the did not discuss groups. And this is an important part. And the withdrawal of support is actually more in the discussion. So this is a critical, important part. And especially the length of stay is shorter in the discussed group. So this is very important for the ICU resources to be effectively utilized. And in our ICU, we have a study published in 2021 this year. We don't have time to talk about it, but there's a very nice comparison model which has collected many important published papers talking about this issue. But in our country, actually, because we have a pediatric palliative care team, and also we have a Hospice Care Act in the law. So this actually help us with using more the limitation and withdrawal, almost more than 85% when the child died. So this is very helpful for better care, and which we want to think about. So actually, among the medical decisions, withdrawal is something we want to think about. So if there's brainstem death, or sometimes we persistent vegetative state, or no chest, no purpose, intolerant situations, we'll think about whether we want to do the withdrawal. And there's a couple ways, and there's with the different modalities, we want to think about how we'll do the withdrawal. And we have to make a very deep discussion together with the family, talking about the benefit and risks, and discuss each of the options and to see their values and views and how they think about the part. And we have to make sure that no suffering with good symptomatic control will be done through the whole process. And we can set up a consensus with the ACP, and then we can have a nice care plan for the child and the family. Withdrawal mechanical ventilation is actually the most critical one and is most concerned. So there are two ways: terminal extubation and weaning. And terminal weaning is actually a part which we lower the ventilator settings slowly, and then we can also increase the support to make sure there's no suffering. So there are a couple of practical issues we need to think about. So where the locations, the timing, whether what people attend, and are there any ritual or cultural issues, and how we're going to deal with the after death plans. These are using morphine as sedatives. This is very crucial and important. So there's two important concepts. The first one is double effect. The second one is about the research also confirmed that using this medication does not fasten the death process. So usually for the double effect, we know that morphine can cause less suffering and better support for the pain and for the respiratory distress. But at the same time, if you use it at very high dose, they will cause it to stop the breathing. So this is the risk part. So that's why we call it double effect. So if we know the act is good, morally good or neutral, and we're going to do the good thing, so proportionally, the good should be outweigh the bad. And after these five conditions are fulfilled, actually we can use the morphine as sedative as a good supportive care for the patients. So this is based actually on no suffering concept. So the intention of the medical team is the most important thing. So usually we will start from the low dose and titrate to use minimal required medication for this kind of support. But we don't use a mega dose to get to stop the breathing. And also psychological, social, and spiritual support is very important. And it will be many different ages for the children, and we all have to think about how to do that kind of care. And for the children to talk about death, the most crucial and important point actually is to let the child take the lead and start the initial step. When they want to talk about this issue, we professionals and the family can all share about this kind of opinions, and we can discuss more further and deeply. But if they don't want to talk about it, it's not necessary that you need to let them understand. So the goal is to support the child's own need, which is very, very important. So there's storybooks, there are many different kinds of them that they actually can help the child to understand and to go through this process. And we also can have many different kinds of ways to make commemorate and memento, like ceremonies, rituals, support groups, and we can create very beautiful memories and life experiences and let the child express more of themselves and their concern, which is very important. There's also many complementary therapies that we can also help. So like Make-A-Wish Foundation, I think it's an international foundation which really can help the child to fulfill one especially important wish, and they can help and help them go through this part and to make a very interesting and enjoying life. So we talk about the storybooks with storytelling. There's childlike service, play therapy, creative art therapy, like many art, music, dance, drama. There's many different ways of supporting the child and the family. So using this kind of complementary therapies actually will help the patients to go through a more non-suffering and increasing life quality way of process. So the care and support for the caregiver is very, very important. It's very challenging time for them. So listening is always very critical and an important way to support. And we have to know that this is a huge sadness and stress for the parents, and it's a lifelong process they need to deal with. And this kind of support usually will make a big help. And also for the medical professionals that maybe sometimes has cared for a long time. So we have to make sure that we've done good enough and the best we can. And through an emotion model, we can help each other with a good supportive environment. Sometimes we need to mellow out and relax and observe ourselves to the needness of this part with a good team collaboration and support, and identify the issue and go on to do it with great support. Then we can really support our child and family. The last part is a quotation from Victoria Miller, which is a foundation of Trisomy 18. And she said, every child, no matter how fragile their life or brief their days, forever changes our world. Thank you for the attention.
Thank you, Frank, for having given us a very concise and clear review of palliative care in the PICU. I think that's something we really find ourselves difficult, and I think it's something that yet very important, especially to the family and the child, also sometimes to us as PICU staff. In my 10 years experience of being in charge of a pediatric intensive care service, often I have found this a very sort of challenging situation. Maybe I have a few questions for you, Frank. Number one, how do you deal with difference in opinion among the staff? Okay, and I think I find that is something that we have to deal with because the patient may die, but then we still have to cooperate with our staff and we have to maintain good relationship.
Yeah, thank you, Alfred, for the we're all friends, but thank you for the question. I think having a consensus between the medical professionals and the staff all together is very, very crucial and important. And because not everybody has the same thinking of life and death and when is going to be the terminal stage, and everybody has a different view of this part. And I think sometimes it's very different when we collaborate with different colleagues. So some will accept it, some will say, oh, it's too early. So there was one attending actually told me, oh, Frank, you're too early. I'll let you know when the time is there. And so it will be challenging, especially during the team, and how can we make the consensus. So actually we will have to, because in our unit, we actually use together our palliative care team. So sometimes when I'm not in charge of the ICU, sometimes also help with the palliative care at that time. So we work together as a team. So we have to have medical professional team meetings to talk about what we are concerned of and what we think will be a critical point. And we'll actually will let the attending, his primary care physician, to talk more about that problem, because sometimes you have to express it out, because sometimes nobody wants to mention the issue and think that if you don't talk it'll be fine. It's maybe somehow will go away, but it doesn't. So this is something we have to raise the question, and especially in pediatric palliative care, they're talking about early involvement and timely palliative care. So sometimes with a high risk diagnosis or life-threatening illness condition happens, we will like to have earlier discussion, especially for the family and children, because sometimes it's too late to do anything and you just do it through the CPR, and unfortunately the child and the family is devastated, and even the team is devastated sometimes in this part. So I think earlier discussion is a crucial part. So sometimes when we talk more and more with the team together, actually slowly you will have a consensus which you think will be more acceptable across the team. And this consensus actually will improve and evolve sometimes after we have more discussions and more consensus. Yes, thank you for this excellent question. Also our challenge too.
Always.
Yeah.
Especially when you have very enthusiastic colleagues who want to try our very best to actually save lives.
Yes, yes.
Sometimes we have to actually balance out. The nurses make a lot of difference too.
Oh, yes.
Colleagues.
I think the nurse has a more sense than our physicians, actually. So sometimes the nurse will come to me and say, oh, Dr. Lu, I think we should talk about palliative care right now. And I say, what about the attending? He's like, oh, well, they're not they're not really involved. But sometimes even the family started to ask before our attendings really notified that this is an issue and question. So I think it's more time to let them know that early discussion actually is not going to put a death to the child. Actually, it's more preparation and more support for the family is very important.
I agree with you that more preparation, more discussion in a sort of relatively earlier stage actually helps to make it much smoother.
Yes. So I'll just talk a little bit because if we have more time, actually we're talking about complementary therapies and more time, quality time for the family to be together. Actually, is a very important and crucial area because, well, in the times long time ago, like 10 or 20 years before, usually would die in the ICU. But now, because of the palliative care has more recognition, we actually sometimes we talk and sometimes we want them to decide whether they really want to come into the critical care unit to perform this kind of challenge and whether it's worth it, whether it's suffering, and these part all we have to more think about it. It's very important.
Yes, agree.
Okay, I think sorry, I'm the host today, so I think the time is up. And
Yes.
thank you, Alfred, and thank you, Yishen Cho, Professor, for this nice section. Thank you.
Thank you.
all.
Thank
Okay,
you,
thank
Frank,
you.
for
Bye.
that good
Okay.
discussion. Thank you.
Thank you, Alfred. Thank you. Thank you,
Thank you.
Yishen Cho.
Bye.
Okay, bye-bye.
Bye-bye.
Okay, so next we'll go into the lunch break. Sorry, a little bit late, but we will share and come back at 12:50 and delay of 20 minutes. So there will be a lunch symposium there in the main room. And also for the TPPCC members, there's a member meeting in the room B. So enjoy your lunch. Thank you. In the meeting room, we have a main room, which is room A, where all the plenary lectures are. We also have a room B that will show the exciting online symposium, e-posters, and nice video shows. For going into room B, go to the participants breakout section that you can find in the virtual meeting conference.
Presenting the new SLE 6000 infant ventilator. The SLE 6000 is an infant ventilator intended for patients ranging between extremely low birth weight or babies up to 30 kilograms. Using our renowned valveless technology, the SLE 6000 can offer conventional ventilation modes, including volume-targeted ventilation, and non-invasive modes of ventilation with flow adaptation technology. This includes nasal CPAP, NIPPV, triggered NIPPV, and nasal high-frequency oscillation modes, and high-flow oxygen therapy. Using the same breathing circuit, a range of modes can be applied to cater for each therapy type, including powerful high-frequency oscillation, both invasively and non-invasively, with volume-targeted oscillation ventilation now available. Using a high-accuracy hot-wire anemometry flow sensor, it enables reliable measurements of tidal flow and volume, and is important in volume-targeted ventilation mode, available in both conventional modes and high-frequency oscillation. The SLE 6000 includes options for Massimo set SpO2 monitoring and end-tidal CO2 monitoring using Medtronic's MicroStream technology. Using Oxygenie, the new automatic closed-loop oxygen control algorithm, SpO2 remains within the specified range for longer. The user interface has been designed for ease of use, with minimal menus and greater functionality, including the ability to link to an external monitor or projector. Data can be transmitted to a hospital patient data management system or to a patient monitor via the serial output, with the ability to store up to 14 days of patient trend data, as well as the alarm and events log. This can be interrogated in real time using the monitor or exported from the USB port and analysed offline using the SLE Viewer application. The SLE 6000 can work from mains power as well as an external battery, and in the event of mains supply failure, the internal backup cells can last in excess of 3 hours. Purchasing and upgrading the SLE 6000 is easy because of its modular architecture, with licenses for additional features purchased at any time and easily installed via a USB port. The SLE 6000, providing medical professionals and patients with a simpler, safer, and more effective system.
In the meeting room, we have a main room, which is room A, where all the plenary lectures are. We also have a room B that will show the exciting online symposium, e-posters, and nice video shows. For going to room B, go to the participants breakout section that you can find in the virtual meeting conference.
And enjoy our lunch.
Okay, good afternoon, I'm the host of this afternoon's program. And before it, I would like to invite our TPPCC members to join the room B for the annual member meeting. To join the room B, please click the participant, and you can see the breakout session. And via the breakout session, and you can see the room B. Then please just log into the room B, and we will start our lunch symposium this afternoon. And for 在此代表儿童胸腔医学会的理事长和秘书长邀请儿胸的会员到讨论室 B 参加会员大会。那要进入讨论室 B， 请在参加者上方按一下分组讨论。那按分组讨论之后，就会出现讨论室 B。那如果有不清楚的地方，也可以在我们的聊天室看到有这个路径的教学。那请儿胸的会员可以到讨论室 B 参加会员大会。Okay, let's be back to our lunch symposium, and I would like to introduce our moderator, Professor Daniel Ni and Daniel Wu, and Professor Zheng Guangliu, and Professor Mahashi Babu, and Ramamersi. And Professor Daniel and Maharusi has a video to share with us. Please start.
Good afternoon, everybody. I would like to thank the organizers for inviting me to be one of the moderators for this very interesting session. Flexible bronchoscopy is relatively a new tool in the last 40 years, and it has come a long way since then. To start off, it was only a diagnostic tool, but as time went by, we now have more and more therapeutic uses for the same. And this is changing as we speak. Professor Wenju Sung is probably the most accomplished in this area from Asia, and I'm so glad that he is addressing us today. We are all waiting to hear from him, and thanks very much for this opportunity. Over to Professor Sung for his lecture. Thank you.
Good afternoon, ladies and gentlemen. Welcome to the lunch symposium of this Congress. It's a great pleasure to introduce the next speaker, Professor Sung Wenju. Professor Sung is currently the Associate Dean of the Department of Pediatric Pulmonology and Critical Care Medicine in the Children's Hospital, China Medical University in Taichung. Professor Sung is also president of Taiwan Society of Pediatric Pulmonology from 2013 to 2016. He's also the standing director of the Taiwan Pediatric Association from 2014 to 2020. He's pioneered the work of interventional bronchoscopy in Taiwan and globally. So it's in fact very appropriate and fitting for him to talk about the respiratory support during pediatric flexible bronchoscopy intervention. So without further ado, I invite Professor Sung to deliver this talk. Thank you, Professor Sung.
I'm very pleasure and very honored to be invited to give this speech. The topic of this speech is respiratory support during the pediatric flexible bronchoscopy intervention. This picture is very unique because it shows how we do the interventional bronchoscopy with our unique ventilation support. There's no any conflict of this speech. This outline, personally, I will show some critical case. This case, one side, no one bronchoscopy. This case, the other case, show you can see from the 3D CT, you can show the central airway is okay, but bilateral main bronchus, right side is stenosis and the left side is severe malacia, 100% malacia. His right lung have no any blood flow perfusion, so he depend left lung to survival. But left main bronchus is complete malacia, so he cannot win for hospital ventilation support for more than 6 months in the other hospital. Therefore, he transferred to our center. When he arrived my hospital, from the X-ray, we can see the right chest is almost by out, and he on endotracheal tube with high setting, 100% oxygen with PIP 25/20. That's very high setting. How we do this case? We just extubate this case and put a stent inside, and when just like this, and he immediately removes the endotracheal tube. And 10 days later, he go back home with no any respiratory support, and both parents is very happy. This is the other case, 3.5 kilogram with congenital heart disease and after cardiac surgery, but cannot extubate with high setting, 100% oxygen, and pressure 35/10 centimeter water. And he showed dyspnea and severe bradycardia, less than 50 per minute, almost going to die. We checked the endoscope because chest film and cannot show anything. But we do the bronchoscopy, you can see in the middle trachea, they have severe airway obstruction, only tiny movement here. So that's why he needs so high ventilator safety, but still not okay. CO2 more than 100. Shall we? What we will do next? We already have intubation with high safety. In such case, we just remove the endotracheal tube, remove the mechanical ventilator, and we do in our way. Just like this. This case have no any artificial airway. We do the stenosis. You can see over minus. Just for the procedure.
Severe stenosis, we use the laser to treat. The vital sign almost stable. Throughout the whole course, the vital sign quite stable.
After laser, usually after laser, we usually do the
The video show how we do the trachea balloon dilatation, the procedure, of the whole procedure.
patient.
We insert the balloon catheter and adjust the location. We inflate the balloon to dilate the stenotic area. We can also see from the monitor the vital sign is quite stable. Just no any artificial airway or ventilator. We just use our source ventilation.
So in difficult case or risky case, doing bronchoscopy, they have some problem. All these cases already have compromised airway and compromised cardiopulmonary status. Frequently combine both situations. For make diagnosis or even for doing the therapeutic intervention, patient should be instrumentation of the bronchoscopy should be put in the airway. That will more block the airway movement. And also, after sedation, will decrease the patient's ventilation ability. This all compromise the patient's ventilation and go into hypoxia. That's the most problem. Why in small or risky patient, the bronchoscopy may be high risky, may be more dangerous. Okay, the current problem in current research support. This article is very famous. My ATS in the 2015, they show the flexible airway endoscopy in pediatrics, the gold standard. In this article, the table 4, they show indication, diagnosis, and the therapeutic. All we know the diagnosis of bronchoscopy is quite easy because it takes only a couple minutes and finish. But in the therapeutic, sometimes maybe take more time or even more than 1 hour or even 2 hours. So that's more difficult. Therefore, the therapeutic item only few for tests for control, breathing, for bronchoscopy investigation, for direct airway stenosis. But to us, to our team, that's quite a limit procedure. Why? We don't know. Maybe they have some difficulty. This is a GIAS article published in 2015. The flexible bronchoscopy for critical ear patients, assistant review. Their total have 43 reference. We are honest because we have 3 articles in this article reference. All these 3 articles is talking about the complicated intervention. The other most are doing only BAL for doing biopsy. That's more simple. All this picture we taken from the Google. We can see the current practical research support is either by mask or by laryngeal mask airway or by endotracheal tube. They have some problem about this research support because all this endoscope should be going to the artificial device. And for example, this is a tubing. The endoscope only pass over the end hole, distal hole of the artificial airway. Then we can do the diagnosis. Otherwise, nothing can do. This is the key point. For example, this picture shows the traditional method this is a patient's airway. For example, chicken. We put an artificial airway inside. This may be a mask or an endotracheal tube. And then we put an endoscope for make diagnosis or even for doing therapy. The scope should be small, otherwise it cannot go into the artificial airway. And they have friction resistance between the artificial airway and the endoscope because space is quite narrow. If we use the instrument through the inner channel of the endoscope, the inner channel, the instrument also small. How about this space? This space is for the breathing ventilation pathway. This pathway is small. And if we now use the artificial airway device, like this, there's no any artificial device, so we can put a more bigger endoscopy, and therefore we can put in the other instrument or the second instrument, and we still get more large lumen for the ventilation flow. So in this way, the patient ventilation is more easy, is more better than a traditional use artificial airway. This kind of setting is our design, our principle. Use no any artificial airway. This is just a cartoon. For example, patient have upper airway and lower airway lesion. when you use the endotracheal tube, the endoscope is difficult going to the lumen, and only the distal airway lumen lesion can be detected. Also, this laryngeal muscle airway, the similar condition. Those upper airway and the larynx lesion, and only the trachea bronchus lesion can be detected. This mask, although it's simple, but still difficulty for going to the mask hole and then going to the nose. This kind of setting have a lot of limitation for the endoscopic manipulation, and maybe need possible ventilation support by the mechanical ventilator or some device. So in this setting, the diagnosis and the treatment is quite limited. If there is no any artificial airway, the endoscopy direct go into the nose, and we can detect and inspection and doing therapy in the whole upper airway and the lower airway. This kind of ventilation is more easy and simple, and increase the diagnosis and then increase the ventilation, therapeutic ventilation. This is our way by this model. This is our data for about up to 30 years. We can see every year up to 400 and 500 total endoscopy. About 1/3 of the scope is belong to the therapeutic. 1/3 of our bronchoscopy is belong to the therapeutic. There are many items of this intervention: stent and foreign body removal and the laser and the balloon dilatation. We can see all these patients is ICU case, and all these patients, the age and the body weight is quite small. All this intervention will use a novel, non-invasive ventilation with no any ventilation bag, no mask, no artificial airway for up to 30 years. We introduce our novel ventilation skill. This key of the breathing. Here we show the pattern with the oxygen and the pressure change for the inspiration and the expiration, and the rate. When patient normal is spontaneous breathing, but once he abnormal, breathing abnormal, should be assisted by this, give the PIP, give the pressure change, give the oxygen, or give maintain the airway. ECMO is not the other mechanism. It's not our topic. So today we will not talk about the ECMO. This is our unique non-invasive ventilation. The full term, the full name is pharyngeal oxygen with nasal closure and abdomen compression. I just made it as sounds ventilation. It's very simple and easy, effective ventilation method. We put the pharyngeal oxygen tester in the pharynx and the intermittent in the nose close and the intermittent in the abdomen compression. The fourth step is put the nasopharyngeal oxygen. Just put from the nose going to the pharynx. The tip location of external measure from the nose to the ear and put in. And in children, small children, we can put the finger through the mouth to detect the tip location. And for bronchoscopy, we routine bronchoscopy going to the nose, and we can check the pharyngeal oxygen tip location in the oral pharynx is good. The test should not be too shallow or too deep the toothpick will go into the esophagus. That is not good. In this space, another space, a continuous flow of oxygen will produce a positive pressure. That's the PEEP. Okay, the oxygen through the nose can fulfill the upper airway space. This kind of setting will improve the saturation time. This is a apneic oxygenation. That means when upper airway full with the oxygen, even patient have no breathing movement because no ventilatory mass flow by many mechanisms. Only this setting, we can delay the saturation time. We can prolong the self-apnea period. That means only a simple setting like this, the patient can keep more safe period. This is one study, 2014. Two groups. This study group with the nasopharyngeal catheter. This control group with the nasal prong. It is the time about 10 minutes until the saturation decreases to less than 95. In the study group with the nasopharyngeal catheter, there's no any patient to saturate. But in the control group of the nasal prong, 1/3 of patients is saturated. Step 2 of our ventilation technique is a closed nose. Once closed nose, we can close and open, close and open. We can make pressure, PIP, peak inflation pressure, or peak inspirator pressure in the upper airway. This upper airway oxygen and the pressure will go into the trachea. We can assist them, we can compress the recoil, so the pressure and the oxygen flow will not go into the esophagus. That's good for patient. The third step is abdominal compression. Compression makes the diaphragm upward. Release the compression, the diaphragm downward. Only the compression will cause the impression and the expression. So this method will induce active and passive inspiration and expression. Okay, summarize. Pharyngeal oxygen, how much flow per kilo per minute, 1 liter, but the maximum less than 15. That's enough for pediatric patient. By this setting, in the upper airway, will produce a small peak about 4 centimeter water. Nose close will produce PIP from 10 to 50 or even more. We have to study. I will show you later. How much is the pressure? We can visible the chest excursion, or we can sense the gas leak from the nose or mouth during release the nose close. The third step is abdominal compression. The rate also option. Nose closure is also option. That means when patient is doing okay, nothing to only continue pharyngeal oxygen flow is enough. If patient is not okay, we just go in the nose close or abdominal compression. The mechanism of this ventilation by the PIP or PIP, we can maintain airway. By the pressure change, we can induce the pressure flow, that's breathing. A and B, we can ventilate the lung, that's a ventilation. And how about C? cease abdominal compression. Abdominal compression can assist the ventilation. And the other effect is abdomen blood flow, about 25% blood flow during the compression. The venous return will go into the intrathoracic. That's good for the cardiac flow. So A, B, C, just complete. So this method can use as a resuscitation, resuscitative ventilation, and also can use simply use during doing the bronchoscopy. Okay, that's we doing. A small oxygen tester, the tip set in the pharynx, and a flexible bronchoscopy going to the upper airway and then going to the lower airway. We can do diagnosis, and we can even doing the therapeutic intervention because there is no any mask, no any artificial airway inside the patient's airway. It's very simple and no any limitation for airway or manipulation limitation for the bronchoscopy. We can also support oxygen and oxygen ventilation, and also increase the diagnosis and treatment. This article just accepted in August this year. This part is my article. You can see sustained pharyngeal inflation on the upper airway in infant. We use the flexible bronchoscopy to measure the pressure change and the image change. Just what we're doing. The scope connect to a pressure monitor so we can detect the pressure change. And we use the endoscopy going to the airway. We can take the picture. When we close the nose like this, we can create PIP. This PIP will expand the upper airway lumen. So that's good for the ventilation and good for the detect any lesion inside. This is data. We can show the PIP data measured by the nanometry. From 0 seconds to 5 seconds, you can see the linear correlation to the duration of sustained pharyngeal inflation. From 1 second, 3 seconds, or 5 seconds. The maximum the pressure may up to more than 60. That's enough pressure. This is the image change. As the pressure increase, the airway lumen is gradually dilate, gradually dilate, gradually dilate. You can see laryngomalacia dilate, and the dynamic control by the operator himself. By the dynamic control, we can detect any obstructive issue or any occult issue of the pharynx, and also in the larynx. For example, this laryngeal cleft, the pressure not enough, where things normal, but when the gradually expand, and we can see the cleft. This can early detect any lesion, upper airway lesion. This summarized data of this article. The duration of nose close, as nose close duration increase, the PIP increase, and the detect lesion number also increase. They have significant increase in the PIP and also in the detect lesion. This is the other study we just finished. We not only measure the upper airway, we also measure the lower airway. You can see similar result. There's a linear correlation of the major PIP in both upper airway and the lower airway. And the other, both upper airway, lower airway, the level of pressure is identical. That means by this ventilation support, all the upper airway and the lower airway can be well dynamically expand. We show this video just like this. Initially, there have no any oxygen flow. We can see the dynamic change of the upper airway. It's quite noisy breathing and quite collapse during the inspiration. But when we give the oxygen flow into the pharynx, the noisy breathing is decreased and the collapse is less severe. If we added a closed nose, the PIP is increased. It is show more dilate of the pharynx and the larynx, and even the esophagus is inlaid, also dilate. That means the PIP can be controlled, the airway change. That's good for diagnosis and for interventional diagnosis. And also we go into the low airway. We go into the low airway. Dilate, you can see dilate, dilate, dilate. Inspiration, dilate, dilate, and expiration. And dilate, PIP, dilate the lumen. Any Malaysia lumen or correct lumen will be dilated by operator by this simple method. When do abdomen compression, we added the other third step, abdomen compression. More expiration and more inspiration. More expiration and more inspiration. The effect is more. Okay, we see this picture. This airway movement is quite dynamic. It's massive. It's massive. When we give the inflation, we see during inflation, the lumen is dilated. The lumen is dilated. It can be controlled by the operator. Can be controlled by the operator. By this technique, we can control the ventilation and control the lumen expansion. This like this. Okay, it is clinical application in bronchoscopy. Our team have published many articles of this technique with bronchoscopy in the chronology, this 2011, 5 years experience. And this animal study in 2013, this clinical study 2015. All this flexible bronchoscopy can be supported by this novel technique. See the topic. Nasopharyngeal oxygen with intermittent nose close and abdomen compression. The other article, 2017, the therapeutic from bronchoscopy in small children, the body weight less than 5 kilograms, 11 years experience. And the other talk about with the pressure endoscope, we press the metallic stent, how to maintain the stent function and the long-term outcome for up to 20 years experience. And this article is our APPS article. We summarize the previous intervention pressure bronchoscopy in 2018. All this paper is published by our team. So it is the effect of the bronchoscope. This picture, this pathway, the traditional, flexible endoscope is for diagnosis. After diagnosis, some patients may be needed operation, but showing but we should consult surgery team and the anesthesia team. If the patient is not stable, this operation will be delayed or refused, and many patients just expire, no chance to get the life. And if accepted for operation, should be wait for schedule. During the operation phase, this risky case, or even with the ECMO or ventilator, should be long-term transport from the ICU to the operation room, and after surgical procedure, you will transport again. During transport, patient just very trouble and very risky and complicated. So this route pathway is not good. If we have ability to make a diagnosis and we can do therapeutic intervention and guarantee a patient's safety, we can, after diagnosis, we direct doing the therapeutic intervention. After diagnosis, we even invite parents, both parents, come to see what happened in their baby's airway. After getting their consents, we just do the therapeutic bronchoscopy. All these procedures can be done in the PICU and by our pediatric team or pediatric pulmonology team. That's better. That's how we do in the past 30 years. The for diagnosis is very simple, but for therapeutic intervention, it may be simple or maybe complicated. For example, in addition to the scope, we maybe put the instrument inside the trachea, or sometimes maybe put more than one instrument inside. We have ability to keep patient safety even under severe sedation. This picture published in the Pulmonology 2015. Just like this picture shows. For example, in this airway, they have two balloons and one endoscope. And this patient already have a stent inside. This just like this. Right
This video, we just show how we do the two balloon tracheoplasty in a small infant. We can see the monitor, the patient vital sign is quite stable, quite safe. So once patient is safe, we can do everything in the trachea, use our ventilation technique.
For interventional bronchoscopy, there are many items. For example, foreign body retriever, laser operation, balloon dilatation, cryo, stent procedure. Many times is hybrid using combination of all these procedures. Because of time limits, we have interesting case present, not in this speech, but we put in the J01 section. There have 8 case, interesting case. There we will show some case presentation about the flexible bronchoscopy demonstration. Just a foreign body removed, just like this, just no any artificial airway inside. By this method, we published in the 2017. We can pick up, remove many foreign body inside. More than 95% foreign body can be removed. This infant, Strider, this one. There's no any artificial airway. You see the parents have a big soft mass. Big soft mass. After this, we don't do the CT scan to make diagnosis. All these cases the bronchoscope may be the first diagnostic instrument. After endoscope, we can make a complete diagnosis. This is a varicose cyst with laryngomalacia. After diagnosis, we just do direct in the therapeutic intervention after get the parents' consent. Like this.
This we just show how we do the diagnosis and the therapeutic intervention during one scope session. After diagnosis, we just do the therapeutic intervention. For both the varicose cyst and the malacia, laryngomalacia.
In the same bronchoscopy session, we make diagnosis and treatment. This paper we published in 2011, talking about how we use a flexible laser scope for the severe laryngomalacia. This paper we published last year, talking about the varicose cyst with laryngomalacia, also by this intervention with a non-invasive ventilation in pediatric pulmonology. This shows how we doing for the subglottic stenosis. We use a laser to widen the stenosis, and after that we may use the balloon dilatation to dilate the stenosis. For example, like this. We use a balloon inflate balloon, and make the lumen bigger. Balloon dilatation, and even change to big balloon to make it even more dilated. This balloon dilatation can do the stem plastic and even the bronchial narrowing. You can see both monitors will show patient safety. And the stent, what stent we use? We usually use the uncovered stent, expandable, or use cover stent, safe expandable. The stent can expand, inflate the diameter become bigger. This article in the 2018 talking about the stent placement and the maintenance in the long-term effect. In that article, we have put 165 stent in 101 patients in every location, trachea or dilated bronchus. And also, we can, during the 20 years period, we remove the 78 stent in 31 patients. So the stent is removable. And also in the other article, we publish the small kit, less than 5 kilograms. We also can put the stent, and also we can remove the stent. So the stent, we can use a flexible bronchoscope for implantation and the maintenance. But during the travel, sometimes we use a flexible, but sometimes because we need a big retraction power, so we use the rigid scope. This picture shows the stent implantation. Put the stent in and confine the location and inflate the balloon, expand the stent, and depress the stent and check the lumen. All this procedure will show in the case presentation section, J01 section. So stent, for example, the central airway collapse is absolutely, but after stent implantation, it is less invasive and immediately can open the lumen and weaning the ventilator support and also diminish the surgical procedure. So stent is valuable in our patient. Also life-saving. This article, 2017, the small kit, quite small, less than 5 kilograms. We do every therapeutic intervention can be done in less than 5 kilograms infant in more than 10 years periods. Can be safely done. And this procedure can promote weaning positive pressure ventilation and it can promote patient extubation. And the surgical intervention for tracheostomy or for the tracheoplasty or thoracotomy, or even for typical left side main bronchial surgery, many need ECMO support. But all we know, the ECMO is too suffer, is too damaging to the patient. We try to avoid this surgical intervention. We will not favor this kind of operation. So in our article we published in 2018, we can see we can dramatically reduce avoid surgical intervention in up to 90%, especially for the stent implantation and the balloon plastic. We can 100% avoid the surgical intervention. That's good for patient. Just like this, I have shown you before, all our intervention bronchoscopy with no any artificial airway. So conclusion is pharyngeal oxygen. This kind of non-invasive ventilation is simple and effective. And we can keep during the procedure, we can keep the safety, and the safety is the most important. And with this NIV support, we can do a lot of diagnosis or therapeutic intervention in both upper airway and the lower airway, in neonates or children. Please, the final, please, illustration case will show in the J01 section. Thank you for your attention. Thank you for your attention.
Thank you, Professor Song and okay. Dr. Niu.
Good afternoon, wherever you are. I think Dr. Song can explode no longer everything. You're sleeping, and put your scarf beside you, right? You see that? Add a question.
Okay, may I answer? I see there have 3 questions. I answer. The first question is during or after the laser therapy, is there any laryngeal spasm or laryngeal swelling? I don't see any laryngeal spasm because we give the local lidocaine solution before the laser. Or before the diagnosis score, we give the local lidocaine, and there may have laryngeal swelling after the laser. We never intubate. We just support with nasal prong NIV, and all these cases will become stable and good. So this is the first question. The second question is how about the high flow nasal cannula in bronchoscope? No, answer is no. High flow nasal cannula is only for patients have spontaneous breathing. They only support a minimal pressure, peak around 5 or 6, never more than 6. It is flow dependent. We use high flow. And during the therapeutic intervention scope, we sometimes use the muscle relaxant to total flow, total stop the patient's spontaneous breathing. And patient have no apnea, no any breathing movement, and every ventilation is controlled by operator. Is controlled by the broncho operator. So high flow nasal cannula is no useful. It is just used for the easy case, not for severe case. And the third question is how about the stem? I use the stem is balloon expandable. That means baby grow up, the stem can be dilate, use the balloon dilatation. And finally, we can maintain stem for more than 10 years or even 15 years. And finally, if the stem can be removed with a rigid scope. So stem is not a problem. In children, it's not a problem. We use the balloon expandable metallic stem. Okay.
My children, yes, have the same situation, and now he is about 5 years old. When he performed his insertion, so about 10 more years.
Please say again. I have not understand what is your question. I mean, the most problem is the subglottic stenosis. But now we can insert the other type of stent. I'm not sure. Only we have several cases receive tracheostomy. That's due to the severe subglottic stenosis. And also, I see the other question is how old the technical source ventilation can be applied. I have patient more than 100 kilograms. That's no problem. The mechanical is very easy. Both in the children and in the adult is the same mechanism. Or you can try.
One thing I want talking to the rookie. Actually, I am. Don't do the procedure as possible. That's the first thing I teach them. Especially if you encounter community acquired pneumonia. If necessary, there is fluid, there is some special condition. Don't have to do that. Just or biotics or common. That's enough. Don't have to do.
I see the other question is when you to retrieve a foreign body, I prefer use the flexible. Once flexible is difficult to remove, I will try the rigid scope. Our team also do the rigid scope, but we try flexible first.
Okay. Thank you. Because our schedule is a little bit behind. I believe the Professor Song is willing to keep answer the question on the chat box. So I have to close this section, and thank you, Dr. Neil, and thank you, Professor Song. Okay, I have to end this section. And now we have 3 minutes break, and please come back 3 minutes later that we have our young investigator presentation. Thank you. Please start.
It may come as a surprise, but about 50% of patients with asthma remain symptomatic despite maintenance treatment. That's 15 million people in Europe, 150 million worldwide, and more than the population of Japan. What is shocking is that of those who remain symptomatic, about 80% see ongoing symptoms as well, or completely controlled. And so, when asked by their doctor about their asthma, they merely say, yes, it's fine. But you know it's not fine. Evidence says a patient is at high risk, 6-fold, of an exacerbation if they remain symptomatic. Nevertheless, although you have explained the health consequences, you may know at least one of your patients on ICS/LABA who might be symptomatic and therefore at risk. You know more could be done, and some patients could live a more normal life. So, after you have performed the normal checks with your patient and still feel you need to do more, what can you offer? The answer might be a medication that helps bronchoconstriction in a different way to other asthma drugs. Add Spiriva Respimat to ICS/LABA, as focusing on one bronchodilation pathway may not be enough. Spiriva Respimat is approved for asthma when patients remain symptomatic while taking their regular ICS/LABA treatment. It's been shown to improve lung function, improve asthma symptoms, and significantly reduce the risk of severe exacerbation. And these benefits work regardless of the characteristics of the patient at baseline. Spiriva is delivered by the Respimat inhaler in a unique mist that can make its way deep into the patient's lungs. Add Spiriva Respimat, a different approach that helps patients stay in front of asthma.
Hey, good afternoon. And now let's move to the next session. And next session is the young investigator presentation, which is the clinical case report. I would like to invite the first moderator is Professor Shida Xu. Professor Xu, please. Professor Xu, please turn on your voice, turn on your microphone.
Distinguished guests, dear colleagues, ladies and gentlemen, the first to talk of the section of Young Investigator Award oral presentation is chaired by me, Shida Xu, Professor of Pediatric Allergy, Immunology, Pulmonology, Mackay Children's Hospital. We will have about 10 minutes for each presentation. It is my great honor and privilege to introduce you the first speaker of the section, Dr. Wei Yi-chen, came from Taipei Veteran General Hospital. His topic of today is tongue lip adhesion as a possible option for Pierre-Robin sequence before tracheostomy. Let's give a warm welcome to Dr. Wei Yi-chen. Dr. Chen, please.
Hello, I'm the presenter Chen Weiyu, and I'm the resident doctor from Taipei Veterans General Hospital at Taipei, Taiwan. Today, I would like to present a baby girl with Pierre-Robin sequence who was successfully treated by tongue lip adhesion. This baby girl came to our hospital for help when she was 26 days old, with noisy breathing sound and poor weight gain since birth. The feeding amount was just above lower limit. She was a firstborn Fulton baby with APGAR score 8 to 9 points. The birth body weight was within the 3rd to 10th percentile. No significant anomaly noted at birth. However, when she went to our hospital, her body weight, body height, and head circumference were all dropped to below the 3rd percentile. Noisy breathing sound was presented with tachycardia, tachypnea, coastal retraction, and stridor when auscultation. Small chin, small jaws with retracted tongue were observed. She was then admitted to our NICU with NIPPV support. Further examination was arranged, including bronchoscopy for checking airway structure and a systemic survey to rule out any other genetic syndrome. Cardiac sonography, renal sonography, brain sonography, and the whole exome sequence were arranged and all showed no significant abnormal finding. This is the picture of the baby. You can see that sometimes we need to elevate her retracted mandible to open her airway to improve the respiration. And the bronchoscopic showed backward tone and epiglottis kissing the posterior pharyngeal wall. Laryngomalacia was also noted. After conservative treatment with NIPPV for about a month, the respiratory pattern and feeding amount were improved. She was then discharged. However, aspiration pneumonia showed up not long afterward. Tracheostomy was suggested at other hospital nearby her home, but the parents were hesitating. She then transferred back to our hospital, searching for a second opinion. After controlling the infection, we consulted the oral surgeon. Larynx CT was arranged and the surgical intervention was suggested with several choices. Tongue lip adhesion was decided after family meeting. Here is the CT finding. A prominent tongue-based protrusion was noted, causing severe narrowing at the epiglottic level. Tongue lip adhesion was done, and here's the picture after operation. We used a suture stitch through the tongue tip and the chin, and it was fixed with button at both sides. The button was removed 2 weeks after the tissue growing up. Here is the bronchoscopic finding after tongue lip adhesion. Airway was almost patent with only laryngomalacia noted, so laryngoplasty was done. And after button and suture removed, we did the bronchoscopic again. Tongue was still retractile, but with better airway space comparing the finding before surgery. Followed combined CT also showed better airway space. The respiratory pattern also improved. Ventilation support was titrated to continuous positive airway pressure only, and she was discharged. The growth curve was shown here. We can see her body weight is catching up. So this is our patient with Pierre-Robin sequence managed by tongue lip adhesion. Later, I would like to share the literature review about current suggestion of the management of Pierre-Robin sequence. Pierre-Robin sequence is a congenital defect with the triad of micropnasia, glossotosis, and airway obstruction. Around 50% of the patients were associated to other anomalies and syndromic PIS, and these patients usually had severer symptoms. Around 50% of the patients could be handled by supportive care alone. However, there was no best choice if conservative treatment failed. The possible choice including tracheostomy, tongue lip adhesion, and mandibular distraction osteogenesis. Here is the pros and cons of tracheostomy. It is the safest and most reliable way for airway obstruction. However, high complication rates in both short-term and long-term, sometimes causing mortality, make this choice not so acceptable. For tongue lip adhesion, the advantage is that it is the least invasive procedure for Pierre-Robin sequence, with the complications were all minor issues and could be managed easily. However, the failure rate is high and may lead to tracheostomy eventually. And the mandibular distraction osteogenesis is corrective orthognathic surgery and could handle cosmetic issues. It still has chance of failure, although the rate is lower than tongue lip adhesion. The complications were less than tracheostomy, but still severer than those in tongue lip adhesion, such as open bite deformity, damage to tooth buds, or inferior alveolar nerve injury. The softness of the bone would also be a concern if this procedure is applied to infants. Here is the characteristics of the PIS patients from a retrospective case review of 2 Canadian hospitals. The only significant difference was noted at the group of tracheostomy. The patient in this group had poorer condition, including higher proportion of syndromic PIS, less birth weight, long hospital and ICU stays. Here is another review comparing tongue lip adhesion and mandibular distraction osteogenesis. Both of these interventions had good avoidance of tracheostomy. In conclusion, tongue lip adhesion may be a good choice for non-syndromic PIS patient after supportive care failed, if the clinical condition is not so bad judged by clinicians. Here is my reference. Thanks for your attention.
We are very enjoying Dr. Chen's presentation today. Let's open for discussion now.
Okay. Hello everyone. Could you hear my voice?
Yes, I can hear.
Okay, I'd like to answer the first question. Dr. Anna Nathan asked about, do we still use the CPAP post-operatively after the tongue lip adhesion? After tongue lip adhesion, the symptoms, including stridor and the CO2 retention, are all significantly improved. But we still use NIPPV for a little bit times and gradually titrate to CPAP until the tongue lip adhesion was released. And after release, recently, about 3 months before, she just received the release surgery. And after the surgery, we still use the CPAP, but the respiratory pattern is significantly improved, comparing the presentation when she just arrived our hospital. And later, I would like to answer the second question about the oral feeding. After the tongue lip adhesion, her tongue is all tied up, so the feeding was all by NG feeding. And when she received the release surgery 3 months before, we start the rehabilitation for the oral feeding, and the oral feeding condition was still under following. Okay. And I see the third question is asking about the age limitation. In my review, I didn't notice any restriction to the age limitation, so I'm not really sure about this question, sorry. And I see the fourth question, is it good to have the baby in prone position? We have tried it when she first arrived to our hospital with NIPPV support, and it seems it works at first, but after she discharged at the first time, there's still many recurrent aspiration pneumonia. So that suggests the supportive care is not enough for her. So we start to consider the invasive surgery for her at that time. So we tried prone position at first, but it seems failure finally in this patient. The fifth question is asking about the choking episode. Is Professor Song want to know about the choking episode after releasing or before releasing? I see. After fixation, okay. After fixation, the tongue is totally fixed and cannot move. So we didn't try the oral feeding. We just keep the NG feeding totally. So when using NG feeding, there's no choking episode.
I think because time is up, so maybe you can answer the question in the chat box. And Professor Xu, can you go on for the next presentation, please?
The next speaker of this section is Dr. Pinson. Came from Taipei Veterinary General Hospital. Her topic of today is intratracheal administration of human umbilical cord blood-derived mesenchymal stem cell improve established severe bronchopulmonary dysplasia accompanied with acute respiratory distress syndrome and suprasystemic pulmonary hypertension in an infant. Let's give a warm welcome to Dr. Pinson. Dr. Sen, please.
Good afternoon, everyone. I'm Dr. Shen, and my supervisor is Dr. Li. On behalf of Taipei Veterans General Hospital, today I'm going to present a case of established severe bronchopulmonary dysplasia treated with mesenchymal stem cells. First, I'll give you some background knowledge about BPD. BPD is a major respiratory morbidity of prematurity. For example, the rate of BPD in Taiwan is about 50% in extremely prematurity. However, currently there's no effective treatment. Fortunately, MSC therapy may be an innovative breakthrough. Our case is an 11-month-old girl, and her corrected age is 7 months old. The past history including extremely prematurity and severe established BPD. She was admitted due to respiratory failure. Upon admission, chest X-ray revealed reticular nodular interstitial pattern and cardiomegaly. Heart echo showed suprasystemic pulmonary hypertension. Gas analysis implies severe acute respiratory distress syndrome. The above findings may be associated with established BPD with acute exacerbation. We intubate the baby immediately. For pulmonary hypertension, we gave murinal pump, sildenafil, bocetin, and inhaled nitric oxide. For oxygenation, we titrate conventional ventilation settings and even tried high-frequency oscillatory ventilation. However, oxygenation showed no improvement. Her family refused ECMO, so we think of human umbilical cord blood-derived MSC. We prescribe human umbilical cord blood-derived MSC weekly for 6 consecutive weeks via endotracheal tube. The dose is 10 million cells per kilogram. This figure shows the change of ventilation parameter after first MSC infusion. You can find that the oxygenation didn't reveal improvement during first 5 doses, but we still complete the 6th dose. Her respiratory conditions improved thereafter. Due to difficult weaning from mechanical ventilation, we tried NAVA sensor. She was extubated at the 74th days after the first dose of MSC infusion. These are serial chest rate before and after MSC infusion. Figure 2 is chest X-ray performed 1 week after the 6th dose of MSC infusion, which reveals dramatic improvement. Finally, the baby was discharged and transferred to the local hospital with nasal CPAP. Then, let's move on to discussion. MSC are multipotent progenitor cells. They play critical roles in tissue repair and renewal in paracrine signaling rather than engraftment. The efficacy of MSC therapy is source, route, dose, and time dependent. First, Human umbilical cord blood is considered a better source than other potential sources because it's easy to isolate and has greater proliferative capacity compared with other sources like bone marrow tissue or adipose tissue. Second, intratracheal route is better than systemic route due to greater paracrine potency. Third, the efficacy of MSC therapy is dose-dependent in an animal study. Most clinical trials choose doses of 10 million and 2 million cells per kilogram for human infants. The outcomes between two groups were similar in a study from Korea. Finally, early greater than late MSC therapy protects neonatal rates from hypoxia-induced lung injury. Currently, clinical trials of MSC therapy focus on BPD prevention and treatment of evolving BPD. We only found few cases about MSC therapy for established BPD, and the results are controversial. Back to our case. The dramatic improvement supports potential efficacy of MSC therapy for patients of established BPD with acute insults. What's more, the improvement happened after 5 to 6 doses of MSC infusion, which implies the importance of repeated dose. To sum up, MSC therapy might be an alternative option for infants of established BPD with acute pulmonary insults, but not the candidates of ECMO. But further large-scale studies are needed. These are the reference, and thank you for your attention.
We are very enjoying Dr. Sen's presentation today. Let's open for discussion now.
Okay, thank you, moderator. And I can see some questions from the chat box. And the first question is from Dr. Song, and he asks, what are the source of the stem cells? And the source of stem cell is from human umbilical cord, and we have 6 doses, and every dose is from single donor. And other sources include bone marrow or adipose tissue, but umbilical cord is easy to isolate. So we choose umbilical cord blood as our source. And the second question is from Dr. Lin. He or she asks, is this improvement a result of mesenchymal stem cell or natural course in other treatment? I think both treatment is very important. We can see, you can see the table from my previous video. The improvement is dramatic after the 5th to 6th dose. So I think the improvement is somewhat related to mesenchymal stem cell therapy. And the third question is also from Dr. Song. He asks, can the stem cell reach the alveolar or respiratory bronchioli? We give mesenchymal stem cell via endotracheal tube, and after we push the liquid containing mesenchymal stem cell, we will use ambu to let them reach distal side as much as we can. And after prescription, the mesenchymal stem cell will migrate to what we desire they will go. And when they will, okay, this is my answer. And so I think it's almost 10 minutes. Should I answer another question or should I answer it in the chat box?
Maybe the last one question.
Okay, so the fourth question is, what is the role of mesenchymal stem cell in this case? The role is it will release some signaling peptide to interact with native mesenchymal stem cell to to improve tissue repair and renewal. Okay, I will answer the other question in the chat box. Thank you.
Okay, thank you.
One word is about the mechanism of the mesenchymal stem cell is not through regenerative effect, but through paracrine effect. Thank you.
Okay, thank you, Professor Shi. And I believe you will continue to answer the question in the chat box. And the next, I would like to invite our moderator, Bao Rennong, Professor Bao Rennong, please.
Ladies and gentlemen, I am Bao Rennong, currently serving at the Kaohsiung Veteran General Hospital, Taiwan. It's my honor to be here as a moderator. Dr. Jielong Li, she is at the National Taiwan University Children's Hospital. Her amazing abstract was chosen from Outstanding Abstracts. Now let's welcome Dr. Li to present her work. Dr. Li, please start.
Good afternoon, the attendees of APPS Congress 2021. I am presenter Li Jielong. I am a resident doctor from National Taiwan University Children's Hospital. Today, I'm going to share a clinical case report of adult patients with severe COVID-19 in pediatric intensive care units. Here is my contents. First is background, followed by case reports, then discussion, and last is conclusion. Coronavirus disease 2019 caused by SARS-CoV-2 infection has been pandemic since 2020. More than 200 million people were infected and had caused more than 4 million deaths in the world. Compared to 10% adults with severe COVID-19, only 1% pediatric COVID-19 patients required admission to pediatric intensive care units. With the outbreak of COVID-19 beginning May 2021 in Taiwan, especially in northern Taiwan, the surge of adult patients with severe COVID-19 struck healthcare systems, and PICUs faced the challenge of critical care of adult COVID-19 patients. We reported 4 cases of critical adult COVID-19 patients hospitalized in PICU and discussed the difficulty of caring adults in PICU. Case A is a 56-year-old man who has past history of pulmonary fibrosis. He was diagnosed with COVID-19 in May 22, 2021, and admitted to our hospital on May 24, 2021. His PRIEST score was 16. Here shows his chest X-ray on admission and before discharge, while no obvious improvement was noted. His initial arterial gas revealed PaO2 155 under 100% FiO2 use. About his clinical course, he had received steroid, remdesivir, and enoxaparin during hospitalization. With progression of ARDS, he started high-flow nasal cannula use on ICU day 4. His respiratory condition gradually improved with better PF ratio and lower FiO2 use. His length of ICU stay was 21 days. Case B is a 70-year-old man who has past history of hyperlipidemia. He was diagnosed with COVID-19 on May 22, 2021, and admitted to our hospital on May 28, 2021. His PRIEST score was 15. His chest X-ray showed consolidation at the both lungs on admission, while his chest X-ray before discharge showed improvement with only infiltrations over both lungs. And his initial arterial gas revealed PaO2 168 under 100% FiO2 use. About his clinical course, he had received steroid, remdesivir, and tocilizumab during hospitalization. With progression of ARDS, he started high-flow nasal cannula use on ICU day 3. His respiratory condition gradually improved with better PF ratio and lower FiO2 use. His length of ICU stay was 19 days. And case C is a 67-year-old man who is a HBV carrier. He was diagnosed with COVID-19 on May 20, 2021, and admitted to our hospital on May 24, 2021. His PRIEST score was 16. His chest X-ray showed ill-defined opacities at both lungs on admission, and his chest X-ray before discharge showed increased infiltration and multiple nodules in both lungs. And his initial arterial gas revealed PaO2 150 under 90% FiO2 use. About his clinical course, he had received steroid, remdesivir, enoxaparin, heparin, and tocilizumab during hospitalization. With severe ARDS, he was intubated on emergency room with ventilator use. and admitted to ICU on the next day. His respiratory condition gradually improved with better PF ratio and lower FiO2 use. Then extubation was performed on ICU day 15. His length of ICU stay was 19 days. The last case is a 67-year-old man who has history of hypertension. He was diagnosed with COVID-19 on May 23, 2021, and admitted to our hospital on May 25, 2021. His PRISC score was 14. His chest X-ray showed ill-defined opacities at bilateral lungs and bilateral pleural effusion. His chest X-ray before discharge showed improvement of bilateral opacities. His initial arterial gas revealed PaO2 96.7 under 100% FiO2 use. About his clinical course, he had received steroid, remdesivir, heparin, and tocilizumab during hospitalization. With severe ARDS, he was intubated with ventilator use on ICU day 2. His respiratory condition gradually improved with better PF ratio and lower FiO2 use. Then, extubation was performed on ICU day 13. His length of ICU stay was 19 days. And here are the inflammatory markers trend of these 4 patients during hospitalization. We can see CRP, ferritin, and fibrinogen levels have the highest peak in all patients at the beginning, but D-dimer has the highest peak around ICU day 7. And here's the COVID PCR CT data of all patients. They were de-isolated between day 19 to day 28. Compared to European study, our adult patients with severe COVID-19 have similar PICU stay, 19 versus 21.5 days, but lower mortality rate, 0% versus 14%. Also, like the previous studies, our facilities in PICUs encountered some difficulties on caring these patients, including unfamiliarity with adult patients, advanced cardiac life support, and the care of COVID-19. And the equipment in PICUs was not appropriate for adults. Furthermore, some treatments such as poor position or fear of getting infection from patients remain challenging for us. All these problems require staff retraining and the equipment reconfigured. Last is the conclusion. Before universal applications of COVID-19 vaccines and control of the community outbreak of SARS-CoV-2, physicians in PICU still face the challenge of caring adults with severe COVID-19, and our observational study provided the clinical insights and preparation for this challenge. And here are my references. Thank you for your attention.
Dr. Lee, thank you for taking the time and efforts to share your thoughts and experience. Here are some questions in chat box.
Okay.
Would you answer, please?
Thank you, moderator. And now I'm going to answer the questions in the chat box. First is from Dr. Song. And what are the differences compared to care pediatric patients? Actually, there are less pediatric patients with severe COVID-19 infection. And in our hospital, we only care about like within 10 patients, about not so many. And most of them didn't have severe symptoms. Like most of them just need care in general ward and instead of the intensive care unit. So the difference is actually because of our facilities, like, and the cooperation between the teamworks, because we most of the time we care about kids, so the nurses and the doctors in PICU are familiar with the training of caring children. So caring adult is quite challenging, but mostly the how to say that the general care principle is the principles are the same. So the differences is just about we have to negotiate with the adults, and while they have their needs are quite different from children. Yeah, I think that's the most important point. And the next question is from Dr. Baoren Bao Renong. And how did you prepare for the setup of teamwork training and facility for adult treatment? And how long did it take for the preparation? Oh, from Dr. Chen Mingfang. Actually, since the breakout of COVID-19 in Taipei surged quickly, so we didn't have enough time for the preparation. So we just modified our carrying ability while carrying these patients. And we also cooperate with physicians from our hospital. So while we pediatrician gave the first primary care for these patients, but we asked a chest specialist of internal medicine, and they will give us advice and the treatment guidelines and principles for these adult patients.
Dr. Lee, thank you again. As time limited, this session ends here.
Okay.
Okay. Thank you, and thank you, Dr. Bao Renong. And next, I would like to invite our moderator, who is Kai-Shen Xie, Professor Xie. Please.
Okay, my dear colleagues, ladies and gentlemen, it is my great pleasure to chair this session, and thanks for the invitation from the organization committee. I'm from Shanghai Hospital and Taipei Medical University, Taipei, Taiwan, and the first topic of this session will be presented by Dr. Naiyuan Jiang. Her topic is challenge case, pediatric idiopathic pulmonary hemosiderosis. Dr. Jiang, please. He's from National Taiwan University Children's Hospital, Taiwan. Dr. Jiang, please.
Hello, today I will present a case of a pediatric idiopathic pulmonary hemosiderosis. IPH is a disease characteristic of anemia, hematitis, and white out lung on chest X-ray. Besides, it is typically found in childhood. Then I will present a case in our hospital. This is about a 3-year-old girl with a with hematitis for 1 week and short breathing progress for 2 days. And here is her brief history. There was no remarkable finding in her birth history. There is developmental delay found before. Besides, before this time admission, she had a congenital diaphragm hernia and received surgery just after birth. She had iron deficiency anemia. She had been hospitalized for pneumonia with hematitis twice before. Here is her past history before this time. Initially, she was found pale looking at 1 year old, and after a survey combining HB, electrophoresis, and iron profile, iron deficiency anemia was diagnosed and varying supplement was given. Later, anemia subsided from HB 6.1 to 10 grams per deciliter. Later, at about 2 years old, she had a productive cold and fever. Finally, diagnosed with pneumonia and just hospitalized for about 5 days with nothing use. Although she had hematitis and pneumonia, she subsided soon. Later, she just followed up her iron deficiency anemia at OPD, and no major complication was found. However, she was found pale looking again 1 month before hospitalization this time. Besides, intermittent dyspnea during exercise was found gradually. Besides, intermittent hematitis twice was found and subsided by herself. Hence, no more intervention or survey was not done. Then, 1 month later, symptoms of short breathing progress and fever for 2 days was found. She was then brought to our emergency department for help. At the emergency department, vital signs showed fever and desaturation, and physical explanation showed respiratory retraction and bilateral bronchi and right side decreased breathing sound and pale looking with decreased activity. Then further survey was arranged, which showed severe anemia and respiratory alkalosis. Other surveys showed non-elevated CRP. Besides, later results of peripheral blood smear showed an encephalitis positive with hypochromic RBC, which indicated intravascular hemolysis and non-immune radiated. Chest X-ray showed the right side ground glass bypass pattern, and combining past history and initial survey, pneumonia with pulmonary hemosiderosis was suspected. Then, due to relatively stable vital sign and clinical condition, she was admitted to general ward initially. However, after admission, O2 demand elevated with tachypnea found just within a few hours. Hence, she was transferred to our PICU for further care. 1 day later, progressive dyspnea with a persistent desaturation under the non-releasing mark. Even after antibiotic treatment of unacin plus doxycycline plus chloramine, symptoms still progress. Here is the blood gas analysis and the chest X-ray after progression. Then, due to rapid progression, she received intubation with 1 day after admission. Then serial survival was done. Remarkable finding is bronchoscopy showed multiple bleeding lesion and sputum smear. Besides, pathology showed a hemostatin-laden macrophage. Hence, IPH was diagnosed due to pathology finding and typical IPH triad. And ARDS was impressed due to low PF ratio. And here's the pathology image. The array indicated hemostatin-laden macrophage, which is a typical finding of IPH. Then inclusive severe infection and then no other pathogen culture data, steroid and IVIG was given, and ARDS improved soon. Because antibiotic was upgraded due to unstable vital sign. Then PF ratio improved gradually. Then for better respiratory outcome, the after lymphocyte subset survey, cranial was added. After stable, CT was arranged, and which showed a reticular pattern over bilateral lung. This is finding is compatible with IPH and interstitial pneumonitis. Then after treatment of steroid, cranial, and antibiotic, ARDS improved a lot, and intubation was done smooth 1 week later. Later, steroid tapered gradually, and hemoglobin level recovered gradually. Final diagnosis was a pulmonary hemodystrophy with ARDS. Conclusively, this is a 8-month-old girl with IDA before this time hematitis with ARDS found after survey. IPH was finally diagnosed. Then steroid plus paracranial was added, and she was discharged 20 days later. Then I will present a case of a discussion for IPH. IPH is a rare disease primarily in children. Incidence rate is about 1 case per million per year in children. It was a disease diffuse alveolar hemorrhage due to autoimmune dysregulation, and it was characterized by a recurrent episode of diffuse alveolar hemorrhage. And here is the IPH clinical symptom, including anemia, caused hematitis, fever, and dyspnea. Besides, it can be found with gout failure. And types of anemia in IPH. Here's the IPH triad. And the pathology of IPH is initiated by the immune dysregulation. The immune system causes alveolar capillary damage, and alveolar macrophage are less able to degrade the erythrocyte. So actual M would be found after the alveolar building and the immune dysregulation, finally leading to IDA. We could see a patient with IPH would be found with some immunocomplex in the plasma, and 25% of IPH patients would develop other autoimmune disease in the future. And here is the diagnosis of IPH. It can be diagnosed by the typical IPH triad, hemostatin-laden macrophage from respiratory specimen, and inclusion after pulmonary hemorrhage disease. And treatment includes as below. The systemic steroid is a first-line therapy, and there are different dosage depending on the disease severity. Besides, combining with other immunosuppressive agent can make a better outcome. And here is the outcome from past history. High-dose corticosteroid can cause a lower ICU admission risk and promote hemoglobin recovery. Besides, the duration of steroid therapy is 2 to 6 weeks. In severe case with respiratory failure, DMARD can cause a better outcome. Finally, in the past analysis, 5-year survival rate was about 90%. Conclusively, IPH is an immune dysregulation disease without precise etiology. And anemia, hemostasis, and GGO pattern in chest X-ray is a typical finding, which can make a diagnosis of IPH. And high-dose steroid plus a DMARD can make a better outcome. And thank you for listening.
Okay, thank you for the excellent presentation, Dr. Jiang. I think there are some questions for you to answer.
Yes, and the first question, and because at our lung biopsy, we can see the typical hemostatin-laden macrophage, so we can straightforward make the diagnosis of IPH. And for IVIG, it's not routine and subject for the IPH, but for the severe infection, we cannot exclude other cause of severe infection. So we use IVIG first, just after our admission to the PICU. And the second question, and at over our bronchoscopy, and we can see the bleeding lesion at the right side distal bronchiole and the distal part. And but this is not a typical finding of the IPH, and which you can just see the bleeding side at the right side and not from both sides. But we still until now we still not know we still not the cause of why we just find the lesion at the right side. And because we see the lesion at over right side, so we just take the pathology from right and not from the left. So we cannot maybe it just the disease not progressed not so much, then the left side is not still left side is not so severe for bleeding. And for the third question, and over our in our hospitals, clinical in hospital in our hospital past experience, our immuno subspecialist suggest combine the steroid and the plaquenil and reduce the severe disease severity. And just I have talked about at our let's started just mentioned above. And the duration of therapy and the high dose corticosteroid combined with DMARD like the azathioprine or the high dose or plaquenil can reduce the duration of therapy. And
hey, the time is up.
Okay.
Thank you for your
And
excellent
other
presentation.
question I
Because
will
of the time restraint, we have to continue to the next presentation. The next topic of the presentation will be the role of intraoperative bronchoscopy in complex airway anomalies. This topic will be presented by Dr. Ji Wei Lin from the Pingtung branch of Taipei Veterans General Hospital, Pingtung, Taiwan. Dr. Lin, please.
It's my honor to share a short speech here. Today, my topic is the role of intraoperative bronchoscopy in complex aerodigestive anomalies. When a patient had compression of airway with respiratory symptoms and signs, surgical correction is suggested. In a review article in 2012, there is including 40 articles and 758 tracheomalacia patients, 659 with comorbidities as following. Esophageal atresia is the most common. Others are vascular ring large vessel anomalies and innominate artery compression. Indications for 581 patients who underwent autopexy. Acute life-threatening events is the most common. For further severe type, complete vascular ring or congenital tracheal stenosis, slight tracheoplasty is suggested. However, the surgical complications are not few. To improve the outcome, does the intraoperative bronchoscopy play an important role? We will have discussion behind. First, I will present 3 cases we did intraoperative bronchoscopy in surgery. The first case is a 3-day-old late preterm infant. She was diagnosed as TE fistula type C, and she was underwent surgical repair when she was 9 days old. 1 month later, the patient had frequent apnea, and regular bronchoscopy showed tracheomalacia. The chest CT done and showed innominate artery compression syndrome with tracheal compression. Because the patient has symptoms and signs with compression of airway, we arranged autopexy via partial sternotomy approach. Here is the bronchoscopy image. And initially, the surgeon only do the one side elevation of aorta. And after that, we do the first bronchoscopy, which showed there is still a little narrowing of trachea. And then the surgeon modified and drew the other side of elevation of aorta. The modified one, you can see that the lumen is intact. The second case is a 4-month-old infant. He has past history of bacterial association, imperforated anus, and bilateral inguinal hernia. After high ligation of inguinal hernia, he had recurrent pneumonia and stridor with retraction noted. Then the CT was done and showed he had left pulmonary sling with tracheal stenosis, and surgical reconstruction was necessary. The bronchoscopy image showed here. The left one showed the pre-operation bronchoscopy at the narrowest side of trachea is only 15 millimeter. And the right side is done after slide tracheoplasty immediately. And you can see the white place is the suture site. And the lumen is intact, and you can see the canarina here. The third one is a complicated case. This is a 3-year-old toddler who had congenital esophageal atresia and underwent end-to-end esophageal anastomosis when he was 5 months old. Severe anastomosis stricture was noted after that, and many times of esophageal dilatation was done. Because of severe esophageal stricture, he underwent colon interposition and pyloroplasty when he was 1 year old. After second-time operation, esophageal stenosis was still noted, and balloon dilatation was done every 2 weeks until he was 3 years old. Once when we did regular esophagoscopy for balloon dilatation, the guide wire couldn't go through the stenosis site, and the surgeon suggested neck exploration for repair. After the surgeon explored his neck, we did intraoperative esophagoscopy simultaneously for localization of esophageal stenosis, and we did balloon dilatation. The surgical finding was no anastomosis stenosis, but segmental stenosis at cervical esophagus with surrounding fibrotic tissue was noted. Finally, the 3 cases, they smoothly recovered and discharged. For the autopexy, in the earlier review article in 2012, very different opinions exist between authors on the value of intraoperative bronchoscopy, which was only 37% cases preferably performed. And one author said that using intraoperative bronchoscopy only during their initial experience, but discarded it later on. For the surgical approach, the lateral anterior thoracotomy is the most common. It's about 72%, and sternotomy is only 12%. For the follow-up, the improved case is in about 80%. In a recent study in 2016, they discussed surgical approach to autopexy in Boston Children's Hospital. They found that partial sternotomy approach may have a better outcome than other group. The partial sternotomy group have 100% improved work of breathing. And also in this group, they use simultaneous bronchoscopy more often than other group. Partial sternotomy is amenable to continuous intraoperative bronchoscopy, allowing the effectiveness of the autopexy suture to be determined. For the slide tracheoplasty, other study also mentioned about the wide application of bronchoscopy in all patients at the beginning of operation and immediate post-operation for checkup of suture and air leak, though they didn't discuss the outcome related to intraoperative bronchoscopy. In our conclusion, bronchoscopy is not only a tool for diagnosis, but also a monitor in operation. According to the scope, the surgeon can modify the autopexy, especially in partial sternotomy approach, which may be related to good outcomes. In slide tracheoplasty, it's a good tool for diagnosis and immediate post-operation checkup. For complicated case, it may be a feasible tool for treatment. Thank you for your attention.
Thank you for your very informative presentation. Dr. Lin, did you get any questions from the audience?
Yes, I will begin to answer the question in the chat box. Can you hear me?
Yes, of course. Yes.
Oh, okay, thank you. So the first question is from Dr. Song. Would you try to balloon dilatation or stent insert before more invasive surgical approach? I think that it's different. It depend on different condition, and just like the third case, we do the balloon dilatation many times before the surgical approach. But for the first case, the tracheomalacia, and the second case, it's a tracheostenosis. we think that surgical approach is now is a safe policy to do this surgical. So we didn't do the balloon dilatation or scan insert before the invasive surgical approach. That's the first answer. And so the second one is the bronchoscopy via the endotracheal tube. No, I think for the case they do the intraoperative bronchoscope, they do via the endotracheal tube. Yeah, yes, it's via endotracheal tube, right? Just during the operation, they via the endotracheal tube. Yes. So.
Any more questions from the chat box? May I ask, if there's no question, may I ask one for you?
Yes, sure.
Yeah. First, what's the additional time needed to perform the intraoperative bronchoscopy during the surgical procedure?
We think that for the tracheomalacia, if you do the autopexy, we think that when we do the sternotomy and do the elevation of aorta, and the first you didn't fix when just before the aorta fixation, you need the first intraoperative bronchoscope and to see the outcome if the elevation is enough or not. So this is for autopexy. And for the tracheoplasty, it's when the when the end of surgeon, when the end of the procedure, you can use the intraoperative bronchoscopy to check if there is any air leak or is there any lesion you didn't check. So it's the time to do the intraoperative bronchoscopy.
Okay, thank you. Because of the time constraint, we have to close this presentation. I will hand the microphone to Dr. Chen.
Okay, thank you. And thank you, Professor Xie. And let's move to the next session. And the next session is our satellite symposium. The topic is the scientific publication, artificial intelligence, and the microbiota and transplantation. And I would like to welcome our moderator, Professor Qingyuan Lin. Professor Lin. Okay, Professor Lin, please. Professor Lin, please turn on your microphone.
It's my great honor to have this opportunity to introduce Professor Gao Yuru. Professor Gao Yuru attended his BS from the Department of Biology, Donghai University, Taiwan, and his PhD from the Department of Physiology and Biophysics, College of Medicine, University of Kentucky, USA. He received his postdoctoral training from the Division of Pulmonary and Critical Care Medicine, University Hospital, Case Western Reserve University, USA. Dr. Gao started his academic career at the Department and Institute of Physiology, School of Medicine, National Yang-Ming University, Taiwan. He also has a joint appointment at the Institute of Emergency and Critical Care Medicine in the same university. Dr. Gao is interested in the areas of neurophysiology and respiratory physiology. He is also actively involved in research related to critical care, pediatrics, otolaryngology, respiratory care, and pulmonary medicine. He has trained 30 PhD students, 37 master students, and 3 postdoctoral fellows. Dr. Gao has published more than 180 original articles in international peer-reviewed journals and contributed one book chapter. He is an academic editor for Roseman and an editorial board member for scientific reports. He is an associate editor for both respiratory physiology and neurobiology and French in physiology. And the topic of Dr. Gao is how to begin writing your manuscript. Professor Gao, please.
Good afternoon, everyone. The topic I would like to discuss with you today is how to begin writing your manuscript. Imagine that writing a manuscript is just like cooking a dish. Without preparing a good writing plan, you might get stuck in the middle and usually have two major questions: what to write and how to write. A good writing plan is just like a good recipe. As we all know, before cooking, we need to come up with a recipe. A recipe can indicate essential ingredients, which are the literature and backgrounds we need to know. And this is for the question of what to write. A recipe can also give us the precise step of cooking, which are the logic and flow of our writing. And this is for the question of how to write. Importantly, we can use the writing formula ABC to construct this writing plan. Therefore, the rest of my talk will focus on how to use this writing formula. The ABC I'm referring to is that for each study, we usually have three major players. A represents the subject we study, and these are usually patients or certain diseases. B represent the treatments, such as drugs, doses, therapies. B can also represent pathogenic or risk factors, such as parental smoking, toxin exposure, and this is in the observational study. C represents the outcomes we need to measure, such as infection, neonatal RDS, bronchopulmonary dysplasia, etc. Here I present an example of how to use this writing formula. In this example, the author studied the development of monocyte toll-like receptor 2 and 4 in preterm newborn during the first few months of life. As we all know, toll-like receptor 2 and 4 are two types of pathogen recognition receptors that are important for the immunoregulation. Therefore, we just simply identify preterm newborns as A, which is the subject, toll-like receptor 2 and 4 as B, which is the mediating factors, and their development during the first few months of life as C, which is the outcome. Now we have to start thinking about what to write and how to write by raising some specific questions as our writing plan. And this question need to be answered by getting the references and knowing the background for answers. First, we start thinking with A. So for preterm newborn as we need to know the prevalence, etiologies, and consequence of preterm newborns. Then we start thinking with B. For toll-like receptor 2 and 4, we need to know what are they and their functions in the immune system. We then logically connect A to B. Therefore, we need to know an important aspect regarding the immature immunity in this patient population. Next, we can start with thinking with B. For this purpose, we need to know the deficiencies in expression and functions of toll-like receptor 2 and 4 in this patient population. And then think about C. For this purpose, we need to know the postnatal development of every aspect of the immune system in this patient population. We then logically connect B to C, and therefore we particularly need to know postnatal development of these two types of toll-like receptors in preterm newborns. Finally, we start thinking altogether with A plus B plus C. For this purpose, we possibly need to understand whether we know the postnatal development of toll-like receptors, particularly during the first few months of life. Evidently, it was still unknown at that time, and that was the reason why the authors could perform their study. Additionally, we also need to explain why we think that this topic is important. In this case, we can say this is important because these preterm newborns are easy to get infection during the first few months of life. And this explanation would give a good rationale for the study. What we have demonstrated here is that by using the writing formula ABC, we would be able to come up with a good writing plan regarding what to write and how to write. The writing formula ABC can also help us to efficiently correct and retrieve references. As shown here in our computer, we can initially preset some empty folders and subfolders. Here we can see A, B, C as premature newborns, toll-like receptors, and their postnatal development. According to the writing plan we just constructed, for preterm newborns, we need to correct references regarding their prevalence, consequence, and deficiencies. I only list 3 subfolders here, but it can be more to be listed if necessary. For toll-like receptors B, we need to correct reference regarding what are toll-like receptors, what their function in immune system, and what happens when they are dysregulated. For postnatal development, we probably need to correct reference regarding differences in postnatal periods, such as 1 month, 1 year, or 10 years. Difference in various aspects in immune system. And the postnatal assessment of several various outcomes. So these are the empty folder and subfolder we can initially create it. For each folder and subfolder, we can also create 3 empty subfolders. Here I present an example of correction reference relevant to difference in postnatal period. If our impression about certain reference we collect is very important to this topic, then we store them into these folders, important article. If the reference we collect are only relevant to this topic, then we store them into the other 2 folders. One additional suggestion is that, as we can see here, is the screen of PubMed search. Here we can download the PDF file of this particular references. Here we can also see the abstract. With some additional time, we can simply copy and paste the abstract into a text file. So the text file we can store into a file name as abstract. So in the abstract, we can know the author's name, the title of the article, and where they or when they are published. We also know the background method, result, and conclusion. So say, for example, in this particular topic, difference in postnatal period, and in the subfolder of important article, if we download some 20 PDF file for references, then we can have one Word file of abstract, and this will contain 20, 30 abstract into this file. So when we need to check or to write this topic, we are not necessary to look through all this file into detail, but maybe just simply open this abstract file for further information. So the writing formula and writing print can give you a strategy which is good for what to correct, where to store them, and where to retrieve them. Here I show an example of how to use writing formula and writing print to write the introduction. In the introduction, the first paragraph, we can first introduce A, B, and then A to B. And then we can raise a question regarding an unknown issue of A plus B. For the second paragraph, we first introduce B, C, and then B to C. Now we can have the question of the study, the major question of the study as A plus B plus C, and come up with the major questions. In the third paragraph, we simply state the objective hypothesis and the approaches of this study. So 3 paragraphs can solve the problem of writing a good introduction. You can analyze this writing print using the writing formula, the strategy for each article you read, because you often find the strategy is commonly used for most of the authors to write their introduction. Here is the introduction of the study. I'm not going to go into detail with you, but if we analyze the first paragraph, we can identify some statements related to A, related to B, and certainly related to A plus B. If we analyze the second paragraph, we can identify statements regarding B, then regarding C, and certainly to B plus C. We can also find a final statement, crucial statement regarding A plus B plus C to generate the research question. In the third paragraph, we can easily find the objective of the study, the hypothesis, and maybe the approaches of the study. So, in conclusion, number one, do not write your manuscript before making the writing plan. You can use the writing formula ABC to come up with a good writing plan, which is the recipe for cooking. A good writing plan can strengthen the logic and flow of your writing. A writing plan can solve the problems of not knowing what and how to write. A writing plan can also efficiently enhance the collection and retrieve of the references you collect. This is how you begin your writing, your manuscripts. Finally, if the reviewer had the same recipe as yours, they are most likely to buy your story and accept your article. Thank you for your attention.
Any question or comments from the audience? If not, may I ask the first question? Professor Gao, can you
Yes.
give us some information and our suggestion how to prepare a figure or table?
Okay, figure and tables are two different things. Table usually construct by Word software. So this just go alignment with each column, and that will do. But for figures, usually I found my student who give me the PowerPoint file for figures, and these figures these files are not acceptable when you submit the file to journal, to most of the journal. So you need to use certain professional image software, such as Photo Impact or Photoshop, to construct your figures. And for each figure, you need to look out for the resolution, the file size, and whether they are color or black-white files. And these are the preliminary setting you need to figure out before you make up the figures. Well, that's a very long course for how to prepare your figure with sufficient quality. So this I'm not going to go into detail.
Can you talk more detail about what time you choose table or figure to illustrate your result?
Okay, that's a very good question. Usually we use a table to represent data of supported data. We use figures to present the major data. This is because in the table we need to list numbers which are difficult to be recognized by the reviewer or by the reader. Then if we use figures, either we use bar diagram or curve diagrams. And these data are more easily to be recognized. So what I mean is supported data use table, major data use figure to present. Thank you.
Okay, thank you.
Is there other question or comment from the audience?
Yeah, I think there are two questions in the chat box, but I think because the time is limited and we can ask the Professor Gao to answer the question in the chat box. Okay. Okay. Thank you, Professor Gao and Professor Lin. And then let's move to the next session. Next session, I would like to welcome our moderator, Dr. Shenlin Zhang. Dr. Shenlin Zhang, please.
Okay, I'm Dr. Zhang from Taiwan. It's my honor to introduce Professor Li Jianzhang. Li Jianzhang professor is from Taiwan. He is a doctor of science, Harvard University, and now is a famous data scientist. He is also a pediatric emergency physician. Now, Professor Li Jianzhang is the Deputy Director of AI Center at National Taiwan University Hospital. And he is also the President of Taiwan Society of Pediatric Emergency Medicine. Professor Li's main research approach is the use of the data science to solve clinical problems. So far, he has published more than 200 SCI scientific papers. This time, we are happy to invite Professor Li Jianzhang to present application and the experience of AI in pediatric emergency, and the opportunities and the challenge. Okay, please, the Professor Li, please start.
Hi, everyone. I'm Dr. Junjiang Li, the president of Taiwan Pediatric Emergency Medicine Society. I feel honored to be invited by the Asian Pediatric Pulmonology Society. We all know that AI has become a heated topic in every discipline of medicine. Today, I'm going to share some of my experience and viewpoints on the use of AI in pediatric emergency medicine. The COVID-19 accelerated the digital transformation of medical practice, and the AI papers hit record high. As of now, there are approximately 222 medical AI applications approved for clinical use by the FDA. Therefore, it is well expected that these approved AI systems will soon change our practice in the near future. Let me walk through some potential applications of AI models in pediatric emergency department. We all know that ED overcrowding is becoming a serious problem worldwide. Therefore, a rapid and accurate triage tool is very important for the operation of a pediatric emergency department. In Taiwan, we use the 5-level triage system, which is a modification from the Canadian ED triage system. However, the emergency severity index system developed in the United States is more widely used worldwide. By ESI, children with life-threatening or critical conditions are triaged as level 1 or 2. The remaining children are then triaged to level 3 to 5 based on the number of resources they may use in the emergency department. Patient triage to level 3 to 5 can be upgraded if the patient presents with danger zone vital signs. So, ESI does not use fixed criteria to triage patients. Instead, it is highly dependent on the triage staff's experience and judgment. Although ESI has been shown to be well correlated with clinical severity, the reality is over 50% of children were triaged to level 3 or below, many of whom deteriorated while they were waiting in the emergency department. The sick children may present a wide range of vital signs and conditions. Solely dependence on the nurse judgment or some fixed range of vital signs may not detect children with potential deterioration risk. The high-dimensional feature of the variables need to be considered in a triage nurse is not easily handled by traditional regression analysis. In addition, traditional regression analysis does not detect complex interaction problems. AI algorithms are very suitable to handle these problems in data analysis. We ran an experimental analysis on the CDC NHMACS database, which is an open ED triage database representative of the National ED of the United States. We used several machine learning algorithms to predict the 30-day mortality and ICU admission. The results showed that the machine learning algorithms can improve the predictive accuracy from 0.72 of the traditional ESI to 0.8986 by the machine learning model. As shown by the table, compared with ESI classification, the machine learning triage increases the event rate of triage level 1 and 2 patients and decreases the event rate in level 3 to 5 patients. In total, the misclassification rate could be greatly reduced from 38% to 21%. Our data show machine learning has a great potential to improve pediatric ED triage. Another major type of AI application in emergency department is risk prediction. Let me take the minor head injury cases as an example. Based on a United States-based research in 2012, the CD utilization rate for children presenting with minor head injury varies across hospitals. Some hospitals use a lot of CT, but others did not. Currently, the evidence-based CACON head CT rule is widely used to help physicians to decide who should undergo head CT exam. Although it is easy to memorize, but there's no need for busy emergency physicians to memorize these rules when computers are widely used in the emergency department. A team from MIT uses a novel machine learning algorithm called optimal classification tree to reanalyze the PACON databases. Results showed that machine learning-based decision rule has a comparable sensitivity, but superior positive predictive value as compared with PACON rule. In other words, less children with minor head injury will need a head CT exam if the machine learning algorithm can be applied. The last applications case I'd like to share is the machine learning-based image auto-interpretation system. The Center of Intelligent Healthcare of National Taiwan University Hospitals developed a COVID-19 image AI interpretation system using the Open Chest X-ray database. Adolescents aged greater than 15 years can also use this system. The system is packaged as a user-friendly web-based app. Either plain chest X-ray or CT can be uploaded for automatic interpretation. The system integrates three main functions: description, diagnosis, and prognosis. The system will first show the 5 common chest X-ray patterns. As shown in this slide, the AI reported the presence of atelectasis. The right side of the picture shows the heat map, indicating the areas that the AI system detected as lesion areas. The system also gives the probability of COVID-19 diagnosis and other lung diseases diagnosis. The system also gives a quantified severity score. We also developed a system to interpret CT image. The CT image will show the probability of COVID-19 as compared to the diagnosis for pneumonia. In contrast to conventional reports, the system can give a quantitative severity score, which opens more future application probabilities. I have to remind the audience that the machine learning image test is not a definitive test like PCR. Rather, it is like a radiologist image report. The report should be interpreted in the context of pretest probability. We propose a diagnostic algorithm similar to the use of a rapid antigen test for suspected COVID-19 patients. If the patient is symptomatic, a positive machine learning image test indicates SARS-CoV-2 infection. If asymptomatic, a negative machine learning image test plus negative exposure history may indicate no need for quarantine. For other, more complex conditions, a second test is needed to guide the appropriate management. After the introduction of three major types of AI application in pediatric emergency department, you may think the future of the medical AI is promising and exciting. However, it will not be a road without bumps. I would like to quote Churchill's words to describe the current situation. Now, this is not the end. It is not even the beginning of the end, but it is perhaps the end of the beginning. There are several challenges ahead. The first challenge is the lack of appropriate validation. There are two major types of AI validations. One uses benchmark databases, while the other tests the AI models in the clinical settings. Validation using a benchmark database is cost-saving and efficient. However, the database is usually a collection of typical cases and healthy controls. In the real world, the patient's presentation is a spectrum rather than dichotomous. Benchmark databases only captures the population at the two extreme ends. This type of the database tends to over-evaluate the performance of an AI model. Unfortunately, nearly 93% of published models are only validated in a benchmark databases rather than a real-world settings. A comprehensive validation of an AI model should include real health analytics, user experience analytics, and product performance analytics. Real-world health analytics analyze the human factors in usability engineering, clinical safety, and health benefits. User experience analytics analyze user satisfaction, issue resolution, user feedback channels, and user engagement. And the product performance analytics analyze the cyber security product performance. The second challenge I'd like to mention is the regulation challenges. As AI models are going to be implemented in the clinical setting, like other medical devices, it has to be regulated to ensure efficacy and safety on patients. Medical AI software is called SaMD, software as a medical device by the FDA. It is defined as AI or machine learning-based software when intended to treat, diagnose, cure, mitigate, or prevent disease or other conditions. The FDA applied a similar risk categorization on this SaMD like a medical device. Class 3 and 4 SaMD may need a clinical trial before approval, but Class 1 or 2 SaMD usually do not need a clinical trial. Another unique feature for SaMD is it can change over time. It will learn from clinical applications and experience. So there are two major types of SaMD. The locked algorithms means the model parameters will not be changed after implementations. Therefore, they will provide the same results each time the same input is provided. The other type is adaptive algorithm. The adaptive algorithms changes its behavior in a continuous learning process. The adaptive feature of the AI model may not be compatible with the current medical device regulations because the model is no longer the exact model approved by the FDA. Therefore, the FDA launched a new certification process named Pre-Certified Program. In this new framework, the FDA will certify not only the product, but also the company. If the company has a transparent and documented protocol that regularly monitors the safety and efficacy of the AI models, then minor changes of the model after approval may not need recertification. The last, but not the least challenges, is the reimbursement issue. Unlike a laboratory test or imaging test, the AI model does not need test kits or staff operation once the app is set up. How to reimburse a medical AI system becomes a challenge. The complexity, accuracy, and cost of maintenance varies across systems. The VIS AI is the first system that obtains an additional reimbursement from the CMS of the United States. These kits set an example for future systems. The VIS AI system is an AI-based stroke image detection and interpretation system that also coordinates the pre-hospital to hospital care of stroke patients. The company launched several real-world researches. In the real-world head-to-head comparison studies, the system showed it can save time, improve outcome, and increases access to care. Therefore, the VIS LVO was granted with a $1,040 new technology add-on payment. This reimbursement model may open a new data economy framework in the future. In conclusion, in the near future, we can see many AI systems used in the pediatric emergency department. They aid physicians in patient triage, risk prediction, and image interpretation. However, the healthcare system may need to make changes in the regulation and reimbursement system. In addition, it has to be noted the AI needs to be validated by a rigorous prospective validation process to ensure the safety and efficacy in real-world practice. Thank you for your attention.
Okay. Thanks for Professor Lee's great talk. May I ask one question?
Sure,
Okay.
please.
Okay. AI application for medical care is now a hot topic. However, the common problem is how do we know the AI interpretation error and how to deal with it? Thank you.
Yeah, this is very good questions. I have explained in my slide that there are two types of AI. One is the log system, the other is the adaptive systems. So for the log system, it's easier. You can view it just like a laboratory test. So the AI system from a company or from a laboratory have to report their sensitivity and specificity to the physicians. So you interpret it just like a laboratory test. You use the pretest probability plus the sensitivity and specificity of the AI diagnosis and make your final clinical decisions. So the adaptive algorithms, it is more complicated. because the AI is learning in a continuous process. Therefore, the hospital has to set up a system that regularly updates the latest sensitivity and specificity, the accuracy of the model to the physicians. And the physician have to judge their clinical decision based on updated accuracy index. So this is my proposed answer to these controversial questions.
Okay. Thanks for Professor Lee's answer. Because the time is limited, so we need close this lecture. And we thank Professor Lee again, and go on to the next lecture. Thank you.
Okay, thank you, Professor Lee and Professor Zhang. And let's move to the next session. Next session, I would like to introduce our moderator. Our moderator is Dr. Shenhao Lai. Dr. Lai, please.
Good afternoon, everybody. I'm Shenhao Lai, come from Chang'an Memorial Hospital. It's my honor to introduce Professor Jianen Wang. Professor Wang is the chief of the Division Pediatric Pulmonology in National Chang'an, in the Chengkong University Hospital. He's the expert in the field of pediatric cardiology, pulmonology, and the critical care. His research interests include the intervention of congenital heart disease and the post-op care. He already published more than 90 papers in SCI journal till now. In these years, he applied artificial intelligence into critical care in children and have an amazing result. Now we welcome Professor Wang to give this lecture. The application of AI in pediatric critical care. Please start, Professor Wang.
Mr. Chairman, my dear colleagues, ladies and gentlemen online, I would like to thank the organizing committee to invite me to present this topic, application of artificial intelligence in pediatric critical care. I am Jianen Wang from National Chengkong University, Tainan, Taiwan. I have nothing to disclose. This congenital heart disease infant received emergency operation. After the operation, he was admitted to PICU to receive critical care. You can see that the sternum is still open and on ventilator support, there are many tubes on his body. So on the monitor, you can see the heart rate is very fast. The blood pressure is low. Although the pulmonary artery pressure is okay, but the body temperature is very high. The SpO2 is a little bit low under the ventilator support. The cardiac output monitor is 1.19 is acceptable. Are these tools enough for the critical care? How many data do you need? Do you need to take care of this patient? Imagine that we can obtain the traditional hemodynamic data. You can know the heart rate, blood pressure, CBP value, cardiac output, cardiac index, and you can have the echocardiography for the real-time monitor, and you can have the arterial blood gas continuous monitor. You can monitor real-time EEG monitor. You can look at the cerebral O2 situation, and you can have the mid-band O2 situation. Are these data enough to take care of this patient? Is there how many data would you need to take care of the patient? Do you want to actually you will want to monitor everything for the critical care. Therefore, you have so many data in hand, so-called big data. how to deal with these big data, which we have a mirror to tell us what to do. Therefore, that's why we need the artificial intelligence, AI, for the help to deal with this big data. There are some terms of artificial intelligence, including machine learning, deep learning. This table shows that the machine learning and the definition of the machine learning and deep learning. Machine learning, it means that you can perform with a similar amount of data. And deep learning means it can benefit, the machine can benefit from a large amount of data. Machine learning can work on the low-end machine, but deep learning needs a very high-end machine to training. But you can output the data run on the low-end machine. And the machine learning means depends on the specific function to reach a conclusion. But deep learning can learn very complex function to reach a conclusion, like a human brain. And machine learning is an important feature and must be identified to help by an external expert, means a human expert. But the deep learning still have evolved into the neural network determinant most important feature do not need identified by an expert. Machine learning is a short time for the training, but deep learning needs long time for the training. And machine learning use statistical methods to improve their experience. And the deep learning means mimics the function of human brain neural network for the training. Dr. Lansdale, in his review article in the journal Pediatrics last year, summarized the machine learning and artificial intelligence in recent pediatric research focused on perioperative and critical care. He summarized some examples for the benefit for the AI in the critical care. The first one is AI and machine learning could use in prediction the severity and mortality. And machine learning can use for the need for the PICU admission and prediction of the cardiac arrest during critical care unit admission and prediction of sepsis. Decision support for the ventilation, mechanical ventilation, and improving data with new technology. In the ancient history, the best doctor is like a wizard. They need to predict the natural history, nature cause, disease cause, and prevent the adverse effect. When talking about the prediction in pediatric critical care, decades ago, Dr. Pollack developed a pediatric risk of mortality score, so-called PRISM score. He using some common variables such as systolic blood pressure, but including age, different age and different heart rate, different score, and diastolic blood pressure, and the heart rate, respiratory rate, PaO2, PaCO2, Glasgow Coma Scale, pupil reaction, prothrombin time, total bilirubin, potassium, calcium, glucose, bicarbonate. Totally summarize, and you have the different scoring, and you can come out using this score to calculate the risk. He used a complex equation and using the PRISM score, age, and operating states, using the logarithm, and to come out with a proportion and the prediction. We have used this PRISM score to compare the outcome of injured children between the PICU and SICU. Our data show that although the patient admitted in PICU was much younger, but the ICU stay and the severity and mortality rate were not significant different between two units. However, the score is valid in very high-risk patient. You can see that when the highest risk patient and the predict patient of mortality was 8.22, but we observe on 8 was very compatible. But in the high risk score 21 to 30, we predict 6.29 patient and we observe 6 patient. But in the moderate risk, we predict 5.17, and we observe 7 patients of mortality. In the low risk group, we predict only 2.9 patient mortality, but we observe 7 patients. So this score is not suitable in the low risk patient in Taiwan. Therefore, we further use an update PRISM score 3. There are more variable, more data, more complex equation we require to correct the cardiovascular, neurologic vital sign, acid-base, blood gas, chemistry data, and hematologic tests to come up with a PRISM 3 score. The PRISM 3 score predict 373.4 patient survival and 30.5 patient mortality, and we observe 371 survival and 33 patient death. So the z-value was 0.65, and it showed that it's very compatible to the prediction mortality in Taiwan. However, we further analyzed the high-risk and low-risk patient. The p-value was between 0.25 and 0.5, when the chi-square was 2.22. So it means that the score can be used, but still need to be improved in the low-risk patient. There are so many scores for the different purpose. Dr. Olive summarized in his paper and showing that using the bedside pediatric early warning score, correcting the scoring common item to predict urgent admission to PICU. Another score is predict pediatric early warning score, is using the nursing administrative score, CNS, CV, respiratory status, family and nursing concern to predict unplanned PICU transfer. The other is cardiac children's early warning score, also using the common nursing administration score to predict the cardiac arrest or unplanned transfer to PICU. And another is update predict PRISM score 6 version and predict the mortality using the 17 physiologic variable. Another one is pediatric index cardiac surgical intensive care mortality using the multivariate logistic regression, including physiologic, anatomy, and procedural variable to predict the mortality. And another score for neonatal use is neonatal acute physiology scoring using the 6 common components in the first 12 hours of life to predict the mortality and morbidity. Dr. Ruiz, in his study, using routinely corrected data and import the machine learning and the clinical expert knowledge to develop and evaluation the model of prediction of the critical events in infant with single ventricular physiology. According to his data, when the clinical expert look at all 33 variables, he can predict the critical event 1 hour before the event with 0.68 accuracy. But if you want him to predict 8 hours before the critical event, the accuracy will below to 0.49 accuracy. the very similar for the clinical expert too. But if you look at only 16 variable, not much data, the accuracy will lower. But if there is clinical expert knowledge, import the data derived from conditional probability table, the accuracy will increase. 1 hour before was 0.88 accuracy. And you can see that if the clinical expert plus conditional probability table and future selection, the prediction rate 1 hour before was 0.87, and 8 hours before was 0.64, was increasing. So example, for all the probability prediction, you can summarize, get an equation, obtain an equation. 1 hour before was 0.88 correct accuracy, and 8 hours before was 0.672 correct accuracy. Dr. Olive, in his study, developed an IDO2 index. It means a software technology integrate patient data from multiple different sources. Because you cannot rely on only one data, you can see that when the heart rate was still stable until the cardiac arrest event, and say saturation and blood pressure and the feeling and the lactic acid level is not easily. But if you integrate all together to come up with this IDO2 index, and you can see that before the cardiac arrest 5 hours ago is significant warning increase. Significant warning increase, so you can predict the cardiac arrest events 5 hours before. When we look at the heart rate change on EKG monitor, there is a term of heart rate variability, HRV. They already had many data using the heart rate variability to predict the risk. We previously also used heart rate variability to examine the patient with enteral 71 infection. And you can see that our data show that in the stage 1, it means a non-complicated infection. In stage 2, encephalomyelitis stages, and stage 3, the severe autonomic system dysfunction. You can see that the SDNN, RMSSD, the power, including total power, low frequency and high frequency power, in the state when the disease progression to stage 1 to stage 2, even to stage 3, there's a significant change of the heart rate variability variable parameter. We can see that using the heart rate parameter change in this patient, you can see that when the heart rate did not seem the significant change. Blood pressure, you do not know the significant, but during the critical hour, the total power decreased significantly, and that during the getting improved in the 16 hour, you can see the total power gradually improving. And we summarize all the data together, and you can see the stage 1 patient and stage 2 patient. And when the patient going from the stage 2 to stage 3, you can see the total power decrease. When the patient in the stage 3 with good outcome, the total power is improving. But if the poor outcome, the total power is decreasing. Therefore, our team would like to develop a system to detect the cardiac arrhythmia automatic screening using the discrete fraction order integrate process, a meta-learning based intelligent classifier to detect arrhythmia and calculate the RR interval. This is our flow chart of meta-learning model for the EKG analysis. We obtain the ECG record and filter the noise and artifact and detect the R peak and extract the QRS complex and put into the meta-learning stage into the fraction order integrate process and the new training and develop algorithm. We also need to get the database from the MIT database for the training and to make sure our algorithm is correct to get our sum result. This complex equation show how the machine learning equation and meta learning station and to adjust the parameter to get the output data for the summary. In brief, after the AI training, our algorithm could detect the arrhythmia, and to calculate the RR interval for the further analysis. Our team also used the concept of computer-assisted auscultation. Initially, we obtained the data from the AV data to record the sound and for the analysis. This computer-assisted auscultation means using the detection based on auditory, time, and frequency domain analysis. You can see in brief, when we get the phonocardiography from the heart sound, and you turn into the auditory spectrum, and we need to analyze with the spectrum flex and the spectrum centroid to tell the difference of PDA murmur, innocent murmur, and normal heart sound. When you look at the normal heart sound A, or the innocent murmur B, and the PDA murmur C, according to the phonography, it's very difficult to tell the difference. But when you see the auditory spectrum for the ABC, you can see a little bit difference. But if when you take the spectrum flex, spectrum centroid, you can tell that the PDA murmur was significantly different from the functional murmur and the normal heart sound, and obtain the data according to our algorithm. The sensitivity was 100% right, 192% specificity. In this study, Dr. Sommer would like to use the computer-assisted auscultation to detect the pneumothorax detection, and he proposed an animal study, and for the further clinical trial. According to his data, you can see that the animal data, you can correct the sound and to detect and using the digital stethoscope to detect the pneumothorax. AI could also using to predict the pediatric typical airway. When you look at the face and you input some data, some clinical characteristic, and using the algorithm to output the data to make the decision for the easy mask ventilation, difficult mask ventilation, or easy intubation or difficult intubation. I think this is very useful for the general pediatrician for the predict the pediatric difficult airway use. AI include both manual action and feedback. You can see the data, the prediction and action, then the human feedback. But the dream is the automation. Means the real-time feedback to further like a human brain for the further action. Therefore, in conclusion, data-rich clinical condition of the ICU setting is ideal for a new AI-centric approach to data, all the information and the knowledge for the new AI tool and data strategy. New AI in medicine paradigm is machine intelligence plus clinician human intelligence. We hope to obtain the further dream of the medical intelligence. I would like to thanks for the attention. Thanks. Any comment or question?
Thank you, Professor Wang. It's a wonderful lecture and congratulate your amazing result. Because the time is limited, our time, schedule is delayed, so only one question. Just wonder if you use this AI application into your clinical care about in PICU and change your decision making and even decrease your the mortality and the morbidity in your PICU. Please.
Thanks. The lie, I would like to say, but thanks for you is a wonderful and very important question. I think because we are this is just the very beginning, because we are trying to input collect many data. I think we are now working on it. Collect our team is working on to calculate from the ECG monitor. First, we want to calculate the variability index and make sure to predict the neonatal, especially the neonatal bradycardia the episode. But I think that we still need to working together to collect more data and can tell you further, maybe a couple years later, we hope we have more data to tell you what I can do and which data is important for the critical care. So now I think probably we need to, most important, hemodynamic data first.
Oh, that's great. I hope in the near future we can use this AI to change our the quality of our PICU care. And there are still some questions in the chat box, but we all have limited time. So please to answer this question in the chat box. And this is the end of the lecture. Thank you very much. Thank you again. Bye.
Thank you. Bye-bye.
Okay. Thank you, Professor Lai and Professor Wang. It's a wonderful talk. And now we have my 5 minutes break. And please come back in 5 minutes. It will be 4 o'clock. Thank you. Okay, please start.
So FeNO stands for fraction of exhaled nitric oxide. So it's simply the concentration in parts per billion of nitric oxide in exhaled air. Nitric oxide is released by the cells that line the airway. And that release is to some extent under the control of IL-13. Now, IL-13 is a cytokine that's intimately involved in type 2 immune responses. So when there's IL-13 activity in the airway, there's increased nitric oxide production, which you can detect by measuring it in exhaled air. So a normal FeNO is under 25 parts per billion, and a reading of above 50 parts per billion is really very suggestive of type 2 airway inflammation. And this type 2 airway inflammation is a critically important treatable trait in patients with airways disease. So it's something that you really do have to assess and know about for a number of reasons. Firstly, patients with asthma and type 2 airway inflammation are known to be at risk of asthma attacks. And this risk is particularly high if they have a high FeNO and a high blood eosinophil count. So if they've got the two together, we know that group of patients are at between a 3- and 5-fold increased risk of having an asthma attack. And that increased risk is independent of lung function and symptom scores, GINA treatment steps. So I see FeNO and blood eosinophils as like the airway cholesterol and blood pressure. You know, they are markers that tell you that the patient is at risk of a serious event, which is an asthma attack. But this risk is modifiable with treatment. So we know that you can reduce the risk down to very low levels with appropriate treatment, whether it's inhaled steroids in a patient with mild asthma or biologic treatment with anti-IL-5 or anti-IL-4/13 in patients with more severe asthma. So FeNO identifies a crucially important treatable trait, and it's absolutely essential that it's assessed in patients with asthma. Well, of course, asthma is defined based on the demonstration of variable airflow obstruction. But I think what we've learned in recent years is that there are different types of asthma, and it's simply not good enough to identify asthma. You need to identify what type of asthma the patient's got. So type 2 high asthma, so this is asthma with evidence of type 2 airway inflammation, is a particularly important asthma to identify because we know this group of patients are at high risk of having asthma attacks, and we know they respond particularly well to corticosteroids and to biologic agents. So I don't think in the 2020s it's sufficient to diagnose asthma. I think you've got to go beyond that. You've got to characterize the asthma. And there are two processes that I would be particularly interested in measuring. One would be airflow limitation, because we do have good treatments that can improve lung function in asthma, and patients are likely to benefit from those treatments. Bronchodilators. And secondly, type 2 airway inflammation, because we've got good treatments that can modify that. What we now know is that there is not a very close relationship between disordered airway function on one hand and type 2 airway inflammation on the other. They are to some extent, independent treatable traits that drive different clinical problems. So disordered airway function drives symptoms, obviously very important, and we know we can modify that with bronchodilators particularly. Type 2 airway inflammation seems to particularly be associated with asthma attacks. We know we can modify that with different treatments. So it isn't adequate now in the 2020s to just identify variable airflow obstruction. That's a good start, but you need to go beyond that and look and say, okay, this person's got asthma. What type of asthma do they have? And how should I treat it? What are the treatable traits here? And what's the most rational treatment approach?
Okay, welcome back. And let's move to the next session. And in the next session, we will have our moderator, who is Professor Shida Xu. Professor Xu, please.
Yes, this distinguished guest, dear colleague, ladies and gentlemen, the Association of Microbiomic and Metabolomic in gut-lung axis and childhood asthma had got great advances in recent years. Today's lecture is chaired by me, Shida Xu, Professor of Pediatrics, Allergy, Immunology, and Pulmonology, Mackay Children's Hospital. We will have about 20 minutes for today's talk. It is my great honor and privilege to introduce you the speaker of today, Professor Zhiyong Qiu. Professor Zhiyong Qiu came from Chang'an Memorial Hospital at Linkou. He is the professor of pediatrics pulmonology. He had finished his PhD training at the Imperial College London. He is a co-principal investigator of a first cohort study in the prediction of allergy in Taiwanese children, Jones study initiated since 2007 to investigate the epidemiology and predict vector of asthma and allergy in Taiwanese children. His topic of today's lecture is integrative analysis of microbiomic and metabolomic for childhood asthma. Let's give a warm welcome to Professor Zhiyong Qiu. Professor Qiu, please.
Hello everyone, I'm Zhiyong Qiu from Taiwan. Today I would like to talk about my project, an integrative analysis of microbiomics and metabolomics for childhood asthma. There's no any conflicts of interest disclosures for my talk. We know about the diversity in the human microbiome. This project is launched in 2007. For childhood asthma, we just want to know about the airway microbiome. So the first we want to know how about the airway microbiome. There's a very popular, very interesting paper just published in 2017. We know from this figure, the nasopharyngeal microbiome changed since birth to 1 year old, and they will get in to be stable for the microbiome maturation. We also know there's a lot of factors, including the host and the environmental factors, that will influence the respiratory microbiome. For example, birth mode, or feeding type, or siblings, or daycare centers, something and so on. So in clinical practice, we know about that allergen sensitization, especially for the mild sensitization, is very, very important for the development of asthma and rhinitis. So firstly, we want to know about the relationship between the airway microbiome and the allergies. For trying doing this, we review the airway microbiome in asthma. We know the airway microbiome maturation process appears to be stable during infancy, just that I talked about the paper before. However, a higher prevalence of allergic asthma develops after age 2, with a possibly associated with sensitization to house dust mite. So we hypothesized that the dysbiosis of the airway microbiome would underlie susceptibility to the development of asthma. So we try to evaluate the relationships between the airway microbiome and the atopic index and the childhood asthma. And this slide shows the study design for the lung microbiome in asthma. We choose the case control study, and we use the high-seq Illumina platform for the children around 3 to 5 years old, and collect their throat swab samples by using the 16S RNA amplification to identify the airway microbiome. So this is the microbiome analysis flow chart. We use the CHARM method to analyze the OTU units to identify the diversity and the richness of the airway microbiome, and try further to identify the differential abundance of microbiome between the asthma and the healthy control. So this is the characteristics of children that we enroll the asthma and the rhinitis and health control into our study. So there's around 30 children with asthma or rhinitis and health control. And not surprised that the total serum IgE and the mild sensitization of food saliva were significantly higher in children with asthma and rhinitis. Richness and diversities of airway microbiome for allergens. Then we found a very interesting finding. In children with mild sensitization, has a significant lower richness and diversities of airway microbiome in comparison with children without mild sensitization. But there is no any association with the airway microbiome to the food sensitization. A further study about the richness and diversity for mild sensitized atopic disease. Then we found that in comparison with children without mild sensitization, in children with mild sensitized rhinitis and asthmas, they all had significant lower richness and diversities of airway microbiomes. So we conclude that the airway microbiome may have a moderation response to the mild sensitization and contribute to the rhinitis and asthma as well. So we conclude our finding that airway microbiome diversity is inversely associated with mild sensitized rhinitis and asthma in early childhood. And we published our finding in 2017 in scientific report. So we just know that the host and the environmental factors will will influence the asthma development, include the diet, environment in infancy, and contribute to the development of asthma in pre-childhood children. So we know the environment factor, including the microbiome and allergens, or the host diet. And we just want to know the metabolomism about these factors and their contribution to the asthma development. So the next question that we want to answer is metabolism analysis for the biomarkers of childhood asthma. So we try to collect the samples from the urine of the child because these samples are not invasive and easy to collect in children. And we use a time series of urine metabolites from a birth cohort and use the NMR spectroscope to analyze their metabolism. So we collect the children from age 1 to age 4, and there's around 30 patients in asthma group and 30 patients as healthy controls. So this is the flow chart about the metabolism analysis. So firstly, we collect the sample of the urine and we try to use the NMR analysis to get the metabolism spectrum. And we grouping our finding to asthma, rhinitis, and healthy control, and try to analyze the metabolite that can differential diagnosis from the asthma and healthy control, and try to analyze their pathway, metabolic pathway, to connect to our clinical findings. So this is the metabolites that we identified during this study. So we found a lot of metabolites are significantly associated with the age. It's quite obvious because a lot of food are quite different from age 1 to age 4. For example, they will have milk in age 1, but we will have a soft food at age 4. So the metabolites are quite different according with the age. But we find 4 metabolites were significantly associated with asthma. One is dimethylamide and 1-methylnicotinamide and anatonin and gaunydoacetic acid. So how about this metabolite associated with the mild or food sensitization? Then we found that the gaunydoacetic acid is quite strong associated with the oral sensitization. But the dimethylamide is unique associated with the asthma, and the 1-methylnicotinamide and anatonin are strongly associated with the mild sensitization. So we conclude that urine metabolites is associated with the mild sensitization and may contribute to the asthma development or strongly associated with the asthma. So this is the pathway and the figure to show the 4 metabolites that we identified to be associated with the asthma. So we can see from the gut, the nicotinamide will be digested to 1-methylnicotinamide and get through to the body and metabolite to the urine. And also the anatonin is from the purine and the dimethylamide is from the chlorine. But most important, that we found the gut microbiome play a role to develop the anatonin and dimethylamide in guts. So we found that we conclude that the longitudinal urinary metabolism profiling, we get the metabolites may strongly associate with the asthma development in early childhood. And this result we published in 2018 in Pediatric Allergy and Immunology. So next, we try to answer what's the relationship between the gut microbiome and allergies. So we just use the same protocol, just like the lung microbiome and asthma. It's also the case control study, and use the high-sig Illumina platform And we also collect the children since age 3 to 5 years old. We collect the sample from their stools and also use the 16S RNA amplification for our study. This slide shows the gut bacterial richness and diversity. However, there is no any difference between gut microbiome and mild sensitizations and food sensitization as well. So we found that there is no any difference in gut bacterial richness and diversities among atopic disease and allergen sensitizations. However, we still find some microbiome or significant difference in children with asthma. For example, the Escherichia and Clostridium and the Butylbacterium were significantly higher in children with asthma. And we also collect this metabolites collected with this microbiome were significant difference between asthma and healthy to try to correlate this microbiome to the IgE levels in stool and in blood. Then we find the Clostridium, Bacteria, and Escherichia that we found are significantly associated with asthma was strongly associated with the mild sensitization or total IgE sensitization. So we conclude that gut microbiome dysbiosis is still associated with allergen-specific IgE response in young children with airway allergies. So finally, we're just very, very interested to try to use the multi-omics integration analysis to try to invest the gut metabolomics and the gut microbiomics. So we just identify all the metabolites in the gut samples, the stool samples. Then we found around 40 metabolites in the stool, and we try to classify these all metabolites to 6 classes. So most important is the first classes. They are all amino acid metabolism, and another class is beta-alanine metabolism and butyrate metabolism. These two metabolisms are strongly associated with the bacteria metabolism. So next we try to correlate these all metabolites and all the gut microbiomes together. Then we find a lot of microbiome were strongly associated with the amino acid metabolism. And most of they were negative correlation, just like there is a green signal over here. And another beta-alanine and butyrate metabolism were strongly associated with some gut microbiome as well, with some positive correlation and some negative correlation as well. So this is a very, very interesting finding. So, and most of the bacteria belongs to the Firmicute in Finland. So next we try to identify some metabolites were associated with the rhinitis or the asthma. So we found only one metabolite was significantly associated with the rhinitis. It's called histidine. However, a lot of metabolites are strongly associated with the asthma. For example, the butyrate, beta-alanine, trimethylamine, 4-hydrobutyrate, and fermentate. So we know the butyrate is a very, very interesting metabolite. And then everyone knows about it. It's one of the short-chain fatty acid. So we just try to correlate all these significant metabolites associated with the asthma and correlate the metabolites were associated with the asthma as well. So we correlate the metabolite and the microbiome and the IgE level. We found that the butyrate was strongly associated with the mite sensitization in mite levels. And the Clostridia and Escherichia, the gut microbiomes, which were significant in children with asthma. Then we found there was a strong, significant positive correlation with the beta-alanine as well. So we conclude that the gut microbiome derived butyrate is inversely associated with the IgE response to allergens in childhood asthma. It's a very, very important findings by using the metabolomic basis to evaluate their association with the gut microbiome and the asthma. And we've just published our data in 2019 in pediatric allergy and inflammation. So this is the summary. Firstly, we try to analyze the airway microbiomes. And we found there is a very strong association with the mite sensitization and the asthma. We also try to use the urinary metabolites, and we found that a lot of metabolites were strongly associated with the mite sensitization and the asthma as well. Then we try to find the gut microbiome were associated with these metabolites, and we try to connect the gut microbiome and the mite sensitization, but there is no any correlations or associations. So next, we just try to store metabolites. We found the butyrates were very important metabolites strongly associated with the mite sensitization. And beta-alanine metabolites are associated with some microbiome, for example, Clostridium, Escherichia, which were strongly associated with asthma. Well, it's all my talk, and hope you all enjoy my talk. And I would like to answer all your questions. And thanks again for your listening. Thank you.
We are very enjoying Professor Chu's speech today. Let's open for discussion now. Can I ask one question for Professor Chu?
Sure.
Did you check acetate and propionate in addition to butyrate? Yes. The first question is, did you check acetate or propionate in addition to butyrate?
Okay. This is I'm Jiyoung Chu. Sorry about the noise of my video. I have recorded my video, but may the staff miss it. But anyway, thank you for this question. This is a very nice question because we know there are three important short-chain fatty acids, including the propionate, acetate, and the butyrate, which will have been reported to be associated with the gut microbial derived metabolites. But in our study, we try to identify the metabolite in the guts in the stool, but we didn't find another metabolite like the acetic acid or propionate acid, but we only found the butyrate. So we can't evaluate the importance of the other short-chain fatty acid metabolites and their relationship to the asthma. So we just identify the butyrate, and this butyrate is quite important to the asthma development based on our study. Anyway, thank you. Hope I have answered your question.
Now, in recent update in the allergy and the microbiome and the metabolomic, we know different allergic disease associated with different microbiome and the metabolomic. And even in different allergy or sensitization, like peanut, milk, others, different, they also associate with different microbiome and microbiomic also different allergic sensitization or allergy. And I have one question is, can you explain more about the gut-lung axis? It's influenced by environment factor and it's associated with disease like asthma.
Oh yeah.
How they influence?
Yes, this is a very nice question actually, because we are still struggling on this project. But actually, I have evaluated the association of the gut and the lung microbiome. Actually, they don't have a very exciting correlation between the airway and the gut microbiome, because clinically they are quite different organ for the lung and the gut. So I'm not very surprised about it. I was still struggling on this lung and gut axis for the asthma development, but we didn't get any result about it. So as you said that they are still very interested field and a very important field that we still don't know about it. So we are still try to understand or investigate many field about it. So I sorry about it. I can't answer all your questions right now, but I hope I can answer your question in the coming future. Thank you.
Is there any question?
Okay, thank you,
Okay.
Professor Xu and
Thank you.
Professor
Thank you.
Chiu. I think Professor Chiu, you can see there are still some questions in the chat box. Maybe you can answer the question later.
Okay, no problem.
Okay,
Thank
thank
you.
you. Okay, thank you, Professor Xu. Okay, let's move to the next session. And the next session, I would like to introduce our moderator, who is Professor Wenju Song and Dr. Alfred Tam from Hong Kong. And Dr. Alfred Tam has a video to share with us. Please.
Colleagues, ladies and gentlemen, welcome to this satellite symposium. My name is Alfred Tam from Hong Kong, and this next lecture is going to be delivered by Dr. Liu Chin-Su from Taiwan. And this topic is going to be liver transplantation in infants. Please welcome Dr. Liu.
Good afternoon, ladies and gentlemen. Today, I'm very glad to present my topic, the liver transplantation for small infants. The purpose of this presentation is liver transplantation for small infants, the body weight less than 6 kilograms, or the age under 6 months old is quite rare. Because of the perioperative care improves in recent decades, I think the indication will become common. In Taiwan, the liver transplantation mostly is done by the living donor. The living donor liver transplantation can expand the donor pool and also, therefore, will expand the indication. But because of in the literature, the report of the outcome is unfavorable. So it is still rarely performed in Taiwan for such small children. In this report, we will evaluate the living donor liver transplantation outcome of the patients under 6 kilograms and or the age under 6 months old. The body weight less than 6 kilograms and even the body weight more than 6 kilograms, but the age is under 6 months old. We can see the plot. Actually, the age over 8 months old, the small cavity of the abdomen is still noted because the weight always over the extremity and the face and the head. There are a lot of difficulties of the liver transplantation for such small infants, include small abdominal cavity to accommodate the larger graft, the discrepancy of vascular structure between recipient and the graft. Because of the large graft, so maybe there is a chance of the insufficiency of the portal flow for the graft. And the kids are small and always the condition is not good, so the perioperative care is difficult. Among this kind of the children, so small children, the etiology of liver transplantation needs attention, particularly in acute liver failure case. The recurrence of disease should be considered. The perioperative care is quite difficult, including respiratory care, life support, and vascular access. Pre-operation, the respiratory condition is usually not good because of the consciousness in acute liver failure is not good, and also the coagulation defect, so the pulmonary hemorrhage, and because of the abdominal distension, sometimes will cause the insufficient expansion of lung and other conditions. Even post-operation, because of the graft is not in a very accurate, exact location, so the diaphragm is always compressed by the new liver graft. And also, after operation, the fluid surface shift will cause the diaphragm, cause the lung sweat, and even a lot of pleural effusions. So respiratory care in the perioperative care is very important. And also, in many cases of the small kids living need living donor liver transplantation, had the hemodialysis, and how to perform the hemodialysis is also very important for such small kids. And also, some acute liver failure or have a very severe jaundice where they receive the plasma exchange, and even the vital sign is not stable, need vasopressors. In some cases, has the portal hypertension will cause the bleeding, and of course, the coagulation deficiency will cause the patients in dangerous condition. The vascular access for such small kids, for example, the dialysis catheter or the central line catheter, are difficult to insert and maintain. I retrospectively analyzed our patients since 2004 until 2021 June. We have totally 74 cases for the patients, pediatric patients under 18 years old. The male patients a little more than female patients. The etiologies of the liver transplantation, including BA and the metabolic liver disease, and hepatoblastoma and acute liver failure. And also for rare disease such as the cryptogenic cirrhosis, Buck-Chiari syndrome, primary biliary cirrhosis, hepatocellular carcinoma, RGD syndrome, and the PFIC type 1. The age of our pediatric patients under 6 months old is about 14.9%, and under 1 year old is almost about half. The body weight under 6 kilograms is about 14.9%, and under 10 kilograms is about 1/3. Our follow-up period ranged from 2 months to 7 years. Our data of the patients under 6 kilograms or under 6 months old, there are 13 patients. 11 patients were under 6 kilograms, and the body weight ranges from 3.2 to 5.9 kilograms. 11 patients, the age were under 6 months old, and the age ranges from 25 days old to 5.9 months old. Diagnosis include 5 cases of acute liver failure, 4 cases of biliary atresia, 1 case of protein C deficiency, 1 case of PFIC type 1, and 1 case of ALGD syndrome, and 1 case of the methylmalonic acidemia. Among the 5 cases of acute liver failure, the causes of acute liver failure including 2 cases of the neonatal hemochromatosis, 1 case of herpes simplex virus hepatitis, 1 case of giant cell hepatitis and autoimmune hemolytic anemia, and 1 case of hemophagocytosis. Among the 13 cases, pre-liver transplantation ventilator support was needed, intubation in 5 cases, prone in 3 cases. Post-living donor liver transplantation ventilator support, I always extubated the patients for the patients if the patient's condition is very stable 1 day after liver transplantation. But we have 7 cases need intubation for more than 5 days, and 10 cases need prone for more than 5 days after extubation. The pre-liver transplantation hemodialysis or plasma exchange, we have 4 cases needed, and even 3 cases still need post-living donor liver transplantation hemodialysis for a while. The follow-up period range from 1 to 12 years. This is the demographic data of our patients. There are 13 cases, and the smallest age is 25 days, is a case of the neonatal hemochromatosis, and the smallest body weight is 3.2 kilograms. This is the 4 months female case with acute liver failure, and the diagnosis is hemophagocytosis. There is the case demonstration for our case number 8. This patient is a case of neonatal hemochromatosis and have the liver failure since birth, and he was transferred to our hospital for living donor liver transplantation. And the condition is not very stable. And 4 days before living donor liver transplantation, we can see the X-ray still lung is good, but 3 days before living donor liver transplantation, there was suddenly pulmonary hemorrhage and the need hemodialysis and also need a ventilator support. But the patients conquered this condition, and then we performed the living donor liver transplantation. We can see 2 days after living donor liver transplantation, the patient still need hemodialysis, and the lung is become better, but still have some pleural effusion. So we put the pigtail for drainage the pleural effusion, and the hemodialysis was stopped about 7 days after living donor liver transplantation. This is another case demonstration. The case number 9, the patient was a case of the hemophagocytosis, and the patient is only 3.2 kilograms. And because the patients have the fluid retention and also the pulmonary hemorrhage 4 days before the living donor liver transplantation, so we put the catheter for the fluid management, and the lung become better, and then we perform the living donor liver transplantation. After 2 days of the living donor liver transplantation, the lung is acceptable. But 4 days later, the lung become worse, and 12 days after living donor liver transplantation, the lung looks okay, but the lung fibrosis was noted due to the hemophagocytosis. So the patients received the tracheostomy 3 weeks after living donor liver transplantation. For the case of acute liver failure in pediatric patients, we have to be very careful about the etiology. Around 50% cannot have the definite diagnosis. And the causes of the acute liver failure are very age dependent. From the English literature reviews, the acute liver failure patient can be divided into 3 age groups: less than 90 days old, and 90 days old to 3 years old, and 4 to 17 years old. Some causes of the liver failure, including like the neonatal hemochromatosis, herpes simplex virus infection, galactosemia, only happened in 19 days old. And the Wilson disease causing the acute liver failure only happened more than 3 years old. This is a very important information when we decide to perform the liver transplantation for acute liver failure patients, because we have to consider the strategy of the liver transplantation, and we have to exclude the possibility of the recurrence of the disease. The operated data, all of the 3 patients were living donor liver transplantation. The graft type includes 7 lateral segment, 1 reduced lateral segment, 4 hyper-reduced lateral segment, and 1 S2 monosegment. The graft recipient weight ratio ranged from 2.11 to 5.4%. 3 patients were ABO incompatible case, and all of the patients, we didn't use the rituximab pre-treatment. The bile duct reconstruction, including 11 cases blue-white and 2 cases duct-to-duct. The results, there were 2 mortalities. One died of the intracranial hemorrhage 5 days after leaving donor liver transplantation. The patient actually already became very, very severe coma, and even the operation is still successful, but the patient succumbed due to the ICH. And the other one have the successful living donor liver transplantation, but died of recurrence of disease, hemophagocytosis, 6 months after living donor liver transplantation. There are operative complications, including 1 hepatic vein stenosis, and the patient underwent hepatic vein stent, but died of ICH. There were 3 cases of the bile duct stenosis, and all have the PDCD with good outcome. 1 case of portal vein stenosis, and we performed the portal vein stent with good outcome. And 1 case of the hepatic artery thrombosis, and had the redo microscopic anastomosis of the hepatic artery with good outcome. Among the 11 survivors, 4 cases already totally weaned off the immunosuppression, at least 2 years. And the particular case of the giant cell hepatitis with autoimmune hemolytic anemia, the patient have the successful liver transplantation, but at 2 months after liver transplantation, the disease recurrence, and had 7 courses of rituximab, now complete remission for 21 months. The case of the PFIC1, as the literature suggests, a lot of graft will become severe fatty change. Our case also, after 6 months after liver transplantation, and the liver graft had the severe fatty change, so we performed the complete biodiversion by sterilization of a limb, and then the graft fatty change become much better. Always the graft size always large for this kind of small children, so there are a lot of methods to reduce the graft size. We can see the picture. The C line and the A line is just like a reduced lateral segment. This is the lateral segment. But if you including COA plus the B is the so-called hyper-reduced left lateral segment. This is our case number 8. We perform the hyper-reduced lateral segment. Initially, we separate the lateral segment and preserve the portal vein, hepatic artery, and hepatic vein. And then we cut the lateral segment, the lateral side, like this. And then we cut the median side. There is another kind of anterior side is the monosegment, S2 so monosegment. It's looking like S3 monosegment. S3 segment always very thick. So if the abdominal cavity is shallow, so some case need to resect segment 3, and we always preserve the portal vein and hepatic artery, but we dissect the round ligament to isolate the portal vein 3 to S3, and then demarcation the S3, and then resect the S3. This our case number 6 is also. This case was also a neonatal hemochromatosis causing acute liver failure. And when we dissect the lateral segment, and then we dissect the round ligament to isolate the portal vein to the segment 3, and then we can see the demarcation of the S3 here. And we resect the S3, and also we resect the lateral segment, the lateral side, and then we put the graft into the abdominal cavity for anastomosis. But even this, we doing this, the case cannot close the abdomen after living donor liver transplantation. So we use the plastic bag to cover the graft. And 2 days after liver transplantation, we close the abdomen smaller. And the postoperative day 8, we completely close the abdomen. And the patient's extubation 13 days post-liver transplantation. For this kind of case, we always use the 3D printing technique to simulate the real. So what is the graft we used? Hyper-reduced lateral segment or reduced lateral segment or monosegment? There are some principles. The first is the GRWR. Less than 4% is better. And the graft thickness should be considered. So we can compare the preoperative image, the donor lateral segment thickness, and the abdominal thickness. So for this case, we use the S2 monosegment, but for this case, the thickness of the lateral segment and the abdominal cavity is almost the same. So we use the hyper-reducement. So discussion and conclusion. Liver transplantation for small babies with body weight less than 6 kilograms or age under 6 months old without large amount of ascites is very difficult. A multidisciplinary team, including neonatal critical care, is very important for success. Monosegment or hyper-reduced lateral segment should be considered not only for graft weight and size discrepancy of vessel, but also for graft thickness. Acute liver cases in small children should be very careful of recurrence. So ladies and gentlemen, the conclusion of this presentation is, although living donor liver transplantation is difficult to perform for small infants, outcomes are still favorable and mainly dependent on underlying causes in addition to technical innovation. Preoperative reconstructive image for estimating graft thickness is necessary for surgical planning. Thank you for your
Thank you. Thank you for Professor Yunsu Liu. Is any question from the chat box? Okay, I have one question. In case of the hemophagocytosis, the case, all we know the hemophagocytosis is a systemic disease due to the liver transplant. It's during the acute phase or when during the recovery phase, the infant finally expired. Can you answer?
Yes. Can you listen to me now? Can I?
Yes.
Okay.
Clear.
Actually, this case is a very controversial case, and the patient was diagnosed as a hemophagocytosis, and also at the same time with the acute liver failure. So we retrospectively to review some papers, and the papers recommended that you can perform the liver transplantation to save the baby's life now, but the condition still need the further chemotherapy and even the bone marrow transplant, stem cell transplant like that. But I at that time I actually, because the case is very difficult, very small, only 3.2 kilogram, and condition is very bad. So, but I asked the mother, but the mother very insist. So our planning is after liver transplantation, we will still have to encounter a very difficult post-operative treatment. And unfortunately, the patient finally died because of the no response for the chemotherapy. And even we applied for the bone marrow transplant, but was refused by the government. So the patient finally died. So, yes, is my answer.
Okay, the other question is on your case, 11 case, why you include the body weight less than 6 kilogram instead of why you chose why don't you choose the 5 kilogram instead of 6 kilogram?
Yeah. Actually, because in the literature always mention about the successful rate of the body weight, and almost all the literature separate the 10 kilogram about 10 years ago, and now we see the 10 kilogram is not so difficult, and other literatures always mention about the 6 kilogram, above or under 6 kilogram. Actually, Professor Song, even 500 gram or 1 kilogram is very important for such kind of case. Smaller will become much difficult. So why I not choose the 5 kilogram. Actually, most of the English literature choose the 6 kilogram. But now almost the literature say the above 6 kilogram is not so difficult, but under 6 kilograms still very difficult. So that's the reason why I choose under 6 kilogram. But why I still choose some people, some patient under 6 months old, because 6 months old also very rare case. We can imagine how many cases under 6 months old need liver transplant. Of course, some very difficult case, some strange case, and even they are over 6 kilogram, but the age under 6 months old, the abdominal cavity is still very small, because the weight always on the extremity or the not abdominal cavity. So I always also choose the other two case under 6 months old into this series of the cases. Thank you.
The other question is, you have one case through the tracheostomy 2 weeks after the operation. Why so early through the tracheostomy?
Yes. Yeah. This case is also the same. Is the case of the hemophagocytosis. Yeah, the same case, because the case of the lung fibrosis after liver transplantation. So we performed the tracheostomy, and then we received the chemotherapy. Yes, the same case, but the patient died 6 months after operation.
Thank you. A very successful operation record. And I know you are very wonderful, very well-known transplantation surgery director in your hospital. And just question, you are originally the director of the pediatric surgery division, why you transfer to the transplantation team.
Yeah.
Experience in pediatric surgery is good for your transplantation procedure.
Yes, Professor Song. Actually, we are very familiar with each other. Yeah, I also perform a lot of pediatric surgery, like tracheal surgery.
Yeah, but pediatric surgery actually, I think that there is a character of the pediatric surgeon. Our technique is more delicate, I think, but the liver anatomy actually not so familiar with the hepatic surgeon in adults. So when I try to learn the living donor liver transplantation in Japan, and then I think the pediatric surgery still can perform the liver transplantation very well. And yeah, so I think I am the former director of the pediatric surgery, but because I perform the liver transplantation, including adults, and the results are also very good. So our hospital want me to become the director of the transplantation surgery. Yeah, last year, because the former transplantation surgery director retired last year. Yeah, so I think the pediatric surgery still have some advantage when perform the living donor liver transplantation, because our technique is more difficult, more dedicated. Yeah, thank you.
I know you are very capability of the in surgical field, especially in pediatrics. Do you have any comment about your
Okay.
your report?
Hello. Yeah, because time is up.
Okay. Okay.
Yeah.
Thank you. Thank you again.
Thank you.
Okay. Thank you.
Yeah.
Thank you.
Mhm.
Thank you.
Thank you. Thank you, Professor Liu and Professor
Thank
Song. Okay, let's move to the next session. And the next session, I would like to welcome our moderator, Dr. Jianhen Lin. Dr. Lin, please.
Hi, everybody. It's my great honor to introduce Dr. Peijun Zhang. And Dr. Peijun Zhang is presently the Deputy Director of the Division of Chronic Infectious Disease, CDC Taiwan. She also serves as Association Director at the Tuberculosis Research Center, CDC Taiwan. Her other positions include Standing Committee of Taiwan Guidelines for TB diagnosis and treatment. She has more than 15 years of experience on policy implementation for TB control. Important operational research papers has been published to provide the effectiveness of policy implementation. Her main research interests are tuberculosis, infection control, vaccination, access, and infection disease. And now let's enjoy her wonderful topic, Integrated Prevention Program for Childhood TB. And please start, Dr. Zhang.
It's my honor to have the chance to share with you the National TB program in Taiwan. Through this experience sharing, we would like to let you know that how the integrated program can do to prevent children TB. Since you stay here until the last program, I hope at the end of the APPS TPPCC, this talk will be as fruitful as you anticipate. This is the disclaimer that the view expressed in this talk are independent from my job. First, before this talk, I would like to give the audience a brief introduction of Taiwan. Taiwan is a small island with a total area of 36,000 square kilometers, and population around 23 million people. Therefore, Taiwan ranks second globally as one of the countries with high population density. The medical care system here is pretty simple. With the single-payer system, the National Health Insurance Agency, NHIA, covers 99% of the inhabitants in this country. There are around 400 hospitals and 22,000 clinics to provide medical care. The size of population makes Taiwan an excellent country to do operational research, and it's very famous for tourism. Hopefully, one day you will come to Taiwan for a short visit. This is my outline for today. First case is an 11-month-old boy. He had intermittent fever and cough for 4 days. Seizure attack with drowsy consciousness brought him to the ER. This is the physical examination record. Portable chest X-ray revealed right lung haziness, and no bowel perforation was noted. Laboratory revealed that lymphocytosis and CSF revealed lymphocyte dominate with glucose low, and protein high. Brain MRI revealed bunting angle. TB meningitis is impressed, and the treatment of anti-TB3 combination was prescribed and VP shunt was performed. Gastric juice and CSF for acifestan and Mycobacterial tuberculosis were sent. Also, urine, blood, and sputum bacterial culture, viral culture, and stool bacterial culture also performed. With detailed past history, it identified one of his uncle had pulmonary TB 3 years ago without regular treatment at that time. He currently lives with another uncle who also had pulmonary TB under regular medication. They lived in Aboriginal townships. 2 episodes of seizure attacks actually noted 2 months ago, and febrile convulsion were diagnosed. The boy also had intermittent low-grade fever and cough more than 1 month. 3 weeks later, gastric juice and CSF culture for mycobacteria revealed positive results and sensitive to all the first-line anti-TB drugs. All the viral workup and bacterial workup were negative. After 1 month, the VP shunt yielded Enterobacter cloaca. For the nosocomial infection, VP shunt was removed. Chest X-ray revealed resolution of the right upper lung gradually and slowly. Contrast CT revealed that the calcification lesion found in mediastinal lymphadenopathy and also perihilar lymph node. The upper lung lesion also revealed calcified lesions, which is a typical Ghosn complex primary TB lesion for children, and become better after anti-TB regimens. The second case is a 12-year-old girl whose mother is a case of smear-negative, culture-positive pulmonary TB. Her grandfather also has TB 10 years ago. She was brought for contact examination. The tuberculin skin test was 12 mm. However, the left upper lung revealed some scar. She was asked for follow-up 1 year later, and no LTBI treatment was provided. This chest X-ray taken for other reason 4 years ago revealed the same situation of left upper lung. After 5 months, she had an episode of hemoptysis, and at that time, chest X-ray revealed left upper lung infiltration with typical adult type pulmonary TB. Sputum acifestan already positive. Mycobacterial culture positive for 3 sets of sputum. Treatment started with 4 combination. The result was good. However, when we saw TB patients, we may not know they have TB exposure history. But if you know somebody with TB exposure history, you have to think about providing latent TB infection diagnosis and treatment. Let's take a look of TB epidemiology in Taiwan. In Asia A region, majority of the countries still suffer from high TB incidence. NTB goal is incidence less than 10 per 100,000 by year 2035. That's the incidence currently in UK, the US, and Australia. In year 2019, the incidence of South Korea, China, and Singapore was 59, 58, and 41. The incidence of Japan was 13, and Taiwan was 37. Majority of the countries has also suffered from high burden of LTBI2, which is latent TB infection. Up to 1/4 of the population here are latent TB infection already. The incidence declined from 73 to 33 during 2005 to 2020 in Taiwan, and the most striking thing is that the active TB patients are now less than 8,000 a year. Geographically, south and eastern part of Taiwan used to have higher incidence compared to the national incidence. As time goes by, only 2 counties still has incidence higher than 50, which is Hualien and Pingtung County, the most beautiful places in Taiwan, where you can see the mountain and seashore at the same time. This could be the only slide related to childhood epidemiology. The incidence of TB less than 10-year-old now is less than 1 per 100,000 in 2020. As the textbook saying, the incidence is lowest among the 5 to 9-year-old, and it's an U-shape for those aged younger than 15-year-old. Incidence increased sharply after adolescence and increased thereafter. In Taiwan, for those who are younger than 35, the NTB goal has been met. In 2020, the incidence of those aged 65 and older currently still exceeding 100 per 100,000, which is the same situation as the situation of the living in Aboriginal townships in Taiwan. Both of them declined very rapidly in the past 15 years under TB program. In short, more than 60% of our TB patients in Taiwan are over 65-year-old. And Taiwan is a country with aging problem, which is a challenge as Taiwan is one of the lowest birth rate in the world. TB patients diagnosed among new immigrants increased 100% from Asia regions during 2006 to 2013 and stayed stable for almost a decade, reflected that the TB control improved in the countries where our new immigrants coming from, which is a good sign for the improvement for TB control in this region. Taiwan involves and provide our experience and skillful training to improve this situation in the past 5 years. We need to understand infectious disease has no border, only love and collaboration can make it better. The slide shows TB and HIV comorbidity surveillance. Taiwan had 33,000 people living with HIV. So actually HIV co-infection with TB is not a serious problem here. However, we still found 2.6% of TB patient aged 15 to 49 had HIV positive. And when we compare the people living with HIV's TB rate to general population's TB rate, you found that people living with HIV has an overall TB incidence of 200 per 100,000. So in different age group, you found that some of the age group you may have 20 times of people living with HIV's TB rate compared to general population. As to the surveillance of drug-resistant TB, in Taiwan, drug susceptibility test, mainly based on agar proportional method, is provided to everybody. So it is good for clinical individual regimen adjustment. Molecular diagnosis such as gene ASPR or Hunt-test genotype for drug-resistant TB are used for high-risk groups for drug resistance, such as retreated patients, foreigners, failed regimens asking for fluocinolone use. The result can also help clinical judgment, but should be very cautious in Taiwan because false positive due to prevalence of drug resistance for rifampin is too low. So utilize the molecular rapid diagnosis for childhood TB. It's good to take the advantage of rapid turnaround time and diagnosis for Mycobacterial tuberculosis, but not very good for rifampin-resistant result in Taiwan. So if you want to use molecular diagnosis, especially ASPR, you need to understand the background prevalence of drug resistance. In Taiwan, the new patient has 1% of multi-drug resistant prevalence, which is kind of low, but if the patient is previously treated, then up to 3% will be MDR-TB. And for the most prevalent use LTBI treatment regimen, isoniazid, for new patient, it's 7% in year 2020. Back into 2005, INA resistant in Taiwan in new patient actually is 10%. So after navigation of the epidemiology in Taiwan, let's move into the our 4 strategies to prevention for childhood TB. Taiwan CDC is the main body for national TB system. We had 6 regional offices to overlook the 22 counties and cities in Taiwan. Each county and city have its own local health bureaus for TB registry from healthcare facilities. Healthcare facilities has TB case manager. She can help to communicate between medical care and the public health service. For public health centers, once they receive the healthcare facility registry for a new patient, they started to do case management, provide dots, and also they are responsible for BCG and contact tracing. Here is how the collaboration between universal health coverage and TB. The slide shows the relationship between medical care system and TB control system. As I mentioned earlier, doctor in the hospital diagnoses patient and report it to health authority. And we have the information system to collect and monitor the data of each case. The medical expense is paid mainly by the National Health Insurance. In order to remove the barrier of accessibility to medical care, Taiwan CDC covers co-payment and the isolation fee. For those uninsured, it is also Taiwan CDC pay. Taiwan CDC has a special project to pay for the MDR-TB treatment other than drug-sensitive TB. In summary, the TB medical care system is a decentralized system. Any physician can treat TB patient in Taiwan. However, the drug-resistant TB medical care is centralized. For reaching high successful treatment rate, the NHI system set up a payment for performance, which called P4P. In the public health side, we provide DOT strategy. When a TB case finished 6 months treatment, the hospital and clinics will get extra $100 case management fee by National Health Insurance. Prevention strategy is BCG. Taiwan has high infant BCG vaccination coverage like all the other countries in this region. However, we shifted the BCG schedule from 24 hours of old to the 5 months old after 2016. Why we shifted the BCG vaccination strategy? Because with the TB incidence decline, the TB meningitis and military tuberculosis become very rare. And we, under the very detailed surveillance of BCG osteomyelitis, we found that in cohort between 2003 to 2015, the meningitis rate compared to BCG osteomyelitis, the ratio is 1 to 5. Which we think it's too, the BCG harm is too high. So we shifted the vaccination schedule to 5 months of age in 2016. During this time of BCG policy shifting, we provided tons of education material for both parents and physicians. We asked them to do conservative management of local abscess and lymphadenitis, and majority of the BCG harm will resolve by themselves beyond 1 year old. Let's move into the fourth part. The fourth strategy is contact tracing and latent TB treatment. The above-mentioned operation research for context published in 2011 was in International Journal of Tuberculosis and Lung Disease. You would like to identify who has higher risk to progress to active TB in children, and this is the paper we published in American Journal of Respiratory and Critical Care Medicine. We developed a new scoring system for childhood context progress to active TB. We used the multivariate cost proportional hazard model to calculate the relative risk among childhood contacts with different risk factors. And you can see that for those with TST larger than 20 millimeter, they will have 31 times of active TB in the future compared to those with TST smaller than 10 millimeter. So in Taiwan, we use 10 millimeter as a cutoff point for childhood TB initially. And if the child had 22 millimeter, then they will have a risk score of 4. It also related to smear status of index patients and whether the family come from high incidence area or the gender of the index patient. If the index patient is a mother or grandmother or aunt, the caregiver will have higher transmission for the child. And this is the illustration how we try to explain to parents that if you have a scores up to 7, then almost 100% the child will develop TB disease in the future. And we developed the risk score app for the childhood TB when we still use tuberculin skin test for context. This is how we did before a child. We provided the TST, and then we calculated the risk score in the app. And physicians or healthcare providers will have the educational material and show the family. So after the contact investigation implemented in Taiwan since 2007, the contact investigation identified contacts increased from 2 contacts per TB case in 2006 to 13 contacts per case since 2018. Taiwan CDC had set up the contact investigation guideline and ran the training course each year for skill improvement for public health nurses. So after contact investigation, we push family to do contact examination. Before 2021, we only provide IGRA test for 5 years and up. And since the 4th quarter of this year, we will start to expand it IGRA to 2-year-old. For achieving the goal of NTB by 2035, besides strengthening the strategies of patient-centered care, Taiwan started LTBI treatment very early and very aggressively since 2008. As a pediatrician, I just want to point out that if a country with good TB control for adult TB and also try to put some effort to do LTBI treatment for every context, then it will be the best strategy to protect children from childhood TB. So with the advance of drug of choice and the easier way for adults, the number of LTBI patients increased slowly. The LTBI treatment stably increased from 6,000 in 2016 to over 10,000 in 2019. In year 2018, a total of 9,180 new TB cases were reported. And for the first time, the total number of LTBI treatment exceeded the number of new TB patients per year. Encountered the so-called the Golden Cross for LTBI to TB. National TB program shares our epidemiology data, no matter trend, context, LTBI treatment, DRTB information with each county and city level. That's how we engage our local government and our hospitals together with us for TB control. At this end, I hope I've given you a clear overall picture about the past and present condition of how Taiwan do prevention of childhood TB. In the future, Taiwan will continue to improve our defense against TB and be part of the global effort to fight TB. Thank you very much. And if you have question, you may raise the question. And if you have the question in the future, please contact with me through the email.
Dr. Lin, we can hear you. Please turn on your microphone.
And hi, thanks for Dr. Jan's wonderful speech. And I see a question from chat box, and Dr. Jan already replied his question. And any question from other audience? So I have a question for Dr. Jan. And in your talk, the TB instance is higher in migrants. And do the CDC have more special policy or strategy to prevent the tuberculosis transmission on this group?
Currently, we have chest X-ray examination routinely for especially migrant workers. Maybe since next year, provided LTBI diagnosis foreigner spouse. They spend more time with our kids, but maybe by 2015, large scale LTBI diagnosis. But right now, it's still very difficult to ask, but they come to Taiwan to.
Okay, and thanks for your answer. Because the time is limited, and so we should close this section. And thanks, Dr. James, wonderful speech. And thank you very much. Thank you.
Okay, thank you, and thank you, Dr. Zhang and Dr. Lin, and thank you for being together with us for the whole day program. Before we move to the next session, which is a award ceremony, I would like to invite all of our attendees to turn on your camera to join us and celebrate with us. And please turn on your camera. And I would like to also to announce that for our attendees who has already registered, and all of our program, including the planning lecture, e-poster will be saved on our website for 3 months. So you can access it without any limitation, days and nights until December 17th. And now I would like to invite our chairman of the TPPCC, Taiwan Society of Pediatric Pulmonology and Critical Care, Professor Ke Huan Lü, to host our award ceremony. Professor Lü, thank you.
Good evening, ladies and gentlemen. We will have an award ceremony. It's very exciting time to announce the winners of the 3 parts of award, including Young Investigator Award, Poster Award, and Best Contributor Countries and Hospital Award. Before announce the winners, I will thank all our reviewers. They look through very carefully over 100 papers and discuss together and finally select the best winners. And I will also thank all submit papers authors in from the different country in the world. Let's proceed to award ceremony. First, I will announce the best original research young investigator award. First winner is Xin Gu from the Chang'an Memorial Hospital at Linkou, Taiwan. Win $500. Congratulations. The second winner is Yijin Li from the Kaohsiung Medical University Hospital, Taiwan. Win $300. Congratulations. That's two winners for third. One is Oiman Yuan from the Prince of Wales Hospital, the Chinese University of Hong Kong, Staten, Hong Kong. Another one is Nitin Sochek from All India Institute of Medical Science, New Delhi, India. Each win $200. Congratulations. Two winners were worse. One is Lian Cai from the Kaohsiung Chang'an Memorial Hospital, Taiwan. And another one is Hoiman Yong from the Prince of Wales Hospital, the Chinese University of Hong Kong, Staten, Hong Kong. It win $150. Congratulations. And next, I will announce the Best Clinical Test Report Award. The first winner is Yin Xian from Taipei Veteran General Hospital, Taiwan. Win $300. Congratulations. The second winner is Ji Wei Lin from the Taipei Veteran General Hospital, Taiwan. Win $250. Congratulations. The third winner is Wei Yu Chen from the Taipei Veteran General Hospital, Taiwan. Win $150. Congratulations. Two winners for fourth. One is Ji Yong Li from the National Taiwan University Children's Hospital, Taiwan. And another one is the Nanyong Zhang from the National Taiwan University Hospital, Taiwan. Each win $100. Congratulations. And next, I will announce the Best Paper Presentation Award. First winner is Marisa Aditya Nadi from the Department of Pediatric and Children Health Faculty of Medicine, University, Indonesia. Dr. Sipto Megan Kusumo General Hospital, Jakarta, Indonesia. Win. Congratulations. The second winner is Taiping Fang from the Department of Pediatric School of Medicine, College of Medicine, Taipei Medical University. Congratulations. The third winner is Jin Tech Team from the Department of Pediatric College of Medicine, the Catholic University, Korea, Seoul, from the South Korea. Congratulations. The fourth winner is Yixin Fan from the Zhongshan Medical University Hospital, Taiwan. Congratulations. The fifth winner is Yijin Cai from the Department of Pediatrics, Zhanghua Christian Children's Hospital, Taiwan. Congratulations. Next, I will announce the Best Contributor Award. The first winner, the best contributor divided to categories, country and hospital. The best contributor, hospital, country, Taiwan, thank you. The next is Hong Kong, thank you. India, thank you. Thailand, thank you. The next is the best contributor hospital. Taipei General Veteran Hospital, Taiwan, thank you. China Medical University Children's Hospital, Taiwan, thank you. Next, Kaohsiung Medical University Hospital, Taiwan, thank you. National Taiwan University Children's Hospital, Taiwan, thank you. Zhongshan Medical University Hospital, Taiwan, thank you. Kaohsiung Hanggang Memorial Hospital, Taiwan, thank you. Mackay Children's Hospital, Taiwan, thank you. National Changong University Hospital, Taiwan, thank you. I will thank again all our Young Congress reviewer. Thank you. Yes, once again, congratulations all winner of the original research with the warmest applause. Once again, congratulations the winner, all the winner of clinical case report with the warmest applause. Thank you.
Okay, in this moment, we have a special session in memory of Professor Kim Sen Wang. Professor Kim Sen Wang is the pioneer of pediatric pulmonologists in Taiwan, and however, he passed away peacefully this year at the age of 68. So we have a video to share with you. Please start.
Now is the time to remember Professor Kim Sen Wang. Professor Wang is a pioneer of pediatric pulmonology in Taiwan, and he is also dedicated pediatrician and retired professor of Chang'an Memorial Hospital and Chang'an University. He is a founding member of Taiwan Society of Pediatric Pulmonology and Critical Care Medicine, and he has served as a council member and supervisor of the TPPCC for many years. And he also served as editor-in-chief of TPPCC journal. He passed away peacefully at the age of 68 on July 6, 2020. It's true that so-called dying young and lost talent for the society. I acknowledge his great contribution in the field of pediatric pulmonology, and may he rest in peace.
Hello. Okay, and at the last but not the least, I would like to invite our chairman of APPS 2021, Professor Ren Gongdai, to host the farewell ceremony. Please, Professor Dai.
Dear ladies and gentlemen, let's move to the farewell ceremony. Please. Slide, please. Slide, please.
Yes, please wait a second. See the slide?
Yeah, slide please. Okay. I will thank the most excellent team. They are organizing committee. Slide please. There are many excellent people to help the setting of the meeting. Slide please. This is the scientific program committee. Slide please. Slide please. We are very proud to be supported by Taiwan Ministry of Science and Technology, Ministry of Foreign Affairs Taiwan, and the Ministry of Health and Welfare, Bureau of Foreign Trade. Slide please. The executive co-organizers are the Institute of the Emergency and Critical Care Medicine, School of Medicine, National Yangming Jiaotong University, Kaohsiung Medical University Hospital, Hangul Memory Hospital, Linkou Branch, Dongshan Medical University Hospital. Please. We also thank the financial support from the diamond sponsors, golden sponsors, and other sponsors, and strongly supported by Siquan Fangu VIS Lipeng Company. Slide, please. Totally, there are 846 registered and 400 people from Taiwan, 434 from international countries. Slide, please. I will in brief introduce the Kaohsiung City. Kaohsiung City is located in the south of Taiwan and was recognized as an important place in medical history. In 1865, Dr. James Maxwell for missionary medicine from Edinburgh, UK to Kaohsiung started the beginning of the modern medicine in Taiwan. Slide, please. Totally, there are 91 faculty. Slide, please. From 136 scientific papers submitted, 102 were accepted, including the 11 for young investigator contribution and the 91 in poster. I will say thank you to my dear colleagues in Taiwan for this kind of participation. Many thanks. Slide, please. This is a very important thing. On behalf of the society, I will sincerely announce that the best award is presented to Professor Andrew Collins of the United States. It's named as the Best International Contribution Award and the Honorary Fellow of TPPCC. Firstly, I would like to invite one of the students in Taiwan, Professor Frank Lu, in National Taiwan University Hospital, to introduce Professor Andrew Collins. Frank, please.
Dear Professor Andrew Collin and the President Ke Huanlu, Professor Zheng Gongdai, ladies and gentlemen, I think today we gather together here as the APPS and TPPCC 2021 Joint Congress. At this moment, on behalf of the Taiwan Society of Pediatric Pulmonology and Critical Care Medicine, which is one of the Asian pediatric pulmonology societies, we want to devote our deepest gratitude towards Professor Andrew Collin. And Professor Andrew Collin, you not only made major contributions to the development of the pediatric pulmonology academic and clinical profession across the world, you also have cultivated and nurtured a group of pediatric pulmonology professionals and opened up and expanded the branches and leaves of this profession at many places across the world. Among them, Taiwan is also within it as an important area developing pediatric pulmonology. Professor Andrew Collin, you have trained fellows such as Professor Rengo Dai and also me, and you visit Taiwan twice. So traveling throughout many places and areas in Taiwan, you give us great sharings of the pediatric pulmonology knowledge and expertise, and provided great encouragement and inspiration for all our professionals here in Taiwan. We are your all dear friends. This has also extended all the way to the international conferences and professional stages. Professor Andrew Collin has always encouraged and supported Taiwan's participation and attendance in the international medical field, especially like CIPP. And this empowers not only Taiwan, but also many places across the world that gave the pediatric pulmonology societies a great support for building a global community to serve the children across the world, including Taiwan. Let us applaud and thank you, Professor Andrew Collin, for this great achievement and contribution to us. Thank you.
Thank you.
Slide, please. There will be a medal trophy sent to the Professor Andrew Collin. This is written as in recognition of the seminal contributions to research and education in the field of the pediatric pulmonology in Taiwan. I would invite the present TPPCC President Ko-Hwan Lee to give the honor and take a picture together with Andrew Collin.
Wow.
And Andrew, could you please say something to us, please?
Thank you, esteemed colleagues from Taiwan and Asia, for bestowing on me these precious and unique honors. I am really moved. These are important when coming from my peers, validating my lifetime work, and particularly close to my heart since they originate from my past fellows. Teaching and fellowships of this profession have been the essence of my career in pediatrics and pediatric pulmonology. So thank you, my friends. It is poignant and maybe symbolic that yesterday was born my second grandchild to my son in New York City, because it is like your own children. What remains after you are the generations of people who you had as fellows. Those are your students, but often become your friends and assistants along long stretches of your life, for many years after your direct interactions. During my years in Boston, I made a central point to invite observers in formal and semi-formal fellowships, pulmonologists from around the world, many from Asia, and my two Taiwanese fellows and friends in these meetings are Professor Zeng Kong Dai and Frank Lei Lu. Thank you, Frank, for your lovely words. And I cannot tell you how proud I am of their professional achievements and world prominence. I'm also aware of many others who are here from Thailand, Philippines, Hong Kong, and others with whom I share honorary fellowships in their respective national societies, since I made it part of my professional effort to assist in starting fellowships and teaching in Asia, a huge continent with huge untapped resources and many people who can use our services has become amply obvious from all that we have discussed here for the last 2 days. My journey to Taiwan goes back almost 20 years, and I started to meet many of you for the first time in 2002, and see here many who were my hosts and became respected friends and colleagues. And with apologies to all the ones whose names I will not be able to mention, I will only remind myself of Professor Tzu Fuye, who established this society, and Professor Jun Ren Wu, who was my first host in Kaohsiung, and I'm still wearing proudly the tie that I received at that university. I'm pained to hear of the passing of the magnificent Professor Kim Seung-won, who passed much too young. I came again to Taiwan after that and toured your beautiful country, which will become even more special after these awards. I was supposed to be here in person. I was going back to visit Sun Moon Lake and the beautiful shores of Taitung, but COVID-19 needs to be defeated first, a task which many of us play a central role in. So, my friends, I wish all of you and all of us around Asia and the globe that we come out unscathed, stronger, and wiser. I wish you all, my friends, the best of health and success in your careers and personal lives. And thank you again for this magnificent award.
Thank you. Slide, please. Slide, please. Oh, no, it's this early morning, I asked Andrew to take the full moon photo from the New York because I want to compare the difference between Taiwan and New York. I just say it's the same. It means the size of the full moon is similar to Taiwan and the Asia. And we also can understand we are close anywhere and any time because we have the same full moon. Therefore, may I invite all of the colleagues to take picture together with Professor Andrew Collins. Please open your camera, please.
I'm sorry. Can you say this again? I missed what you said.
Can we take a picture with Andrew Collins together? Okay, take a picture.
Okay, countdown. 3, 2, 1. Smile. Thank you. We do it again. 3, 2, 1. Smile. Thank you. That's all.
Slide, please. The day after tomorrow will be Chinese and Mid-Autumn Festival. There is a phrase, 中秋月圆人团圆. It means the full moon brings family members to get together. We further hope to bring us as a big APPS family together forever. Slide, please. So I want to say, see you next year in Manila. After introduction video finish, I would like to invite all of you to take a picture for complete ending. Please start the video, please.
We are very sure that you will have a wonderful experience in APPS Congress 2021. Thank you.
Best wishes. Take care and good luck. And we will see you next year. Bye bye.
好，
跟有关。
I want to say this ending，我没有办法接啊。好。他没有帮你，但没有办法接。
Thank you for participating in this great meeting. See you next year.
我没有办法进去啊。
Thank you all. I think this is the end of today's second day meeting, which is we thank you all for all the participants from national.
这个没有点开。我刚才听到你3分钟。
Yeah.
Yeah.
Yeah. Thank you for joining us
Thank you.
today, and see you next year. Bye bye. Thank you. Bye bye.
Thank you. Thank you for the conference and all the experts from everybody across the world. Bye.
Bye bye. See you
Bye
next
bye.
year.
Bye.
Bye bye.